Then we'll start. Hello.
We are live, sir.
Okay. Good afternoon, everyone. It's my proud privilege on behalf of TMRE ASD DIPSI 10th International Symposium to welcome you all to the second day of our virtual program. As you know, that vision of CMRE has been to promote continued medical education, impart training and upgradation of knowledge and skills to various medical as well as paramedical and allied healthcare providers. And in an effort and in pursuance of that, we have been organizing these international symposia year after year. Today, it happens to be the 10th symposia, which we are organizing in partnership with DST and Diabetes in Pregnancy Study India Group. And it gives me immense pleasure that we had registered close to 5,500 national as well as international delegates for the virtual conference. We had close to 2,000 plus logins yesterday also. The yesterday program went till almost 9:15 and it ended with the keynote lecture by Dr. Adi Mehta. Today also we'll be closing by 9 o'clock with a keynote address by Professor Dandona, who will be starting at 8:15. So we have both the halls parallel running, and I can promise you it's a very dense, of course, and very excellently woven scientific program. Here not only we have the international faculties like Professor Inash Sheltau, Professor Amar Gamila, Professor Mohammad Hasnain, Professor Colin is with us. Dr. Kalhan from UK made his presentation yesterday. Dr. Dondana is going to talk about his session today. Dr. Adi Mehta did a wonderful session yesterday, and Professor Devjit Tripathi will also be joining. On the national scenario, again, we have top national faculties. Just to name few, Professor Madhu is there, Professor Tripathi will be joining shortly, and Professor Vijay Vishwanathan, Professor Mohan, Professor Shashank, and Dr. V. Kumar, Dr. Bansi, Professor Sheshai, Professor Balaji, just to name few celebrities those who are going to join us on virtual mode today, starting at 1:30 p.m. So it gives me once again immense pleasure to welcome you all to this virtual program, which we are starting just now, and it is going to continue till 9 p.m. both halls parallel. We have two halls, and both the halls you have separate themes and separate programs. JS Bajaj Hall and MMS Ahuja Hall. So I now invite my co-chair, Dr. Meena Chabda, a very close friend, our colleague. We are working together for last 20 years. She has been immediate past chair for RSSDI Delhi chapter. She's also chair for IPF, that is Indian Physician Forum, a national and international forum. She has been very, very actively involved not only in RSSD activities since 90s early days, since 1991 almost, we have been together, and she has been working for the cause of type 1 diabetes patient to great extent. One of her efforts have been appreciated by ISPAD also, and I was told that along with Dr. Anju Varmani, they recently won some international award also, which has been an appreciation of her work into the field of type 1 diabetes. So over to you, Dr. Meena, to run the session. And before we have others faculties joining, I'd like to introduce Professor S.V. Madhu. May I have his CV? Yeah. Although I don't need to remember Professor Madhu again, he has been a mentor to us almost since 94, 95. We have been working together. He is Director Professor, Department of Endocrinology, Center for Diabetes, Endocrinology and Metabolism, University College of Medical Sciences, GTB, a state-of-art center in this city. Has been past president, Endocrine Society of India. He has been past president, Research Society for Study of Diabetes in India, past president, Diabetes in Pregnancy, Study India Group, just past editor-in-chief, IJGDC, and currently serving as editor-in-chief, IGM. He has more than 250 publications to his credit in all national and internationally accredited journals, index PubMed journals, and he has been actively involved in endocrine research and care for more than 35 years. To me, he has always been like an elder brother, hand holding my hand throughout in this journey of RSSDI and in field of diabetology. Over to you, Professor Madhu, to give your clinical pulse. How this session actually we have planned like that it is a professor teaching to all the delegates, especially junior students or DNBs and postgraduates. So I'll request that you handle the session in that spirit. Professor Madhu, please.
Thank you, Dr. Chawla and Dr. Meena Chabra, the co-chair. And I thank Dr. Chawla for inviting me and considering me worthy enough to address the graduates and give them some teaching. It will be a very simple, straightforward session, so don't you worry on that. So let me share my screen. Okay, can you see my screen now? Okay.
It's slide mode. You may continue, sir.
Okay. So this is a session on individualizing glycemic goals, choosing the drugs in a patient-centric approach. The topic is straightforward. We are straight away will be moving on to the topic and how we choose. And for the undergraduates and the students who are willing to learn from this, it's a simple approach, which was basically constructed by the Research Society for Study of Diabetes in India, in how to deal with glycemic management in Indian patients particularly. And I'll be mainly elaborating these guidelines only for your benefit. The glycemic goals, to start off straight away, as per the RSSDI guidelines, and this is the same as it was earlier in 2022 as well. These are the modest targets that we believe in, and therefore we say HbA1c of less than 7, a fasting blood glucose of less than 115 milligram per deciliter, and a PP of less than 160 milligram per deciliter, more or less what the IDF suggests. However, if you're able to maintain better goals without causing hypoglycemia in some patients, you can go ahead and look for stricter targets like 6.5, 100 or 140 postprandial. We need to assess the glycemia two times a year once it is stable, but earlier maybe every 3 monthly till you get the patient into goal. However, it's very difficult, even whether we talk of 6.5 or 7, these are very difficult targets to achieve, as you can see. And these are the targets, of course, set by different organizations. And this is what the slide that tells you that while India is 8.7 to 9.6 in terms of achieving these targets, the rest of the world doesn't know better. Almost everywhere the targets are around 8 or more, and very rarely it's under 8. So while we do talk of glycemic goals, they're very hard to achieve in practice. So how intensive would these goals be? Especially for younger patients, you can aim for less than 7 or even 6.5. Healthier, newly diagnosed patients, especially more stricter, aggressive. However, you need to individualize. Existing guidelines are appropriate if applied flexibly, and you have to fit an individual circumstance, as we will see in the subsequent slides. And therefore, you might need to define less stringent goals of, let's say, less than 8 in some patients, especially who have low life expectancy, or where the harms of treatment are greater than the benefits. And there you need to be a little lax, especially elderly patients, those who are prone to hypoglycemia, CVD, and other comorbid conditions, and so on. And this was very well summarized in the ADA guidelines earlier, where they clearly showed that the disease duration being short, life expectancy long, no comorbidity, no established vascular complications, and the patient is also motivated, you can be more aggressive. If all these factors are not existent or the opposite, then you be less stringent and maybe have more stringent goals or goals for control. The RSSDI in 2020 with ESI, and now revised by RSSDI in 2022, set up guidelines and specifically talked about individualizing treatment goals. When I'm not going to the depths of each sulfonylurea or each agent and the relative merits or demerits, I'll focus on this individualized patient care approach that RSSDA actually has put forth. This is referred to as the ABCD EFGH approach, as we will see. And an expansion of that is the RSSDI ESI therapeutic goal wheel. And we'll come to the details of it a little later, just to tell you that this wheel summarizes what I'm going to talk in the next 10 to 15 minutes, and then we'll come back to the wheel briefly towards the end. Why should we have individualized treatments for type 2 DM? For patients who have been diagnosed with diabetes, consider a combination of metformin and one of the treatment options. We all know that we start with metformin most of the time as the initial drug of choice whenever we deal with high blood glucose in diabetic patients, particularly type 2. And we're talking in this talk, we'll confine ourselves primarily to type 2 diabetes mellitus. And therefore, the factors of A, B, C, D, E, F, G, H would be age, BMI, CKD, which is now known as DKD, duration of diabetes, established CVD or established CVD risk factors, financial condition of the patient, glycemic status, and hypoglycemia concern. These are the basic factors on which we base our choice of an individual type 2 diabetic. And therefore, we call it individualized treatment, depending on which factor becomes prominent in one or the other. And drug choice should be based on patient preferences as well as presence of various comorbidities and complications and drug characteristics, with the goal of reducing blood glucose levels while minimizing side effects, especially hypoglycemia and weight gain. This is a broad goal that we want to set in most patients. And within this broad framework, we will set individual goals. A comparative effectiveness meta-analysis suggests that most of available non-insulin agents added to metformin actually lower the HbA1c by maybe 1% or so. And another study from India also showed that all oral antidiabetic agents and GLP-1 analogs reduce A1C by 0.5 to 2% range. Insulin is the only one which can reduce it as much as 3.5, depending on the dose that you use. So this basic framework, which we understand, and then go to each of these factors, age to begin with. Age is an important factor or determinant of the choice of oral antidiabetic and even injectable antidiabetic agents. Individualization of therapy is highly desirable based on risk of hypoglycemia, comorbidities, functionality, cost, and personal preferences in elderly diabetics. So when we talk of age, we say the higher the age, the more precise you have to be in your choice of drug, and therefore elderly diabetics are the issue. Higher the age, the more careful you have to be, the more limited is your choice. DPP-4 inhibitors may be more suitable addition to metformin in elderly patients, especially to avoid hypoglycemia, weight gain, because you're already on metformin, mind you. However, the dose needs to be adjusted as per GFR. Recent double-blind RCTs have reported that gliptins are efficacious and safe with minimal tolerability issues in this age group when added to metformin. AGIs also have been shown to be useful in elderly. However, their effects are modest, and they also have limiting factors like GI side effects, which are particularly worrisome in the elderly. A double-blind RCT, again, compared to diet, showed it was very successful in improving glycemic profile in the elderly. Newer sulfonylureas like gliclazide MR and low-dose glimepiride can be safely used with minimal risk of hypoglycemia. Use of glitazones, although it can be used, but it is restricted in elderly because of other complications, particularly weight gain, fluid retention, CHF propensity, osteoporosis in postmenopausal women, and so on. And therefore, we generally tend not to use this drug as a first line. GLP-1 analogs, SGLT2 inhibitor, the evidence is recently forthcoming even in the elderly. The available data suggests that both of these agents provide good glycemic control and can reduce CV risk even in this age group. Certain drawbacks like cost, discomfort of injection in case of GLP-1 analogs, risk of mycotic infections, genital infections, UTIs, hypovolemia, postal hypertension, and weight loss. With SGLT2, especially in the elderly, which may cause frequent falls, may be a factor, a deterrent. And evidence suggests that basal insulin analogs, particularly the glargine, etrasimod, and diclodic, are effective and safe. And compared to NPH and premix, are probably better and safer in the elderly. And a pooled analysis actually revealed that modern insulin analogs added to oral antidiabetic agents worked much better, especially in terms of hypoglycemia in the elderly. So with these factors in mind, and we'll probably briefly look at the wheel if time permits, these are the factors we consider. And as there is increasing age, these factors become more and more important, and we need to be more rational in our choice of a patient who's older than who's younger. Then coming to the second most important component of the wheel, which is the BMI or the B. Again, weight is an important concern in few patients. And therefore, while prescribing pharmacological treatments for overweight or obese patients, providers should first consider anti-diabetic medications which either cause weight loss or are weight neutral. GLP-1 analogs and SGLT2 inhibitors, as we all know, are associated with weight loss. DPP-4 inhibitors and AGIs are weight neutral. And a systematic review actually suggested that both these agents, groups of agents, had significant weight loss when added to metformin, and therefore seem to be the best add-on therapy for those who have high BMI. And a recent systematic review again showed significant weight loss with GLP-1. SGLT2 also has significant weight loss properties. And agents of this class have an added advantage apart from weight loss in that they can be given orally, and they're also useful in preventing cardiovascular and renal complications. Side effects I've already mentioned earlier, and therefore we need to keep that in mind. So these are the two agents, followed by the two other groups which are weight neutral, which will be the choice if BMI is of major concern. Gliptins are major, I told you, weight neutral. Sulfonylureas, if at all they have to be used, the newer ones, especially glycoside, glimepiride, which are supposed to be, either weight neutral or only have slight weight gain, can be preferred over the traditional ones. In terms of DKD, again, a third important concern in patients with renal impairment, primary preference of therapy would be gliptins as add-on to metformin, however, most of which would require dose adjustments, except linagliptin and teneligliptin. Ripaglinide is another choice, a short-acting drug, and therefore it's useful because its effect goes away and the risk of hypoglycemia doesn't persist. Pioglitazone theoretically can be used in CKD, even in advanced CKD, but because of fluid retention, one needs to be a little cautious. Short-acting sulfonylureas, glipizide and glycoside, again, are preferred in situations of DKD, especially in moderate to mild renal impairment. GLP-1 analogs, although they can be used up to a GFR of less than 15 ml, probably because of the GI side effects, especially in renal insufficiency, are not practically very useful. AGIs, again, can be used, but especially in mild to moderate, but have their own limitations and mild effects. Insulin can be used at any stage, from mild to moderate to severe DKD. Across the board, you can use insulin. So that's one drug which is always available to you. Duration, the problem with duration is that, the beta cell function is deficient. Those drugs which act via insulin don't act as effectively. So secretagogues, like particularly sulfonylureas, will not be that effective at this stage. The insulinogenic insulins are generally preferred. However, incretin-based therapy can also be used at times. SGLT2 and AGIs, which don't work through insulin, can also be used. DPP-4, of course, are not very useful agents. They're not very effective in this setting. Those who have cardiovascular risk factors, especially or already established CVD, you need to think of GLP-1 analogs and SGLT2 inhibitors. As we all know, both have significant cardiovascular benefit, and especially in heart failure, the SGLT2s are preferred. And these are the drugs of first choice, followed by pioglitazone at times, although it can be sometimes tricky because of subclinical heart failure or low ejection fraction. In terms of the other drugs, linagliptin, glimepiride, and glycoside MR may be preferred over the conventional sulfonylureas. So they come later, third choice. As far as cost is concerned, best would be sulfonylureas, and these days they've been shown to be fairly effective or neutral in types of cardiovascular risk. Pioglitazone is also inexpensive. DPP-4, some of the inexpensive ones might be used, and these days the costs have come down. So these can also be used. Conventional insulins, of course, are cost effective all the way. If somebody has severe or worsening glycemic control, these agents to be used in this order: insulin most effective, GLP-1 analogs, followed by SGLT2, followed by pioglitazone, DPP-4, sulfonylureas, and lastly, glinides and AGIs, which have only mild effects. So that sequence will be followed. When hypoglycemia is a concern, insulin, sulfonylureas, and glinides are obviously associated with greater risk, so you tend to avoid. And if in a meta-analysis, it was shown that these have higher risks of hypoglycemia compared to AGIs, thiazolidinediones, DPP-4s, and GLP-1 analogs. And for those drugs, would be preferred instead of insulin, sulfonylureas, and glinides. And therefore, with history of hypoglycemia, you need to focus on the groups that I've mentioned. Now coming to the wheel itself. So all these factors and all these points of individualization have been incorporated in the design of this wheel, and spend a couple of minutes on this design, and then we'll quickly wind up. If you look at this wheel, the center is the lifestyle management, or this is the most important thing, lifestyle modification to be given in everybody. This is the core, followed by metformin. RSSD even today says metformin for most patients is as a drug of first choice, except it is open-ended here, which is the C, or which is the DKD, as I said now. And here, you depending on the GFR, we all know that 30 ml per minute or below, you will not give or start metformin or even continue metformin. And there are guidelines to use. You may not use in every patient. All of the patients metformin. So metformin is the drug to be given after lifestyle. And then we have A, B, C, D, E, F, G. And this is the A, B, C, D, E, F, and G. And as you see, the widest options are in the center. If a particular factor is not important, then any drug can be used. As long as the patient lies in this ring with respect to any factor, most choices are available. But as you go to the periphery, it becomes orange, and then red, the choices are much more limited. So for example, for age, you have only these drugs, the DPP-4 AGIs, SSUs, gliptins, and insulin available, as I mentioned in my discussion. Or for BMI, for example, all that is available here is SGLT2, GLP-1, DPP-4 AGIs, the 4 drugs which I had mentioned during my discussion earlier. And similarly, for all the groups, for finance, for example, you have sulfonylureas, insulin, pioglitazone, the cheapest drugs available if the patient can't afford. So depending on, in a particular patient, which is the priority, and looking at the wheel and running from center to periphery, depending on how serious is the concern, you will choose either the red or the orange, and then add those 2-3 concerns and finally come to a drug of choice. This is how we use the wheel. It's a user-friendly wheel, and when a patient comes to your clinic, prescribe lifestyle and metformin to most patients, then identify the 2 or 3 most important concerns in him from the ABCD, EFGH, and then depending on that, you go to the outer ring, the red or the orange, depending on the concern, and then come to which drugs you can use. When you add 2 or 3, then you're left with a choice of maximum 1 or 2 drugs, and then based on that, you can individualize which particular agent or drug you will use in that particular patient. So this is how we choose drugs in our setup. 2 things which have not been covered by RSD ESI, just to give it open, and we have not yet recommended it, which have been touched by the American ADA, is that they also believe that if somebody has a high risk of atherosclerotic vascular disease, heart failure, or CKD, you might initially give them GLP-1 or SGLT2, depending on the situation, not worry about the HbA1c level at all, and maybe this is the first drug to use rather than metformin also. All other cases would follow the traditional pathway. And as far as the ACE is concerned, it has divided it individualized based on the A1C levels. If it's less than 7.5, you give monotherapy in the way I've described. But if it's more than 7.5, you start 2 drugs to begin with. And if it's more than 9, you may start 2 or 3. And if the patient has symptoms, also give insulin right from the beginning. So with these 2 additions, your individualization gets complete. So my message to most listeners and participants is that, it's a very simple method because there's a wide basket available these days. You choose as per the RSSDI wheel. How to do, I've shown you. I'm not giving you examples because it's not a workshop, but then you can individualize based on these concepts and effectively organize control of blood glucose in your type 2 diabetic patients. Thank you.
So, thank you, Professor S.V. Madhu, for that enlightening talk, and I'm sure our students will be benefited. And do we have question answers, Dr. Chawla, or sir?
We will have a panel discussion towards the end. I think we'll request him to stay back for discussion.
So I think it's my proud privilege and honor to be welcoming Professor Vijay Vishwanathan And so we all know him. He is the head and chief diabetologist at the MV Hospital for Diabetes. His center is the Collaborating Center for Research, Education, and Training of Students in Diabetes. And more than anything, he's the honorary president of the Diabetic Foot International, which is a society based in Belgium. And this is a society with lots of experts in diabetic foot. He's completed 32 years as a diabetologist and has published over 200 original research papers, mostly in diabetic foot and in diabetic nephropathy, also on diabetes and tuberculosis. So we are all actually lucky to hear from him how to manage a diabetic foot ulcer. So over to you, Professor Vijay Vishwanathan, for your topic today.
I'd like to thank my elder brother, Dr. Rajiv Chawla. And
our pleasure, sir. We welcome you on the. Thank you.
And I'll try to finish in 12 minutes. And when I say 12 minutes, it's not 22 minutes. It's 12
no, we have 20 minutes slotted, sir. Take your time, because next speaker obviously will start once you finish. So you have your 20 minutes. We are okay.
I'm just sharing the slide. 1 minute.
Yeah. Thank you, sir.
So the topic given to me is how to manage a person with diabetic foot ulcer. And this is going to be a case presentation because we have heard so much about diabetic foot infection in the past. So I'm not going to talk about theory much, but how to manage a person with a diabetic foot ulcer. So this is a typical patient who comes to us with an ulcer here, and you see this is a patient who's admitted here right now, and you can see that this person has got a Charcot foot. Jean Charcot was a person who described it, and you can see that the Charcot foot is there. There's a dislodgement of the tarsal bones here, and there is an ulcer. So how do you manage this ulcer? Is my topic for the next 12 minutes. So first of all, you should understand that people with diabetes can have a high-risk feet when they have neuropathy, loss of protective sensation, loss of blood supply to the leg, which is called high peripheral artery disease. And then they can ulcerate, which can become infected, gangrene, and then this is a simple algorithm given by our colleagues in King's College, Ali Foster and Mike Edmonds. So this is a very simple algorithm, stage 1, stage 2, stage 3. So we are now dealing with this patient who has an ulcerated foot, not yet infected, but ulcerated. So first of all, when you have a patient like that, you have to establish a test. And Dr. Rajiv Chawla has published a paper on NDS and NSS together. And I'll be talking about it 2-3 slides later. So we have the monofilament testing, where we use the monofilament to test the large nerve fiber. So the monofilament is widely available in India, and we're testing, once again I'm telling, we're testing the large nerve fiber. The Ipswich touch test is a simple test, just touching, not pressing, not moving. Just touch the first, third, and the fifth toes of each lower limb of both of the feet. And if we can't feel in 2 out of 3, then the Ipswich touch test, which was developed by Jerry Raymond, is showing loss of protective sensation. You also have an instrument called the vibration perception threshold, called a biothesiometer or sensitometer, which is once again for the large nerve fiber. So monofilament and the vibration perception threshold is testing the large nerve fiber. Now, what about the small nerve fiber? Small nerve fiber is tested by 2 simple methods, the temperature perception and pinprick. And if you can't feel the vibration perception threshold or biothesiometer, then you give 1-1 here, and the ankle reflex alone is given a mark of 2. This is an algorithm NDS, which Dr. Rajiv Chawla published along with NSS, neuropathy symptom score. And so this was described by a by Andrew Bolton of Manchester and by Carolyn Abbott also from Manchester. And they found that if you have a score of more than 10 out of 10, they found anybody has a score of more than 6, I'm sorry, more than 6, then they ulcerate. So if you have just loss of ankle reflex and temperature, this you get 6. So you get 2 points here and 1 point here. So you get 6. So if you have a score of 6, that means you will ulcerate. If you have a score of less than 6, you will not ulcerate. This was what was described as neuropathy disability score by Andrew Bolton and Professor Andrew Bolton and by Carolyn Abbott. Let's not forget that about 20 to 30% of the population has peripheral artery disease also. So you can use your hands, but there is a handheld Doppler which is available in India from Huntley company called Huntley, which is costing around 30,000 rupees. And every diabetologist should possess one handheld Doppler, and you test the dorsalis pedis artery, which is kept here, and the posterior tibial artery, which is felt here. So you can measure the dorsalis pedis and the posterior tibial by doing this. Now, neuropathy is the commonest cause, and this was a Nature review which we wrote along with neurologists from United Kingdom and United States. And what happens in diabetes is there is a demyelination and also the axonal degeneration. These two are the pathological changes which occur in diabetic neuropathy. And this is pathognomonic of diabetes, and 70 to 80% of people who develop a foot ulcer have neuropathy. Now, coming back to the patient, we need to do this patient, you saw, if you remember, the ulcer on a Charcot foot. So you need to have a mechanical control where you offload. And I'm going to talk 2-3 lines about offloading. Wound control, where you try to manage the wound with wound dressings, modern wound dressings. You do microbiological control. You take a swab from the theater and try to treat the antibiotics, give the antibiotic according to the organism. If you have less of blood supply to that ulcer, this patient had a Charcot foot and no peripheral arterial disease. But if you have a vascular problem, you should refer to a interventional radiologist. Many patients require a basal bolus insulin regimen, and educational control is very important. You have to educate the patient not to walk. Now, footwear manufacturing unit was started by us 20 years ago, 25 years ago in our hospital. And you can see that such a patient needs offloading, unless because he's got Charcot and got an ulcer. So this is a Crow device, Charcot restraint orthotic walker, and we make it for about 2,000 rupees. So the Charcot restraint orthotic walk Crow is applied on the side of the ulcer. And the other alternative is to use a total contact cast. If it's not infected, there's no peripheral arterial disease, and if it's not infected, if it's just an ulcer, you can use a TCC, total contact cast. And I need not tell you about how to apply a total contact cast. That's a different talk altogether. The IWGDF guideline gives the latest, this is the latest guideline in 2023 about how to manage somebody with an ulcer. And I would strongly recommend all of you to read this iwgdfguideline.org, where we have talked about the offloading guidelines for people with a foot ulcer. Now, what about people who do not have an ulcer? And I'll wind up my talk with that. So people who do not people who do not have an ulcer as yet, who have loss of protective sensation, we have developed these footwear, which is made like a shoe. The inner should be soft with no stitches and all that. And there should be a counter. There should be a wide toe box. These are the characteristics of a good footwear. And we make this footwear in our hospital itself. It costs about 1,500 to 2,000 rupees for these footwear. And It's available. You can order it in Amazon. You just go to Amazon and the search text box, you type MV Diabetes Healthcare and so on. And lastly, I think the only way to prevent an ulcer is especially if you have neuropathy or loss of protective sensation, is to do a self-examination. You should use a simple magnifying glass and mirror and examine the foot, the plantar aspect of the foot every day, and see that you have not developed an ulcer. So I'd like to thank once again Dr. Rajiv Chawla and Shalini for asking me to talk this afternoon. And thank you, Dr. Rajiv.
Thank you, sir. But do stay back for some discussion toward the end of the session. Thank you for a wonderful presentation.
Thank you. Thank you.
Next is Dr. Krishna. Dr. Meena, you may introduce, or I'll introduce, let them.
Yeah, go ahead.
Okay.
Yeah.
Okay.
This is a recorded.
With that, we go to the third session, that is by Professor Krishna Sheshardi, who is Director, Primary Academy of Medical Sciences. He is American Board Certified Endocrinologist, Consultant, Chennai Diabetes and Endocrine Clinic, Clinical and Research Lead, Apollo Sugar, and Senior Consultant, Apollo Hospitals, Chennai. Has been Professor, Endocrinology and Medical Education and Board Member at Shri Balaji Vidyapeeth and MGM Health. He's a huge CV, has more than 150 publications to his credit, a true researcher in sense, and a wonderful orator. I'm a personal fan of Professor Krishna, as I always tell him that you are a wonderful orator. So I'm sure he's going to do more than justice to his topic. So Dr. Krishna is already logged in. Neelam, you may run his session, which is recorded, and then he will be available for discussion.
Sir is joined for question and answer.
Yeah, please.
And colleagues for having me in this meeting. It is really my pleasure to give this talk, especially something that's very dear to my heart, but how we need to transition from diabetes care to metabolic care. I've always believed that we need to sort of upskill diabetes care into metabolic medicine for the past 10 years. And this was strengthened by two conversations, both doyens in the field of cardiology, and they both passionately believe that it's time to talk about a specialty of metabolic medicine. Especially, I had this conversation with Dr. Eugene Braunwald, who's subsequently been writing about how diabetes is a cardiovascular disease. And I had this fortune of actually facilitating a meeting that he spoke in, and I had the good fortune of speaking with him for close to an hour in that particular talk, and how he was passionate about this, including starting a fellowship in this particular area. Such efforts have been very popular now in other countries, and I was hoping that this is something that we need to start looking at in India. Support for this came to me from this man, somebody who I admire a lot, Dr. Mohan. And our discussions, we followed this up with a nice editorial that was published last month in the Journal of Diabetology, that again summarizes some of the things that I'm talking today. Let's start with the patient. Here is someone who is 57 years old, a man from one of the suburbs of Chennai, who presented to me actually with hypothyroidism. Notice he was hypothyroid. His TSH initially was 54, and I have just pasted things straight from my electronic medical record so that we know that these are authentic patients and I have their permission to do this. And you see that around, and he's somewhere around 4 months later, his TSH was pretty much normal. But if you notice that from the time he had come in, his BMI was around 34, and also that he had pre-diabetes that he did not know about. His LDL was also elevated. He started complaining of fatigue, and this persisted even after control of the hypothyroidism. So when I saw him somewhere in June 2022, I said, these were the problems: dyslipidemia, vitamin B12 deficiency, vitamin D deficiency. And we do scoring. And one of the things that our EMR is able to do is a stop bank score. And what we did was that looked at the age, the BMI, the gender, the neck circumference, treatment for blood pressure, snoring. And the stop bank score was pretty much 6. That pretty much showed that he had obstructive sleep apnea. And we got a sleep study, and it showed that the apnea-hypopnea index was quite high, which is 26.4. So besides suggesting a CPAP and a BiPAP, we started thinking about weight loss in this particular patient. In the meantime, very interestingly, his annual testing showed, and somewhere around this time we started doing CBCs and LFTs routinely on patients annually, and you would notice that again our EMR calculates a FIB-4 score. The FIB-4 was more than 1.3. When we did that, we got a TWE, a FibroScan, and if you notice the FIB-4 score, the TE score, anything more than 7.4 kPa is high, and anything more than 292 decibels is high in terms of steatosis. Here is someone who incidentally had an F3, S3 MASLD. We call it MASLD now. And he had an ultrasound also that was done. So with the modern criteria, just him having these pre-diabetes, evidence of dyslipidemia, all the others, plus an altered fibroscan, puts him at an increased risk of cirrhosis and having MASLD. If you look at his sugars, when we first saw him, he had only pre-diabetes, and it took him a while. And despite the fact that he was on a weight-losing diet, around about 2023 he became a diabetic. But if you notice that the problems that he had, the obesity, the obstructive sleep apnea, the MASLD, all predated the diabetes. So clearly, what we now know, and the BMI, of course, had actually come down. These were his medications. He is on a DPP4 inhibitor. I'm sorry, he is on a SGLT2 inhibitor. He's also on a PPAR a gamma alpha agonist to take care of the MASLD. So look at his current problem. He's pre-diabetes, he's hypothyroid, now he's become diabetic, vitamin D and B12 deficiency, obstructive sleep apnea, obesity, hypertension, MASLD. Now, so the metabolic state in type 2 diabetes is a consequence of a complex network involving multiple organs and biochemical pathways. So glucose is just one part of this whole picture. Importantly, obesity predates many of us. At around normal or underweight, you're okay, but once you start moving out of that pathway, and remember that we now know that each one of us has our own fat threshold, that there is a threshold of fat above which it does become toxic. But when we exceed our fat threshold, or in the olden days of BMI of 23, and the inflammatory cytokines and the adipokines are activated, fat accumulation and fat becoming ectopic starts. But once you start going past the overweight into the obesity area, you start getting vascular endothelial dysfunction, hypertension. MASLD, remember, insulin resistance is sine qua non with fat in the liver. That unless there is diacylglycerol accumulation in the liver, there is no insulin resistance. So clearly, that starts off the cycle. There is diabetes. There is peripancreatic fat accumulation that occurs that worsens beta cell dysfunction. At the same time, SIT1, PPARs, and the CREB group of proteins are already activated. By the time the obesity is moderate, you already are at risk for chronic kidney disease, cardiovascular disease. And if the obesity is severe, you are already at a risk of cancer development and progression. In addition, at the same time, there's inflammation associated with change in the microbiome that affects our eating, that affects the insulin resistance, that affects the pancreas, multiple things that can be talked about in another talk. So why metabolic medicine? So diabetes is only one manifestation of a cluster of abnormalities that occur when environmental influences interact with genetic predisposition. These include food-related, activity-related, sleep, and light-related. Right? So both have a genetic susceptibility, then an environmental interaction, they feed on each other, and we know now that if you lose weight, you get rid of diabetes. The consequences of these interactions include food excess fat storage, the inability to partition fuel, which is an important part of why there is a change and the alteration in mitochondrial bioenergetics that leads to a change in the fuel efficiency in critical organs. There's inflammation that occurs because fat becomes ectopic and fat apoptosis occurs. Organ dysfunction follows. So there is a metabolic conundrum that we talk about, where the presence of free fat in the liver decreases glucose uptake in the muscle, increases oxidative stress, presence of endotoxins, inflammations, steatohepatitis, fibrosis, and cirrhosis. The fat accumulation in the liver also causes increase in glucose production and a change in insulin and glucagon. So the phenotypic expression of these abnormalities occurs in a linear fashion, or they can occur simultaneously. Obesity, and remember that we don't anymore talk about metabolically healthy and unhealthy. And even if there is healthy, it can quickly change into unhealthy. Metabolic syndrome, diabetes, cardiac and renal dysfunction, NAFLD, obstructive sleep apnea, cognitive dysfunction, hypertension and dyslipidemia can occur early or delayed depending on the epigenetic imprinting, the genetic inheritance, and the interaction of the environment with the genetics. For example, MASLD is an anchor, correct? So it accelerates atherosclerosis, it accelerates diabetic nephropathy, it accelerates diabetic retinopathy, it worsens diabetes. Diabetes, on the other hand, also increases the propensity of NAFLD to cirrhosis and cancer. So the presence or exacerbation of one component affects the expression and outcome of another component. Example, cardiac and renal dysfunction. And of course, obesity, for example, has an impact on diabetes outcomes. We weren't able to prove this for a long time, but we now know that obesity worsens CKD progression, worsens retinopathy, and worsens neuropathy. For example, when the progression of DKD occurs, CV outcomes worsens. Here is an interesting slide. I'm sorry about the quality of it. This is looking at an EGFR 30 to 60 and less than 30, and you will realize that the MACE scores are much higher when your GFR is higher. When you look at when your GFR is lower, when you have an updated EGFR slope, look at what is happening. When your slope is much higher, you will find that there is a increase in the progression of MACE. And if you look at the mean plus slope, again a low EGFR plus a slope causes an increase in MACE plus. Similar with heart failure. So clearly, the progression of DKD affects CV outcomes, and I can tell you the progression of CV outcomes increases the progression of DKD. A classic example, of course, is NAFLD. If there's no diabetes, you have about 25% of the population have NAFLD, 10 to 20% have NASH, 10 to 15% have cirrhosis, of which 3% progress on to hepatocellular carcinoma. Let's look at what is happening on the other hand. If you have diabetes, about 66% of patients have NAFLD, 40% of which have NASH, and our own data seem to confirm that the FIB-4 scores at least are high in about a third of them, of which 2/3 of them have F2 or higher fibrosis. S2 or higher steatosis, and a third of them have F2 or higher fibrosis. So a third of them progress to cirrhosis, and of which 5% go on to hepatocellular carcinoma. Just the presence of diabetes increases the progression of NASH. So why metabolic medicine? A holistic approach to care often improves and moves the expression and outcome of more than one component. In addition, medical therapy of one component improves expression and outcome of another component. For example, in the direct study, we knew that if you took care of weight, for example, a 10 kilogram weight at the end of 2 years showed a 64% diabetes remission. And weight loss at 5% improves just diabetes and obesity. At 10%, reduces the cardiovascular risk. At 15%, even changes mitochondrial structures. Let's look at the impact of treatment of obesity on diabetes outcomes. Again, some new data. And if you look at it, it's looking at surgical versus non-surgical populations. The composite microvascular outcomes are improved when compared to the standardized therapies. For example, at around 2.4 years of follow-up, the crude HR is around 0.52 for composite microvascular outcomes. It's really good stuff. And remember that more and more people are looking at treatment of obesity as one of the primary targets of diabetes therapy. Also, the availability of agents such as SGLT2 inhibitors, GLP-1 receptor analogs provide a single modal therapy that addresses many components. And now we have agents that can lower the weight as much as 15%. That is something that was unknown of in the past, but now the GLP-1 receptor agonists at higher doses, combination therapies, the glucagon co-agonists, the twin cretins and the tricretins are all there that bring down weight as much as bariatric or metabolic surgery. Here's an example of SGLT2 inhibitors that work on energy metabolism. Again, multiple salutary effects. And the question, and I saw a joke somewhere saying, I think we should start having trials of what SGLT2 inhibitors do not do instead of having some on what they do. Similarly, GLP-1RA has very salutary effects in the metabolic syndrome. GIP increases LPL activity, increases adipose tissue and accretion, decreases bone resorption. GLP-1 increases enzyme secretion, increases natriuresis, increases diuresis, causes cardioprotection, and decreases gastric emptying. So the care of the initial expression of many of these conditions can be done better by primary care physicians with some additional training, allowing for most of care of the more severe expressions by subspecialists. And that's really the concept of metabolic medicine. We have non-invasive tools that are present. The Curis 3, I already gave you an example of the FIB4. We already all use EGFRs. Simple tests that can be done in the bedside through your EMR, through an app, through your calculators that make it very easy. You don't need to do fancy stuff. For example, even if you don't have access to an echo, today many of us can do an NT-proBNP to decide whether somebody's in stage B heart failure or not. So what should we do? I think we should upskill our practice metabolic medicine, definitely. Improve our knowledge of nutrition. I think that's very important. Increase our knowledge in data science and start collaborating and working with each other. And that brings us to the end of this presentation. I hope that, I've made a point in saying that it's time to start looking at diabetes holistically, treat it upstream, look at obesity, look at MASLD, look at heart failure, look at obstructive sleep apnea, look at cognitive dysfunction. Because diabetes is just being blindfolded and looking at one part of the elephant. We need to open our blindfolds and look at the whole elephant and start treating the elephant in the room, which is metabolic dysfunction that's associated with obesity and lifestyle, genetics and epigenetics. Thank you so much for your patience. I will join for questions. Thank you so much.
Thank you. Thank you. Dr. Chawla, we shall proceed to the next.
You may introduce Dr. Anuj, and towards the end, after his session, we will have discussion. I'll request all these faculties to please stay back.
Yeah, we'll have a question answer at the end. Thank you, Dr. Krishna Seshadri and Dr. Anuj Maheshwari. Yes, put up his CV slide. Yeah, so he's professor in medicine at the Hind Institute of Medical Sciences, Lucknow. I say Anuj is omnipresent. We see him at every meeting, every conference, and he's a recipient of several awards, including the 2016 Notable Achievement Award in Hypertension Prevention at the population level by the World Hypertension League, and also received the Marvelous Personality of the Year Award 2017 by the Governor of UP. So it's going to take me a very long time if I read his entire CV. So a very warm welcome, Professor Anuj Maheshwari, and the stage is all yours. Has he logged in? I can't see, Dr. Professor.
Neeraj, Neelam or Mahima, please connect Dr. Anuj. Yes.
You for giving me this opportunity to speak in very prestigious CMRE meeting. I shall be telling you about the clinical benefits of weight loss of diabetes and cardiovascular risk in next 15 minutes as an interactive case-based approach. As we all know that obesity is increasing in our country very fast. Not only in our country, but this is becoming a global pandemic, which is requiring the treatment. Around 650 million people live with obesity across the globe. Life expectancy decreases as the BMI increases. Usually we can see normal BMI at which 80% life expectancy there. But if the BMI is increasing up to the 35 and 40, then life expectancy reduces to 60%. And if it is further increasing BMI 40 to 50, we can see life expectancy just 50%. And chance of reaching age 70 becomes very, very less. So if we talk about the obesity and its complications, we understand that it may affect on multiple organs with the mental, metabolic, and mechanical complications. It is associated with multiple complications on the multiple organs it is working on, maybe inducing to the cancers, infertility, gallstone, non-alcoholic fatty liver disease, and through this may also lead to various ailments of the cardiovascular disease, as well as type 2 diabetes and pre-diabetes becomes more common in patients with obesity. Weight gain is dangerous. Obesity is further dangerous, and morbid obesity is actually a stage of obesity where we can get lot of those complications which we see with metabolic diseases usually. If we talk about the case-based approach, and if we talk about a example from our community, HbA1c 8.6%, a gentleman who is obese, having the BMI of the 30 and weight is 106. Duration of diabetes is 3 years. Managing his diabetes with weight management a bit difficult, although he is using a medication that is semaglutide, which is supposed to be the weight reducing medication, together with already being given anti-diabetic medication, gliclazide, metformin combination. But the challenge is, despite the claims of the weight reduction with the molecule, he is not getting the optimum benefit of weight reduction. Although glycemic control he got better after some time. What happens after the 6 months of this patient when he was continuing of that medication? HbA1c came down to the 7.1%, but weight has also come down to 101 kg, BMI a very little reduced to 29. Semaglutide has been added up with increased in the dose or up titrated to 7 milligram while continuing with the existing medication. What the challenge was that glycemic control is definitely working good, but weight has also been reduced, but after a few months it gets stationary, and many a time it starts getting up higher and it starts getting up again and again. So most of the time our weight loss efforts gets in vain when after some time weight starts getting increased. Long-term weight loss is definitely very challenging. Maintaining the weight loss is difficult. because metabolic adaptation following the weight loss is actually resist the further weight loss because of the multiple reasons and multiple changes which are occurring at the hormone level, where we can see that satiety hormones are decreasing and hunger hormones are increasing, and they actually try to regain whatever the body has lost. And metabolism is further tries to reduce the energy expenditure so that body may not lose whatever it has lost. And this is the defense mechanism of human body, which usually takes place in response of our all effort for the weight loss what we do. 58% reduction in type 2 diabetes with 5 to 10% weight loss could be seen. So simply a 5 to 10% weight loss is giving a huge reduction in type 2 diabetes, and which is much more higher as compared to the metformin and other methods of the weight loss. So lifestyle modification is the strongest way through which we can achieve the weight loss, which may be long sustained, which may be the highest in amount instead of using any medication. Finnish diabetes prevention study has shown that more than 50% reduction of the diabetes type 2 prevalence after less than 5% weight loss in 4 years. So 5% weight reduction reduces the relative risk with 61%, and every 3 kg reduction in weight doubles this effect. Diabetes is caused by once the weight gain is there. ACP has also suggested that each unit increase in BMI increases the risk of diabetes by 25%. Each unit increase in BMI increases the risk of coronary event by 10%. An effect of the weight loss on complications can also be seen here, that 0 to 5% reduction in hypertension, hyperglycemia, 5 to 10% in the prevention of the type 2 diabetes, NAFLD, PCOS, dyslipidemia, and so on. Towards greater weight loss, overall health benefits are there. As much as we shall lose the weight, we shall be making more and more disease-free life of ourselves. So when we talk about the health consequences of the obesity, it is not simply a weight gain or simply an inconvenience which is occurring because of the weight gain, or even diabetes which may occur in such a huge number in patients, those who are gaining weight. But there are some certain other metabolic diseases which are hypertension, dyslipidemia, and all these three metabolic diseases, diabetes, dyslipidemia, and hypertension, together makes a bigger danger for the cardiovascular adverse ailment. The metabolic syndrome and reproductive problems are other commonly observed consequences of obesity, which are usually less talked about. So if we talk about a multiple metabolic syndrome, which is a cluster of the multiple metabolic abnormalities which predispose the individuals to increased risk of developing diabetes and cardiovascular disease, which is also known as the syndrome X. It includes a component of the central obesity, or we can say the visceral obesity, high blood pressure, high triglyceride, low HDL cholesterol, insulin resistance high. In India, around 31% adults are suffering from this kind of the situation in which what we call as metabolic syndrome. Why does it happen, and why does these three components are actually increasing each other or supporting each other? Because the insulin resistance is in the root of all these metabolic diseases. Like if we talk about the obesity, if we talk about the metabolic syndrome, hypertension, and diabetes, we see that 2 times metabolic syndrome and hypertension is higher as when it is combined with the obesity. And the complications which are coming up with as a result of the metabolic disorders, metabolic syndrome, hypertension like CAD, coronary artery disease, kidney disease, peripheral arterial disease, and cerebrovascular disease, they all get 4 times higher when diabetes joins the hands with them. So physiologically, obesity is caused by long-term positive energy balance, and higher energy food intake leads to the higher fat deposition. At the same time, once our body starts playing the defensive, against the higher energy food intake, and its expenditure gets lesser, or many a times we don't do enough physical activity, which reduces lower energy expenditure, and further we get more and more fat deposition, ending up with the obesity. So once we talk about the obesity management, this is available pharmacotherapies and potential economic benefits may be enumerated here, that multiple pharmacological options exist for weight management, like penteramine, like topira in the form of the topiramate. We can use the bupropion, orlistat, liraglutide. But what the problem is here, all of these are not really complete and well acceptable for the patient. Every molecule which is ending up with the weight loss has some or other difficulty to use. Lifestyle modification is the easiest pill which can does a weight loss or significant or optimum weight loss. And understandable and very important to understand is that medical cost decreases with weight loss. It has been a data of the United States Medical Expenditure Panel survey, which shows that greatest savings are seen with the higher baseline BMIs. The role of the brain in regulating appetite is also very much important. As we already have discussed, the brain always tries to maintain the homeostasis, may it be in eating, and it also increases the hunger whenever we are trying to save or trying to increase the energy expenditure. Whenever we are trying to lose the weight, and whenever we are doing all our efforts to increase our energy expenditure by doing exercise or by doing or getting the reduction in that diet or less carbohydrate intake, whatever we are doing, the brain tries to balance the phenomena. On the other hand, we see that behavioral intervention empowers the sustainable behaviors in controlling eating. Many of the time, certain hormones which are responsible for the pleasure of eating, like dopamine, controls wanting and more motivation to eat. On the other hand, the opioid and cannabinoid receptors control liking, the pleasure, and associated with the food intake. So once we talk about the hemostatic regulation of the appetite, we see that it's the arcuate nucleus, the first order neuron, in which we get the hunger signals, the release of the hormone that is called as ghrelin. Satiety peptides are those which stop this hunger signal and stop the release of the ghrelin hormone. On the other hand, the adiposity signals in the form of the leptin and insulin are also there, which increases the fat deposition. Satiety and hunger, these are the two different phenomena and which are actually opposite of each other, are being governed and being controlled by the hypothalamus. The brainstem regions which are known to control this nucleus tractus solitarius and area postrema, which controls the satiety through these satiety peptides as well as vagal afferents. So obesity management lies in the three structures, like one is the diet and exercise, and the pharmacotherapy, and third is the surgery. There are certain guidelines which have been given by the ADA and as a standards of care, and they suggest that metformin, SGLT2 inhibitor, and GLP-1 receptor agonists are the molecules which can help us in reducing the obesity. GLP-1 is released in response to the food intake, and it has its action on multiple organs of the body except the liver. GLP-1 activates areas of the brain involved in the appetite regulation. It also increases the satiety and reduces the hunger in normal weight subjects. GLP-1 reduces energy intake in humans. At the same time, it has the multifactorial effects. Its pharmacological effect is working on multiple organs like pancreas, heart, liver, stomach, and brain. So what does it do in the pancreas? Beta cell functions are improved, beta cell apoptosis is decreased, insulin biosynthesis is better, glucose-dependent insulin secretion is improved, and glucose-dependent glucagon secretion is suppressed. in the heart, it improves the cardiovascular action function, reduces the risk, fatty acid metabolism is reduced, and systolic blood pressure is reduced with the reduction in inflammation. Brain, it reduces the body weight by reducing the food intake and increasing satiety. Stomach, it reduces the gastric emptying, and as a liver in works that where the endogenous glucose production is reduced, hepatic insulin sensitivity is increased, and de novo lipogenesis is also decreased in the liver with less lipotoxicity. Other benefits of the potential mechanism for long-acting GLP-1 RA to reduce atherosclerotic burden. That's why we suggest that this is actually a cardiovascular reducing anti-obesity medication. If we talk about the SGLT2 inhibitors, there are certain studies which have shown improvement in waist circumference, central obesity, and visceral adiposity, and all of which are features of the diabetes as well as metabolic syndrome. EMPA-REG outcome, if we talk about the SGLT2 inhibitors and its effect here, we see that it confers early and sustained risk reduction for cardiovascular death in patients with type 2 diabetes and atherosclerotic cardiovascular disease. And overall study population and risk reduction is much, much higher in the Asian patients as compared to the rest of the world. Empagliflozin also demonstrates a clinically meaningful 21% residual risk reduction in the composite primary endpoint of the CV death and hospitalization due to heart failure. Empagliflozin consistently lowers the risk of CV death and heart failure hospitalization in patients across the spectrum of the heart failure. It's not necessary only in the patient, those who are having the reduced ejection fraction, but also those who are having the preserved ejection fraction, they are also getting benefits of the use of SGLT2 inhibitor in reduction in the cardiovascular disease in addition to the weight loss. SGLT2 inhibitors confer significant and meaningful cardiovascular benefit in patients throughout the CV risk continuum. So cardiovascular death or hospitalization for the heart failure has been seen in all stages of the disease, may it be in the early stage of the disease or in the advanced stage of the disease, where the reduction fraction has considerably reduced. So summarizing the talk, the obesity is a complicated disease which leads to multiple comorbidities, more important cardiovascular risk. As far as the management is concerned, is actually very, very suboptimal and needs more focus. The molecules which are known to reduce the weight, like GLP-1 receptor agonist and SGLT2 inhibitors, are not only game changer in obesity, but they are the molecule which adds value of weight reduction, because the weight reduction itself reduces the cardiovascular adverse event. But here we can say that if we are doing the weight reduction through GLP-1 receptor agonist and SGLT2 inhibitors, then it makes more sense in reducing the cardiovascular risk per se. And very soon we shall be having the recommendation to use these molecules even in non-diabetic individuals also. As of now, they are not available right now. Thank you very much for your kind listening.
Thank you, Dr. Anuj Maheshwari. And I think we have all the four panelists here and we can start our question answer session. So Dr. Chawla sir, I request you to set the ball rolling with your first question.
Let me start with Professor Madhu. A topic which he covered is very, very close to my heart, because we have been together in evolution of this RSSDI and ESI wheel also, since first edition 2015, then 17 by Dr. Madhu, 20 by us together, and 22 by Dr. Makkar. Of course, it was a team effort, and I must appreciate the entire RSSDI and ESI in putting and making this wheel a very, very important wheel. Sir, you had made 2-3 case presentations also, and you made a case for going back in your clinic and choosing the best drug in best interest of the patient based on our wheel, which is RSSD ASI wheel 20, and little bit addition again has changed in 2022. It is for the first time that now we talk about, if you remember our first wheel, 2015 and 16, 17, there we didn't fix up any hierarchy of a drug. That time we were talking like ADA says it is an open bouquet approach. Let the onus be on the treating physician and the decision be in best interest of the patient to choose drugs based on the prudence of that clinician. But for the first time now we have fixed the hierarchy of the drug also, but we are still saying based on Indian evidence that metformin, let it be the first line drug. Although ACE also and ADA 22 for the first time said, in fact, European Society of Cardiology for the first time said that all those patients, those who have atherosclerotic cardiovascular disease or presence of diabetic nephropathy or reduction in EGFR or ejection fraction, they may be actually be on SGLT2 or GLP-1 receptor agonist even before being on metformin. So what is your viewpoint in 23? Is it high time that we again evolve this wheel further and give maybe option of choosing these drugs over metformin?
Yeah, thank you. Actually, that's part of the reason why I showed the last two slides, which were from ADA and ACE, rather than restricting myself to the RSSDI wheel per se. The main issue was to just raise this aspect. I think now evidence is accumulating and probably even mounting to suggest that if there is significant cardiovascular or cardiorenal risk, then one might consider even ahead of metformin, giving SGLT2 inhibitors or GLP-1, if, as the case may be, depending on the situation. By far till now, RSSDA has been saying metformin first in any case. And maybe in future, we need to consider the available evidence and suitably modify. Only one thing that I'm not, although I may not be aware, and it might be my ignorance, whether there are studies where, only drug that was used was SGLT2 and the benefit in a diabetic patient, and the benefits were as profound as when they were added to metformin.
I don't
Also,
think Meena,
resistance is the core defect in type 2 diabetes. So I think ESC, it's a misstep. We have to give, because whenever we talk about obesity, we talk about insulin resistance. So I think I will continue in spite of whatever. So they have told us ESC that you divide the patients into mild risk of ASCVD, moderate with target organ damage, use the risk engine, any good risk engine, and you quantify ASCVD risk. But I still think that in India, most of our patients quit taking GLP-1 RA. And they start with enthusiasm and they quit. And so, of course, SGLT2, they might continue. But being a women diabetologist, I feel that at least 15 to 18% of my patients develop genital infections and resistant UTIs. I've not seen too many, but have resistant UTI because they're type 2 diabetics. So I don't think metformin can be replaced by, we can use these along with metformin is my take, because the glycemic benefits, the benefits on insulin resistance. So I don't see SGLT2s being the first line. I feel we think metformin is the first line. I mean, that's my take.
Only suggestion is that not that we want to replace metformin as a first line therapy. Even European Society of Cardiology 2019 said that those who are on metformin, they must be added either GLP-1 or SGLT2. But those who are not on metformin and the risks are very high, they may be on one of these drugs as first line option, and metformin can be added later. So can we have this little bit flexibility? Do we have enough Indian evidence? And more important than that is that whether it will be based on simple risk score, that we risk this patient and we stratify this risk and then say that because risk is very high, then you add SGLT2 or GLP-1, or we need certain biomarkers, or maybe a 2D echo or carotid intima media thickness or something else to risk that, and then based on that we should add these drugs ahead of metformin. That is what I want to clarify.
The two angles which I just want to add. the cardiologists are already doing it. You know,
They are
even
doing it.
non-diabetic patients, I think it's almost become the norm.
First line option.
Yeah, in every cardiology, OPD or a cardiologist, he will first put the patient on dapafloxacin and then talk about other things.
Yeah.
So given that,
Non-diabetics with heart
diabetic and
failure, or you're
non-diabetic.
talking about heart failure?
even in heart failure is a relative term, not obvious heart
CBD,
failure.
even in
Grade one to
CBD.
head mein hota hai. So they keep giving it. If you go to cardiology OPDs, I don't say it's the right practice, but what I'm saying is that it's being so widely used by cardiologists far more than endocrinologists or diabetologists. And therefore, the patient who is, whether it's diabetes or not, is already on an SGLT2. So this question actually becomes a little redundant, because we are talking of glycemic control, but when there's a cardiac risk or a cardiac event or a cardiac failure already existing, even if it is subclinical and only diagnosed by echo, they already are on it. What my point is that the evidence in terms of, part of the recommendations in my view, and I'm always a conservative person, Dr. Meena, that is pharma driven, and it's going to have a cycle length after which it will fade away. So that's one thing I believe in. I also need, before we revise that's why the word of caution was, when we do the next round of our guidelines, we need to review the evidence critically, whether Indian or non-Indian. Indian available, even better. Even the international evidence, whether they have seen that, giving SGLT2, even the absence of metformin as a first line of drug wherever, similar benefits accrue or no. This evidence has to be very carefully reviewed before we think of a change in priority.
Dr. S.V. Madhu sir, just a question. In earlier days, we were talking about combination therapy. So we used to use sulfonylurea with metformin. So if you have somebody with HbA1c of 8.5, we use a combination therapy. We know metformin is not going to work. So in such a case, where's the question of using metformin first and followed by SGLT? We start both together. And we have combos available in India and abroad. So I think the combinations are the rule in treatment naive patients. If the A1C is 8.5 or whatever, 8%, it's not going to come down in metformin.
And most patients, most of our patients would have A1Cs above 8.5. And if you had seen my slide, even after treatment, they remain at 8.5. So therefore, that discussion is purely academic.
Mean HbA1c across India, DICARE study was 8.2. So in any case, these days, Dr. Vijay, you are very right. In practical approach, we tend to start a combination of metformin with SGLT2 as a first line option right in the beginning. And Dr. Madhu, you very rightly said, I will say what you said, that a prescription by cardiologist. Other day, I saw a patient who was referred to me by a urologist because of recurrent urethritis and melanoprostatitis. And obviously, urologists will not do a typical band of DAPA, whether it is there or not. That patient was not diabetic. And urologist was worried why he is getting repeated attacks of urethritis. And when I saw the prescription already written by a cardiologist in that patient was already, he was not diabetic and he was already on DAPA. So it's a very, very common.
It's like a B complex that they're using it. It's as frequent as that. It's
Can
yeah, please.
Can I say, but with good reason, the sense that, I think metformin is ruled without a lot of data for many, many years. If it's being, if you look at it, we all sing the peans of metformin, but if you look at it very, very carefully, the data is very marginal.
UKPDS?
Please, I don't let me dissect UKPDS today, but the thing is that what did the UKPDS show? It didn't show anything, right? It did show that glucose control was good, and 10 years later it persists. It didn't show that metformin.
That is true. That is the only study which has actually established, other than the glycemic control, little role of metformin alone. There has not been any CV outcome. There were no outcome designed for proving a drug efficacy and superior.
There are more patients who undergo endoscopies and then come back and get their metformin stopped. So, I think we need to reach a balance. I'm not putting down metformin. Yeah. I'm just taking the other extreme just to say that, as times change, as the data improves, I think horses for courses is what we should do, and not hold on to something that, because the Brits have done a study on it, I don't think it's a reason to continue to hold on. But that's my personal view.
Yeah.
So, Dr. Sheshadri, your personal view in the light of India, where it's a moist country, where the sari wearing women in North India do not use undergarments at all. I see a lot of genital infections. So we are not saying metformin, but and the other thing
I'm
with
not saying that you
GLP-1
should use this SGLT2 inhibitor either. I'm saying
No, no.
don't be
What we're saying
sacrosanct
is,
about metformin being there always.
yeah, we're there with you, but please talk about insulin resistance being addressed by metformin, because we are talking about
Ma'am, that's also a myth, ma'am.
That's a myth.
So there's enough data that supports that the action of metformin is actually mitochondrial modulation. It's although there's a reduction in HOMA IR, it doesn't directly reduce insulin resistance. That is the role that the TZDs do, right?
Right.
The mechanism of action of metformin, while in the past we've been talking about insulin resistance, I don't think there is enough data to support that its primary mechanism of action is insulin resistance. If at all it's action on insulin resistance, it's an indirect and marginal. If you really want to reduce insulin resistance, use a TZD.
So we move on to the next question, I think. And
Krishna, you talked about NAFLD, MEFLD, and other day in Dr. Mohan meeting, MA, that is steatotic liver disease, MASLD. I was talking about MEFLD, and there was a sort of discussion on that what it is and how to do FIB4 scoring, and how do we actually reach to a early diagnosis and early suspicion. Where do you place that metformin there when we are talking of a comorbidity of type 2 diabetes, maybe MEFLD or NAFLD? Or
So again, metformin has little or no data in MASLD, isn't it? So the data seems to be with three drugs. One is the SGLT2 inhibitors, some amount. Again, no fibrosis data, just prevention of progression of the scores. With thiazolidine there is again emerging data. Our own data is small, 800 patients in 2 or 3 centers, showing that the combination of SGLT2 plus pioglitazone reducing FIB4 scores. Saroglitazar, for all the things that people tell about saroglitazar, has an orphan state approval for primary biliary cirrhosis. It's now DCGI approved. I think there is where I think what is going to happen is the glitazones will get will get a positioning in the MASLD status. Again, simply because I have a feeling, also because of the insulin resistance data, but also because of the action in PPAR and mTOR. So that's where that story is going.
But if we talk about evidence, I think GLP-1 receptor agonist has the best evidence in terms of not only some amount of reversal of fibrosis, but also checking the progression of fibrosis. Because even with
the reason I didn't mention the reason I didn't mention it was just about 2 months ago, semaglutide data did not show prevention of, it just showed markers, but not prevention of progression of fibrosis. So I think we should reserve the GLP-1 stories. This is just 1.5 months ago that semaglutide, the data showed that it did not prevent progression of fibrosis. So that's why I held back.
Coming to Dr. Vijay, you made again a very good presentation, and I'm happy you cited our study on NSS and NDS. I think this is high time, the way we had earlier an atlas by Dr. Pansay, you now being an DFOOT chair, international chair, and hopefully an upcoming RSSDA president. Don't you think that we should make a simple, very, very simple booklet? Other day, we together made a presentation in Dr. Makkad meeting where you actually demonstrated how to do a foot examination and all that. I think a very, very simple booklet you should design, and it could be sort of distributed across RSSDA membership, maybe under the logo or banner or domain of RSSDA, because doing alone, either you could do it through DFOOT or through RSSDA, because if you do through your center, people may not, obviously, may have a conflict on that. But I think I've seen how you examine your patients and how you made that examination very, very simple looking. In hardly you take 3 minutes or 2 minutes, and examination is complete. If that can be demonstrated through a video or maybe a simple booklet, and it could be distributed across, I'm sure this will be extremely helpful, because at least in North India, I haven't seen many people find me very odd when I examine the feet. And I, just to not boasting about me, many people gave this comment that, sir, only one person whom we have seen examining feet of every patient has been Dr. Hajra, because people don't even ask to remove the socks, what to do a detailed foot examination or a NSS or NDA score. And I have found in all our studies, it comes out to be very handy, very simple score on the bedside, and it almost clinches the diagnosis, even if you're not doing a biophysiometry, neurophysiometry, or nerve conduction velocities. What is your comment?
Yeah, RSDA is bringing out an atlas in another 1 month's time with JP Brothers.
Yeah.
So almost ready, and it's a question of 2-3 weeks before we. So RSDA, the official
That's good.
official
That's great.
publication of the RSDA.
Oh, congrats. Very nice.
That's very good. I think that is what was needed for quite some time. Especially, one thing is, North Indians, we are not barefooted walker, but that is one. Maybe we don't get that bad ulcers and neuropathy in our population. Our study, couple of studies we have done, prevalence is close to 15%. I think in southern studies, a lot of your data I have reviewed, there probably neuropathy is much more than in North India. Maybe either by virtue of those living habits, or walking bare, or maybe going to temples and all that. That is not very common in North India. So we people, are physician here, are not very sensitized to this type of examination. I think this can serve a real purpose, especially if it is an initiative by RSSDI. I think it will be a very innovative one.
Thank you.
Dr. Madhu, will you like to comment on that?
No, fine. I mean, what you said is absolutely fine. And Vijay has already told us that something is in the offering, and I think it will be very useful, undoubtedly.
Because
this is an area
you
which is
run
neglected
with
by
such a
most
big center, I'm sure even peripheral neuropathy in your center may not be very high, or foot ulcers, at least typical diabetic foots.
Yeah, but yeah, we do see foot ulcers quite commonly. It's not that uncommon as well, because people tend to dump it on us, na? Then nobody else wants to take diabetic feet.
The private sector people. Maybe, yeah.
So I have a
Your
question.
comments, and then we need to close
Yes.
at 3:20.
Dr. Chavla sir, I have a question. When we talk about oral semaglutide, most of our patients are not tolerating 14 milligrams. So we're going back to 7 and we're struggling with them. So it's the same with my other co-panelists here, that higher doses are not tolerated by our patients. So should we continue 3 and 7 for glycemic benefit, or try to, go to 14, because most of my patients are finding it difficult to go to 14 milligrams. And is there some clinical evidence that this patient will not be able to tolerate a GLP-1 RA? Is it patients who cannot tolerate metformin obviously will not tolerate the GLP-1 RA, or is it some other clues? Because once you start an expensive drug and then you can't build it up, it's like you wasted their money for 2 months when you were giving 3 and 7. Or should we continue with other strategies like alternate day 7 milligrams, or maybe alternate day 3 and 7, or continue with 3?
I don't think there is an alternate day regime of 3 and 7, or alternate day 7 or 14. If obviously 14 is the best dose, but if patient is not tolerating 14, and patient is doing okay with, when you were giving 7 milligram, patient was having good glycemic control and getting some benefits, it is safe to continue 7, then going on 14, and then stopping the drug. What do you say, Dr. Krishna? And
So one thing is, there seems to be no correlation between acid peptic disease and intolerance to GLP-1 RA. I think there have been several studies that have looked into it. This is one. Second is that there are no predictors for intolerance. That is also the second one. That has been also well shown. What I tell patients is get 1 week's worth, right? The one caveat is that we need to be all careful about is that don't say take 2 3s and see what happens, because the snack content of each tablet is fixed, and a higher snack content means the absorption will be low. So which means that if they're going to take 7, they have to take 7. Now, I don't know if the alternate day regimen is interesting, because the data shows that the alternate regimen actually works. There's at least one study that I'm sure nobody wants to see, but there's one study that was published that that the glucose control and the weight loss with the alternate regimen, day regimen, was also the same. Having said that, I have worked with patients, and if they don't tolerate a 7 to 14, I switch them back to 7. But then again, after 2 to 3 months, try to go back to 14, right? The third part is if they're on 14 and you bring them back to 7, there is not much weight gain either. So, I mean, that is anecdotal from my view, but other people have also noticed that even, let us say somebody has lost a considerable amount of weight and you stop them also, that they don't regain all the weight back. So I think while they may not be, it may not be to the benefit of the company for all this data to come out. I think our clinical experience is actually right. So we work with the patient. But the important thing is neither metformin use nor presence of APD is a predictor of whether you're going to get nausea on this. So I think that is something we should be careful, because many times I stop the metformin and see what happens, because the metformin may be causing the side effect. So this is what I do.
So this is a new learning, because I feel for a patient who's not tolerating even a 500 sustained release metformin, I shy away from using a GLP-1 and because I feel if he cannot tolerate metformin, even people who keep on complaining of a reflux, or who say we can't tolerate milk. So you're trying to say it's irrespective, you can try a GLP-1 So this is a message to our audience also, the doctors who are tuning in. Thank you so much, Dr.
We need to close because we have already next session waiting. Thanks a lot, Professor Krishna.
Thank you to all our
Professor
panelists
Vijay,
for joining
Professor Madhu, and Professor Anuj. Thanks a lot for your wonderful
insights.
With that, we go to the next session, and may I invite the chairs for that, Dr. Girish and Dr. Sen Gupta. Dr. Girish, a very close friend, like younger brother. He's a consultant physician and diabetologist, founder and medical director of Vidya Medicare Center, Delhi. And Dr. Sen Gupta, again, a very close friend. For years together, 3 decades we are together. He's a consultant, internal medicine, diabetes and cardiology, and works at BM Specialty Clinic and also at National Heart Institute. So I'll request both of them to please start the session.
Good afternoon, and thank you, sir, for your kind words. Now I'll call upon our for a very interesting session, which is prescribing anti-diabetic drugs in Indian patients. And to start with, our first speaker is Dr. Meena Chavda, and she is a wonderful speaker, and she is presently a chairman RSSDI Delhi chapter from 20 to 23, and she is also chairman of Innovative Physician Forum, and she is a senior visiting consultant and diabetologist at Sir Gangaram Hospital, Delhi. And she has won various awards like Women Diabetologist Award for 2022 from RSSDI. She has a number of publications and awards to her honor, and she has also won the V.D. Kumar Oration Award in 2019 for excellence in field of cardiology. And her center is declared among top 40 centers of India for creating awareness about diabetes through various initiatives during year 2016. So I'll invite Dr. Meena to start her presentation on first topic, which is on metformin. And she will tell us metformin still the queen bee. Over to Dr.
Thank
Meena.
you so much. So I'm going to talk about metformin. That metformin still remains the cornerstone of treatment. And I'll try to, it's not a debate actually while my slides open, but yes, I will try to convince you that queen bee it is, metformin. So, slideshow. So I'll start my presentation, and I like to prove that metformin is still the queen bee. And what is a queen bee? She's the queen in the hive. So first, I'll tell you what are the properties of an ideal first-line oral anti-diabetic drug. It should be potent. That means it should be able to bring down the HbA1c. It should have a durable glycemic action. It should have freedom from hypoglycemia and weight gain. It should not increase cardiovascular events, at least should be neutral, if not reduce them. It should be time tested and should be cost effective. Now, metformin, still recommended by all guidelines as first line of therapy, including our very own RSSDI, the American Diabetes Association, the European Association for the Study of Diabetes, all other associations recommend metformin as the first line therapy. It is still placed first for management of type 2 diabetes by the guidelines. So we all know that if the HbA1c is between 6.5 to 7.5, we start with one drug, which is usually metformin. 7.6 to 9, we start with two drugs, one of them being maximally tolerated dose of metformin. More than 9 and without symptoms of hyperglycemia, we can start with, again, metformin and two other drugs or basal insulin. So metformin in every guideline is there. Now, when we talk about glycemic management, you can see here after lifestyle intervention, we start with metformin. Some people might argue there are side effects, but we build up the dose, give sustained release, try 500, go up to 1 gram and gradually try to give maximally tolerated dose. Now, most guidelines say if the metformin is not able to bring down the HbA1c in the next 3 months to less than 7 or 6.5, you can add a drug depending on what you expect. So if the patient is obese, you want to add a GLP-1 RA or an SGLT2. If there's a risk of hypoglycemia, again, you would like to add drugs which do not cause hypoglycemia. But remember, queen bee has helper bees. But the queen bee is the queen bee. She may need some helper bees at time. Now, just like the queen is the mother of the hive, metformin is the queen queen bee in the hive of various age-related disorders. So metformin in women's health, particularly GDM and PCOS, metformin in metabolic disorders like obesity, dyslipidemia, and non-alcoholic fatty liver disease, metformin in cardiorenal, of course, in tuberculosis and aging-related. Now, metformin acts at each stage in the woman of PCOS by improving insulin resistance. See, in PCOS with menstrual irregularities, improves hirsutism and the irregularity. If the patient has anovulatory polycystic ovarian syndrome, it improves ovulation and increases pregnancy rate. Patients who are undergoing IVF sometimes have over or hyperstimulation of the ovaries, so they prevent that and they increase the incidence of live birth. During pregnancy, reduce miscarriage rate, and in metabolic dysfunction, in PCOS, they help in metabolic syndrome. They improve dysglycemia. Now, coming to obesity, one line will suffice that metformin improves leptin sensitivity and reduces leptin secretion. This results in appetite suppression and decreased food intake. So this is a role in obesity. Again, in dyslipidemia, metformin affects a reduction in LDL cholesterol as well as triglyceride levels. In NAFLD, metformin reduces liver fat content and maintains the reduction in liver fat content when you give it in a dose of 2 grams. Now, this is very important. And in the previous discussion, we were talking about this, that the European Society of Cardiology says that a patient who walks into your clinic, always do 2 things: calculate the EGFR and calculate the ASCVD risk. Now, we have several risk engines. One of them is SCORE2, which is very diabetes specific, unlike the Framingham, which was not diabetes specific. So if the risk is low, so you have a newly diagnosed type 2 obese patient, young executive, and the risk is not very high, immediate risk of developing ASCVD or a 10-year risk is not high, you can safely start with metformin and there's class 2A evidence. However, they go on to say that if there's a high risk of ASCVD, so which means that the patient has not only diabetes, obesity, hypertension, dyslipidemia, family history of sudden death in a first degree relative, or is a smoker, and the risk is high, he may not have atherosclerotic cardiovascular disease or severe target organ damage. But if the score 2, which we are using as a risk engine to quantify risk, and the 10-year risk of developing ASCVD risk is more than 10%, we should start again with metformin, the queen bee, and you can add either a GLP-1 receptor agonist or an SGLT2 inhibitor. But it is this controversy where there's a very high risk. I say controversial because ESC says that if the patient has established ASCVD, you could straight away start, there's class 1 evidence that you could straight away start with an SGLT2 inhibitor or a GLP-1 RA. But my problem is that glycemic benefits with the SGLT2 inhibitor alone are bare minimum, only about 0.5% reduction in HbA1c. GLP-1 RA, I am with it, but because of the cost, it's prohibitive for a lot of our patients. So again, even in patients of high risk of ASCVD, for additional HbA1c lowering, we may need metformin. The queen bee is still required. Now, so these are the guidelines, and I've already talked about them, that yes, a patient who goes to the cardiology, the ICU with an attack, maybe a PTCA was done, or patient had a stroke, or there's evidence of target organ damage, yes, you could start with an SGLT2 or GLP-1 RA monotherapy, but I think metformin needs to be added if HbA1c is above target. So this is the KDIGO treatment algorithm in patients with type 2 diabetes, the kidney disease global outcomes, improving global outcomes. This is the treatment algorithm. It again says that SGLT2 inhibitors may be first-line therapy. But again, remember, doctors, if the eGFR is less than 45, there are no glycemic benefits with SGLT2. Because if there's nothing being filtered by the kidney, how will the SGLT2 inhibitors block the reabsorption of sodium and glucose? Because nothing is being filtered. So up to an eGFR of 45, you can use SGLT2 for glycemic benefits, but below 45, when you use it, you're using it for pleiotropic benefits on the progression of chronic kidney disease. Metformin, again, can be used up to an eGFR of 30. Of course, you decrease the dose once the GFR is less than 45. So this is about metformin, and I think it's talking about CKD stages, and you can see that up to stage 1 and 2, when the eGFR is 90, when it is between 60 to 90, which is CKD2, you can still use it. But yes, between 30 to 60, so 3A and 3B, 30 to 45 and 45 to 60, you have to you have to decrease the dose. In fact, in 3A and 3B, both you decrease the dose. Coming to my important question, is it the time to change clinical position of metformin? We've been discussing, should the guidelines change? Should we say that no? But most treatment guidelines still suggest, like I told you. However, because of newer agents, some have suggested that the modern approach should be based upon identification of etiology and to control the multiple pathophysiologies. So they're arguing that glycemia is not the only thing you address in a type 2 diabetic, but you should also address other risk factors. Let's check through available literature whether this theory of replacing metformin is right or wrong. So we have 60 years of metformin use. It's been used in type 2 diabetes, and it helps in diabetes prevention. I've told you about its use in pregnancy. It's also used, its benefits as an anti-aging in cancer and PCOS. It's an insulin sensitizer and acts on adipose tissue, skeletal muscle, and liver. It acts upon the gut, reducing the appetite. At the mitochondrial level, it activates the AMP kinase, and therefore it acts as a calorie restriction mimetic. Most of our patients don't stop gaining weight. They might even lose some weight with metformin. So it helps prevent weight gain and improves cardiovascular health. And it has been studied as a primary preventive therapy in colonic cancer, as well as an adjuvant therapy in certain cancers. Used in PCOS, in gynecology, a lot of gynecologists use it. Now, glycemic control of metformin is similar to most other anti-diabetic drugs. If you compare these 52 weeks trial versus thiazolidinediones versus DPP-4 versus sulfonylurea, it's an efficacious drug. UKPDS results, we all know that the patients were on metformin And there was a reduction in all-cause mortality. There was a reduction in diabetes-related mortality, as well as reduction in microvascular complications. The macrovascular complications reduced, but did not reach statistical significance, because we all know that to reduce macrovascular complications, we need to control the blood pressure and dyslipidemia and other things. This was the diabetes prevention trial. In DBP, patients in the metformin arm experienced a 31% reduction in the incidence of type 2 diabetes over 2.8 years relative to placebo. So this study proved that if you use, you can prevent progression of diabetes. In the DBP OS, those initially randomized to metformin experienced, now they were no longer on metformin, but they had received metformin. They experienced an 18% reduction in the incidence of diabetes versus the original placebo group at the end of one full decade of 10 years. So pre-diabetes has been put up in the algorithm of diabetes. They say that treat hypoglycemia if fasting is more than 100. And if after diet and exercise, these patients are not maintaining target, then even for pre-diabetes, when the blood sugar is not in the diabetic range, you can start with metformin and of course, egg butters. So there are several cardiovascular benefits of metformin. Several randomized clinical trials involving metformin and CVD outcomes. These were not dedicated trials for cardiovascular disease like the SGLT2 inhibitors, and now we do not expect a dedicated trial with metformin. But these trials involving metformin, you remember all the trials on SGLT2 and GLP-1 RA, majority of the patients had background metformin therapy. So clinical outcomes of metformin use in populations with chronic kidney disease, CCF, and congestive heart failure and chronic liver disease. You see that patients here, even these are sick patients, there is a beneficial outcome even in these patients. This is a systematic review of 17 observational studies, and it shows that you can use metformin even in complicated patients.
So if you could just wind up a little faster, please.
I thought I had 20 minutes. I'm so sorry. Initial choice of oral. I thought I had
15 minutes. No, yeah.
Okay. So use of medication. Okay. So concept of metabolic fulcrum, you have patients who are eubolic, you have patients who are maladaptive and anabolic, and you have catabolic patients. So what I'm trying to say is all your obese type 2 diabetic patients, forget the lean ones who do not have insulin resistance, but your young type 2s with acanthosis, with borderline hypertension, with dyslipidemia are all candidates for metformin. You can calculate the ASCVD risk, and you can't argue that SGLT2 inhibitors do not have side effects. In my practice, because I'm a woman diabetologist, 15 to 18% of my patients do develop genital infections and urine infections. So what I'm trying to hear is that metformin remains the queen bee, does need helper bees. So in order to replace metformin, what we need to show is an a head-to-head trial for my patients, a head-to-head trial with the proposed agent. So do we have a head-to-head trial, metformin versus SGLT2 or metformin versus GLP-1 RA? No. And in a country like India, we all know that we start GLP-1 RA with a bang, but the cost is prohibitive and patients stop taking it. But SGLT2s are not so expensive, but we have to remember with great power comes great responsibility. We have to use it responsibly. Now, side effects are very less. Yes, some patients cannot tolerate even very low doses of metformin, and there you should not do. But you can try sustained release metformin, give it at bedtime, and try to build up the dose gradually, and you can then, kind of help the patient tolerate. Long-term use may cause B12 deficiency, I agree, but you can give it. So give B12. So hardly any issues, unlike the SGLT2. My premise is we cannot replace metformin. It is still the queen bee. It is an old drug for the treatment of diabetes. It also helps in protection of the endothelium. Since you want me to, it's a gold standard drug in managing obese type 2 diabetes patients. And because of its effect on leptin sensitivity, there is some reduction in appetite like the GLP-1 RA. And therefore, what I feel is it's not the time to change the type 2 diabetes treatment paradigm, at least in India. Metformin should remain the foundation of therapy for type 2 diabetics. Yes, patients who are lean and have insulopenia may need sulfonylurea or basal insulin. And those patients who have combined insulin resistance and insulin deficiency may still benefit from metformin and maybe an insulin sensitizer like pioglitazone. So cost of therapy with GLP-1 RA is prohibitive, and we've used metformin very extensively. So I think it still has a major role in our management. So the take-home message is, friends, effect of metformin. It's not a drug with less HbA1c or less efficacy. Unlike the sulfonylurea, we tend to believe no, it can be used as monotherapy. But yes, after various trials, what I feel is that it may be the queen, it needs helper. So in a patient who needs weight reduction, even if the ASCVD risk is not very high, you could add the SGLT2 right from the beginning. If the patient has no weight issues and all you want is better glycemic control and more durable control, you can add a DP4 inhibitor. We had a trial with vildagliptin and metformin. You can do that. These are the updated guidelines which allow complementary therapy. So this is correct. You can use complementary therapy. Metformin has been in use for 60 years. It has demonstrated many positive effects in observational studies in patients with coronary artery disease, heart failure, and chronic kidney disease. So we cannot replace, my talk was, can it be replaced by monotherapy? No, but it can be replaced when, it can't be replaced, but you can add. You can add an SGLT2 if you desire weight reduction. You can add an SGLT2 if you want to address chronic kidney disease progression. You can add an SGLT2 if you want to address cardiovascular, a heart failure, patient has heart failure, you want to address that. And you can add a GLP-1 RA if you want weight reduction, if you want to address long-term ASCVD risk. But metformin is widely considered first-line treatment for type 2 diabetes, and therefore it is referred as the gold standard or the queen bee of diabetes medication. Thank you. I'll stop sharing.
Thank you, Dr. Priya. Now I'll ask Dr. Sen Gupta, my co-chair, to invite the next speaker, please.
Thank you. So at the outset, thank you very much, Dr. Rajiv, Dr. Shalini, and Team CMRE for inviting us to chair this very important session, which would be dwelling on the context of oral hypoglycemic drugs in the Indian context. The second speaker is Dr. Vipul.
Dr. Sen, please unmute yourself.
Okay.
But sorry. So should I start from the beginning? I mean, was I muted all through? Hello?
Yeah, start again. Yes.
Yeah, so thank you, Dr. Rajiv, Dr. Shalini and Team CMRE for inviting us to chair this important session of this particular session, talking about OHAs in the Indian context. And it is my pleasure to invite Dr. Vipul Gupta, who's a consultant physician and diabetologist and an important member of the EC of the Delhi RSSDI, a very close friend. And he's the founder and medical director of the Gupta Ultrasound and Heart Care Center since 1997, which is a multi-speciality hospital, and awarded the Legend in Internal Medicine in 2017 from the Times of India, awarded the fellowship of the RSSDI and the American College of Physicians, and he is presently the treasurer of our branch and the executive committee member of the API Delhi State Chapter, and has 30 publications in national, international journals and chapters in books. He would be speaking on the alpha-glucosidase inhibitors in the context of the Indian patient. So very quickly over to Dr. Vipul Gupta. And just a reminder for all the subsequent speakers, the time allocated per talk is 15 minutes. Thank you.
Thank you. Thank you, Dr. Sen Gupta, for nice introduction. Thank you, Dr. Rajiv and Dr. Shalini, for inviting me to deliver a talk in CMRE conference, which is a very prestigious conference. Dr. Veena has set the context for OADs in the treatment of type 2 diabetes. I'll share the slides first. Is it visible, Dr. Sen?
Yeah, it's visible. You just have to scroll up.
So
yeah, that's fine.
I'll be speaking in next 15 minutes about alpha-glucosidase inhibitor, their relevance in Indian context. The type 2 diabetes management in Indian context is very relevant, as we know that we are more fond of a carbohydrate diet, and the postprandial glucose levels, take a toll on the HbA1c, and we need a molecule which can tackle in that regard. And during treatment of type 2 diabetes and controlling postprandial hyperglycemia, alpha glucosidase inhibitor, which are not that commonly used molecules, are a very good tool. And I would, in next 15 minutes, take you to the journey, how they are important and what is the evidence we have got in the treatment of type 2 diabetes. The flow of talk would be how Indian patients are different, how they are relevant to Indian diabetic patient context, what is the experience and relevant data we have got, and then to summarize later on. As we all know that Indian patients are different, and we are Asian Indian phenotypes are different from the Western counterpart. We have increased insulin resistance, we have a greater abdominal obesity, we all know, higher waist hip ratio, lower body mass index, and that's why we are known as thin fat Indians, and we have low adiponectin levels, which makes us more prone to diabetes and premature coronary artery disease. And if we see what is the role of postprandial hyperglycemia, glycemic response is much higher in Asian Indian compared with the Caucasians, and we have a higher carbohydrate consumption, as I told you, and the greater effect of underlying beta cell cetacean deficiency in Asians. That's why the importance of AGIs becomes even more. If we see the STAR study, which tells us that the carbohydrate diet is the main constituent all across India, and it constitutes around 64% of the total energy from the diet. Postprandial glucose of 62.5% diabetic population was over the target of 180 mg/%. And this was seen not in the northern India as you see or the southern India. It was all across the India subset of patients in the STAR study. And if we see the trend of patients who are taking less carbohydrate diet, their postprandial excursions were less as compared to patients who are taking more than 60% of their energy from the carbohydrate diet. And we all know as the HbA1c is higher, the contribution of the fasting glucose level is much higher. And as we go close to the HbA1c target of 7%, the contribution of postprandial hyperglycemia is much higher. And Indian subset of patient or the Asian patients, if we see here, it contributes to around 80%. The postprandial hyperglycemia is the major contributor factor, and it contributes to 80% of the defect in the HbA1c. So once you are able to control the postprandial hyperglycemia, you are able to achieve the targets once you have fixed the fasting first. And in Indian context, how they are more relevant, if we see just how they act, they inhibit the alpha glucosidase inhibitor, and there are multiple alpha glucosidase enzymes which are present, the glucoamylase, sucrase, maltase, isomaltase, and the acarbose inhibits all these enzymes in the intestine, pancreas, and as well as in the salivary gland. If we compare it with the other AGIs, the voglibose and miglitol, they only inhibit the enzymes in the intestine. It doesn't act on the pancreatic and salivary amylase. So this is much more effective. And because of this effect with acarbose, it delays the intestinal absorption of carbohydrate, lowers the post-meal hyperglycemia, less insulin is needed during the post-meal. So it gives a rest to the beta cell, which is very important, and improves the insulin sensitivity as well. And it also helps in secreting the GLP-1 release from the gut, because the carbohydrate meal goes slowly into the lower intestine where the GLP receptors are situated. And this is what is shown, that the insulin sparing effect helps reducing the blood glucose level, and the serum insulin secretion also becomes less. If we see that these two effects of insulin sparing and the postprandial control of hyperglycemia ultimately translates into a reduction in body weight as compared to the other molecules for the treatment of type 2 diabetes. If we see alpha glucosidase have a weight neutral effect, if we see here, and the hypoglycemic events also are much less as compared to the insulin and the other sulfonylureas. If we see here, it is much less in that range. Similarly, if we see what are the other evidences in the clinical evidences we have got for acarbose in terms of glycemic control, if it's, we see there are the meta-analysis of 46 studies, it causes a reduction of 1.5% of HbA1c as compared to placebo. So there is a difference of 1.02% more HbA1c reduction in with acarbose in the Asian population as compared to the Western counterpart. This is the blue one is the Western counterpart, and this is the Eastern population. If we see the meta-analysis of another study, which was a 12.5-week study. The mean HbA1c change was also high. The postprandial change was up to the tune of 74 mg/%, which was very high in the patients who were also having an Indian subset of patients. If we see the response of HbA1c reduction, we normally have a notion that this is a molecule which is doesn't lower the HbA1c to that level. If we see that DPP4, we all know, reduce the HbA1c from 0.5 to 0.9%. Acarbose as well reduces HbA1c from 0.4 to 1.3%, and similar HbA1c reduction to the other molecules which are available for the treatment of type 2 diabetes. And if we see it, if you combine it with metformin, all the parameters which the metformin does has already been told by Dr. Meena. If we see acarbose reduces the postprandial, very ideal combination with metformin, insulin sparing effect is there, no weight gain, no risk of hypoglycemia, and the cardiovascular benefit, which we'll talk later, also helps in the gut symbiosis, which is also an important factor in the treatment of type 2 diabetes. So all these factors make it an ideal partner with metformin. And there have been studies where the patients who have been added on either with acarbose or drug-naive patient, they have a very good HbA1c reduction and reduction of the postprandial sugar levels. If we see the HbA1c more than 10, the HbA1c reduction is up to the tune of 2.8, and in patients who have a HbA1c of around 7%, still it has a reduction of 0.35%. So it, on addition of metformin, in addition to metformin, this also gives a very good reduction. Similarly, here also from the first visit to the last visit, if we see a postprandial reduction from 60 to 122 mg% was seen over a period of 12 weeks in this GLOBE study. Again, if we see the weight reduction, it was substantial weight reduction also seen in the similar study. If we compare the add-on of voglibose plus metformin with acarbose, it has a much better effect in the HbA1c reduction, fasting reduction, and to our post-meal reduction, which was much better as compared to miglitol. And if we see the available other molecules which are there, this is the meta-analysis of 62 RCTs, and it shows that acarbose has a HbA1c reduction of around 0.79%, which is comparable to all other SGLT2 and the DPP4 inhibitors which we commonly use. So this is a very effective molecule in terms of HbA1c reduction, giving a response in the GLP as well, and the glycemic variability and gut microbiota and CV benefits also. If we see, if the patient is not on acarbose, the carbohydrate would reach the distal small intestine, whereas once you give acarbose, very less is absorbed and more will reach the distal gut where the GLP receptors are present, and they activate the GLP receptors, and this also helps in indirectly controlling the blood glucose levels and gives the rest to the reduces the insulin resistance as well. And if we see the indices of glycemic variability, this is the graph of DPP4 inhibitor alone and DPP4 plus acarbose. This shows the green line is the acarbose, and the flat line indicates that the glycemic variability has become less, much less with once you add patients on acarbose. This is another multi-center trial showing that all the indices of glycemic variability, the MAGE, the standard deviation, and the patient having more time in range was much higher, and the time above range was much lower in patients who were on metformin, vildagliptin plus acarbose as compared to metformin, vildagliptin and placebo. Similar, the coefficient of variant and MAGE and standard deviation was much higherly changed in patients who were on acarbose. If we know that the diabetes and gut are very closely related, and a moderate degree of gut microbial dysbiosis occurs in diabetic patient, decrease in the abundance of some universal gut bacteria also occurs, and there is an increase in the opportunistic pathogen. But if you add acarbose to the treatment, there is a higher abundance of 5 main genera of probiotic gut biota, the lactobacillus and dialister, and lower abundance of 6 other genera, which are not very important. And it ultimately leads on to increase mechanism accounting for diabetes and related metabolic diseases. Gut bacteria use polysaccharide substrates as fuel for the growth and converts it into small chain fatty acids, and which have a beneficial effect on the host energy metabolism. And acarbose is the only AGI, you must understand, that allows polysaccharide to enter the large intestine, and it facilitates production of small chain fatty acid and the hydrogen gas. And this ultimately leads to increase of useful bacteria, which helps in the treatment of type 2 diabetes. If we see what is the evidence of cardiovascular benefits, because the time the acarbose came, there was not dedicated cardiovascular outcome trials which are there. But if we see the STOP NIDDM trial, which is a very important trial, shows 25% relative risk reduction from progression to diabetes, increase in the reversion to normal glucose tolerance in 35%, and it also showed a 49% relative risk reduction of any CVD events. So if we understand that acarbose causes a reduction of postprandial oxidative stress, by which it has a lower postprandial glucose levels, and thus it has a positive effect in the prevention of diabetes and CVD. This is also a meta-analysis to show that the clinical MI and any cardiovascular events were reduced in patients on acarbose. Similarly, if we see this case study where the acarbose cardiovascular evaluation was done in IGT, all the cardiovascular events, the MACE outcome, the death from any cause, cardiovascular death, fatal or non-fatal MI, they were all equivocal, and it was found to be non-inferior as compared to placebo. And because of this evidence-based science and so much of data which is available with acarbose, as compared to voglibose, it causes a reduction of HbA1c to 0.77% as compared to 0.47 in voglibose. It has much more clinical data, and it has been approved in more than 95 countries, including US and Europe, whereas voglibose is not approved by US FDA. And it has a well-documented CV risk reduction, and there's no published data on CV safety for voglibose. Depending on these 25 years of experience with acarbose on Indian patients, India has approved indications. In 1997, it approved the molecule for treatment of type 2 diabetes, and 1999 approved for treatment of type 1 diabetes adjuvant to insulin, and also 2006 approved it for the treatment of impaired glucose tolerance. And all across the globe, acarbose was approved in year 1990 and approved in 117 countries worldwide, which makes it a most widely used AGI and has the widest, longest experience of over 25 years. And if we see what are the guidelines also say in the all other guidelines, and including our own RSSDI ESI guidelines, this would not be a first line or a second line molecule, we all know, because the guidelines now say that you need to look for the comorbid condition and the associated cardiovascular risk, heart failure or CKD in choosing a molecule along with lifestyle and metformin. But once you see that the postprandial hyperglycemia is not controlled, once you have reached a fasting level with whatever molecules you have tried to use, this could be an add-on molecule in a Indian subset of patients where carbohydrate content of the diet is higher and they are using more than 60 to 65% of their dietary resources from carbohydrate. And similar indications are given by IDF and ACE, and the AGI or acarbose fits into all the algorithms, though a little lower down. But in Indian context, I would say it comes a little higher up, and we can use it as early as after the first line molecules. To summarize, that acarbose demonstrate a consistent glucose lowering efficacy across a broad range of patient population, regardless whether the patient is on metformin or DPP-4 inhibitor or SGLT2 inhibitor. This can be add-on therapy to control the postprandial hyperglycemia. Whatever may be the baseline HbA1c, we have seen the higher the HbA1c, it gives you a reduction of up to the tune of 2.4%. And even in lower HbA1c around 7.5, it can reduce HbA1c to 0.7 to 0.8. What may be the duration of diabetes? This doesn't make a difference. This this is effective, because certain molecules, if they are on a longer duration of diabetes, when the beta cells are totally burnt out, may not be that effective. Whatever may be the body mass index, maybe it is a patient who has a higher BMI or lower BMI, the mode of action is such that this molecule would be effective. Any age of patient, it would not cause hypoglycemia and would be effective. Not that you cannot use it in an elderly patient and this would cause more hypoglycemia. So this is a very ideal molecule to control postprandial hyperglycemia. Longer use has been seen. We have used this molecules for now 25 years and this has not failed, and this gives the rest to the beta cells because the mode of action is such that it doesn't allow the carbohydrate diet to pass on to the lower intestine, reduces insulin resistance, can be used in any comorbid conditions, because we have seen the data, though no dedicated cardiovascular outcome trials, but patients who it reduces the 3-point MACE and the incidence of cardiac death in patients who are, high risk for these conditions. Thank you.
Thank you very much, Dr. Vipul, for aptly summarizing the usage of alpha-glucosidase inhibitors in the Indian context. I now hand it over to Dr. Girish Khurana to introduce the next speaker.
So I think next speaker should be speaking on sulfonylurea, if I am right.
Yeah, that's Dr. Pratap Jetwani from Rajkot.
Yeah. So I'll invite Dr. Pratap Jetwani to speak on sulfonylurea. Dr. Pratap is a director and consultant at Jetwani Diabetes Center at Rajkot. He is a visiting diabetes specialist and fellow of RSSDI and Diabetes India. He is chairman of the Gujarat State Chapter RSSDI and presently National Joint Secretary of RSSDI. And he has been a tutor for postgraduate diploma in diabetes course for Leicester University. And he is a editor of Indian Diabetes Educator Journal, associate editor. Over to Dr. Jetwani to speak on this topic on sulfonylurea.
Thank you, Dr. Girish Khurana, for kind introduction. Thank you, Dr. Sen Gupta. Let me first thank Dr. Rajiv Chawla and Dr. Shalini and the team CMERE for making me part of this event. I have been given the task of speaking on sulfonylurea in this year 2023, that how it fares against other anti-diabetic agents. I hope my slides are visible.
Yes, sir, visible.
Okay. So let me start with the facts about diabetes in our country and across the globe. 1 in 11 adults across the globe, they have diabetes. And India accounts for 1 in 7 of all adults living with diabetes in the world. And this is predicted to increase by 69% to 152 million by 2045. Only 1 in 2 people are diagnosed with diabetes. So for every diagnosed patient, there is one patient who is roaming around without diagnosis of diabetes and may land with complications. And it is responsible for around 7.5 million deaths in 2021. So it is a deadly disease and it is a costly affair. India has got second highest number of people living with diabetes in the world after China, and probably we are going to take over China in next 20 years to be the first country having highest number of people living with diabetes in our country. But rather than that, we should focus more on making our country diabetes care capital of the world. Also, the HbA1c control remains very poor in our country. This is the impact data recently released. 2018 mean HbA1c is around 8.56% in our country. And we also know that the higher the HbA1c, the higher will be the risk of diabetes complications. And we know that the burden due to complications, whether it is microvascular or macrovascular complications, is very high as far as public health systems are concerned or the private health practitioners are concerned. We have got an armamentarium of drugs as far as hyperglycemia management is concerned, and sulfonylureas are one of them, and they are age old. We are using them since decades as part and parcel of treatment of hyperglycemia as far as type 2 diabetes is concerned. They remain central to management of diabetes across the world. Even after advent of so many newer molecules, still we rely on these agents because they are the most potent oral anti-diabetic drugs that can lower HbA1c very well. And that is the only function sulfonylureas they have got. They are designed for glucose lowering, and they do that function very well. And we were having doubts about their safety, about their concerns with cardiovascular events, which has been settled to dust with the upcoming evidence in the last few years that I will touch upon in my subsequent slide. So long-term experience with sulfonylureas as second-line agent proves its efficacy, safety, and acceptability, and long-term trends, even in the US, where everything is being sponsored or paid by the insurance company, still sulfonylureas are a part of prescription pattern as far as type 2 diabetes management is concerned. We all know that they are classified based on their hierarchy of development. Either they are conventional or modern. Currently, we are using only modern sulfonylureas, that is glimepiride, gliclazide modified release, or glipizide modified release. Based on their action, they can be divided into short-acting, intermediate-acting, or long-acting. Intermediate-acting are gliclazide and glipizide, whereas long-acting are mainly glimepiride, glibenclamide, and modified release glipizide or gliclazide. They bind to SUR receptor on beta cells and open potassium-dependent ATP channel, and through that, there will be depolarization of beta cell, and that will result in insulin release. Apart from stimulation of insulin release, they do inhibit glucagon secretion by paracrine effects because they increase the insulin release. A paracrine effect, and the adjoining alpha cells, the glucagon secretion will be inhibited. We all know that this SUR receptors, they are present not only in pancreatic beta cells, but multiple other sites, including cardiac muscle, vascular smooth muscle, and brain also. And therefore, all sulfonylureas, they are not the same. They have got different effects on different SUR receptors present on heart and brain. Let's not forget that sulfonylureas, they do not only increase insulin release, they inhibit metabolic clearance rate of insulin. They have got some effect on glucagon secretion. Particularly modern sulfonylureas may improve insulin sensitization and decrease insulin resistance in peripheral tissues. Ischemic preconditioning, some of the sulfonylureas like glibenclamide may interfere with this and may increase the risk of cardiac damage. They have got some antioxidative properties and some modulating properties on vascular health as well as angiogenesis. As far as efficacy is concerned, as I have already told you, agents, they have got efficacy almost comparable to metformin, GLP-1 receptor agonists, and second highest to insulin therapy. And they are much better than SGLT2 inhibitors, glenites, DPP4 inhibitors, or AGIs as far as glucose lowering is concerned. As far as monotherapy is concerned, they can decrease HbA1c to the tune of 1.5% as per the meta-analysis of this number of studies. Even 0.5 milligram per day. This is the Japanese trial where people having mild type 2 diabetes, baseline HbA1c less than 8. There they have used only glimepiride 0.5 milligram per day, and it has reduced HbA1c mean from 7.2 to 6.4 at 4 months without increasing the risk of hypoglycemia and without much weight change. So this low dose sulfonylurea is also very effective, and nowadays we are using this concept of lowest possible dose of sulfonylurea for glucose control in our clinical practice. When it has been added to variety of other treatments, whether it is metformin, glitazone, third drug, or on top of 2 drugs, then they can reduce HbA1c to the tune of 1.62%. These are the variety of trials which are there as compared to metformin monotherapy. When it has been added to DPP4 inhibitor along with metformin, low-dose sulfonylurea, it can provide a better glycemic control as compared to glitazones. As add-on to metformin, they are either comparable or better. And as compared to, as add-on to metformin, as compared to GLP-1 analogs, they are almost equivalent as far as HbA1c reduction is concerned. Even there is data to say that when it is being added on top of insulin therapy, it can reduce HbA1c to the tune of 0.4 to 0.5. So this was about efficacy. I think we all agree that these are the most potent agents and they are serving their purpose because they are being designed only for glucose lowering and they are doing it nicely, very beautiful manner, second highest HbA1c reduction to insulin therapy. There are concerns about safety and tolerability, which I will try to address. Hypoglycemia, I think hypoglycemia is not same with all the sulfonylureas. The modern sulfonylureas, glimepiride and gliclazide, they are much better as compared to glibenclamide as far as hypoglycemia is concerned. This is one of the study which was carried out in fasting Ramadan, and their gliclazide modified release was having hypoglycemia rate equivalent to or better than DPP-4 inhibitor sitagliptin. So as far as hypoglycemia is concerned, gliclazide MR scores much better as compared to glimepiride, which scores much better as compared to glibenclamide or glipizide. So glimepiride as compared to glibenclamide, 6.5 times less risk of hypoglycemia, and at the same time, the efficacy is maintained. The Carolina trial, which has changed the way we look upon sulfonylureas, particularly modern sulfonylurea, glimepiride, which has got the best CVOT evidence or cardiovascular evidence as far as sulfonylureas are concerned. This is only active comparator CVOT trial for DPP-4 inhibitor. One of the trials with the longest follow-up of around more than 6 years may influence the decision-making process whether to use DPP-4 or glimepiride as a second-line therapy. So 6,041 patients with type 2 diabetes, 42% having established cardiovascular disease, another 37% having multiple CV risk factors, early diabetes less than 5 years in almost 40%, 9% they are treatment naive, 0% on insulin, and rest are on metformin therapy. They are either given linagliptin or they are given glimepiride 1 to 4 milligram, and the baseline HbA1c was between 6.5 to 7.5. These were the baseline characteristics. If we see the baseline HbA1c was around 7.2 in both the groups. And if we see the 3-point MACE, it was same. Whether you use glimepiride or you use linagliptin, the hazard ratio was 0.98. So glimepiride and linagliptin, they are equivalent as far as cardiovascular outcomes are concerned in this kind of type 2 diabetic patients who are either having established cardiovascular disease or multiple CV risk factors. So you rest assured that glimepiride do not harm as far as cardiovascular outcomes are concerned. They are equivalent to DPP-4 inhibitors. If we do 3-point MACE, various subgroup analysis, again it is same, elderly people, male, female, prior anti-diabetic treatment, whether sulfonylurea were used or not, background metformin therapy, baseline HbA1c, baseline eGFR, everywhere the results were same. Heart failure related outcomes, that was a surprising outcome. This was the patients who were on linagliptin, they were 21 times at increased risk of heart failure hospitalization as compared to glimepiride. So this is the first trial which settles the controversy that sulfonylureas can increase the risk of heart failure related hospitalization. Rather, glimepiride is rather equivalent to or numerically better, less event of heart failure hospitalization with glimepiride as compared to linagliptin as per the Carolina data. So this is the trial which confirmed that glimepiride had got same HbA1c reduction over a period of 5 years. So again, there were issues that durability is an issue with glimepiride or sulfonylureas. Here, if you see over a period of 6 years, 5 to 6 years, glimepiride is able to maintain that HbA1c nicely in comparison to linagliptin same way. And weight neutral, it is not a weight neutral. There was some weight gain, but the weight gain was to the tune of around 0.5 to 1 kg. So all the issues with sulfonylureas, that they are not durable, they are increasing the risk of hypoglycemia, they can increase cardiovascular events, they can increase heart failure hospitalization, they increase weight gain very significantly. All these, they are issues. They are settled with this one trial, that is Carolina trial, and it concluded that glimepiride and linagliptin, they are similar in terms of CV safety, they are similar in terms of glycemic efficacy, they are similar in terms of what we say heart failure rate, hospitalization numerically better with glimepiride as compared to linagliptin, although this was a post hoc analysis, not a primary outcome of that trial, and hypoglycemia were higher, but they were not increasing cardiovascular events. So that is the beauty of this trial, and it has settled all the controversies related to modern sulfonylureas, particularly glimepiride. The another trial, which is just published, this is a prospective cohort study in patients with type 2 diabetes and chronic heart failure. Although this is a thought-provoking trial, we cannot conclude that glimepiride providing benefits, but at least it is not providing any harm to patients who are already having heart failure. There was a reduction in cardiovascular mortality. There was a reduction in hospitalization and emergency heart failure visit in patients with type 2 diabetes and CHF in people who were on glimepiride as compared to non-glimepiride. However, this need to be proven in a dedicated heart failure outcome trial. TOSCA-IT was a trial which was carried out in Italy, where again, the glimepiride, when compared with glitazone, it was same as far as cardiovascular outcomes are concerned. And in this trial, the most of the patients, they were either on glimepiride or glitazide, and the patients who were not able to maintain HbA1c with metformin, they were either given 5-glitazone or sulfonylurea and followed over a period to find out the outcome or primary cardiovascular outcomes in these two group of patients. So all these trials, they have settled the controversy as far as cardiovascular events are concerned. How can we place? We can use it in the monotherapy in people who do not tolerate metformin and who are having very high levels of blood glucose. Combination therapy can be used, particularly in our country when patients, they are diagnosed with very high HbA1c to the tune of 9.5, 10, to presenting HbA1c. A lot of glucotoxicity is there. There you can use this combination therapy. You can take care of glucotoxicity. You can add other agents and you can gradually reduce the dose of sulfonylurea and maintain the lowest possible dose. Second line, third line therapy can be added as and when the glycemic control is not adequate with the ongoing therapy, particularly elderly people, renal impairment, you have to be very careful. Certain types of MODY and particularly neonatal diabetes, where the sulfonylureas, they are the main choice of therapy because they target that genetic defect. Let's take a look at the guidelines. ADA says that sulfonylureas are recommended as third-line therapy in people with type 2 diabetes, ASCVD or CKD, following the failure of SGLT2 or GLP-1. One should keep in mind in people who are having CKD, if you use SGLT2 inhibitors, they will not provide good glycemic control. And many of these patients will not be able to tolerate GLP-1 analogs also because of the nausea and other things which are happening. So many of these patients, they definitely require either low-dose sulfonylurea or glinides for good glycemic control. IDF says that SUs can be prescribed if metformin is not tolerated as first-line therapy, and they recommend it as a second-line therapy to metformin. All other guidelines like NICE, WHO, ESD, ACE, all they recommend that sulfonylurea can be used, particularly when you require a good glycemic control. So most of these guidelines, they recommend that you can use as add-on to metformin therapy whenever you want a good glycemic control, or even as a third-line agent when the glycemic control is poor. Our own RSSDI guidelines, which focus on ABCDEFGH approach, they also say that the the sulfonylureas, they are the best molecules as far as type 2 diabetes management is concerned because they are efficacious. They have got CV safety, so do not worry about cardiovascular bad outcomes. Overall, the only concern, tolerability is good, and cost, I think it is the most cost-effective agent created so far. The SAFES, the South Asian Federation of Endocrinology Societies, also says that considering their efficacy, safety, pleiotropic benefits, and low-cost therapy, this should be considered as recommended therapy for the treatment of diabetes in South Asia. And modern sulfonylureas, they should be preferred, and particularly start low, go slow. That should be the approach whenever you are using sulfonylurea. So to summarize, I will say SUs are most widely recommended, most widely used, and the oldest molecules, safe, effective, and glucose-lowering drugs, which has a very well-deserved place in the management of type 2 diabetes. Among the various classes, they are most potent, second highest HbA1c reduction after insulin that is possible with sulfonylureas. All the probable controversies with sulfonylureas, that is durability, weight gain, cardiovascular bad outcomes, heart failure, hospitalization, increase, They are settled with correlative study. And definitely they increase the risk of hypoglycemia, but then you have to use it smartly in your clinical practice so that you can give your patients good glycemic control without increasing the risk of major hypoglycemia. With that, I end my presentation, and I will say that in our country, we need to have a cost-effective molecules because diabetes require lifelong treatment, and sulfonylureas are effective, affordable, easily available, very easy to use molecules with moderate risk-benefit profile, so they are to be preferred for management of type 2 diabetes, particularly in our country where cost is
Thank you, Dr. Jethwani, for finishing on time and giving a very beautiful overview of the usage of sulfonylureas in our country and the fact that because of its efficacy and its all the benefits, they are, very safely entrenched in our anti-diabetes practice. So the next talk is by Dr. Purvi Shroff Chawla, eminent diabetologist from Bombay. And she's a consultant diabetologist and director of clinical research at the Lena Diabetes Center. She has been the co and sub-investigator for a number of global and national trials at the BACS Municipal General Hospital. She's also the president of the Santa Cruz Medical Social Association, an active RSSDI social media cell member, an early career physicians council member for the ACP, co-chair for the Diabetes and Women Interest Group, and also won the RSSDI USV Best Innovations Award in Diabetes Care during challenging times of 2020. Numerous other achievements and awards to her credit. She is also a reviewer of national journals, including the International Journal of Diabetes in Developing Countries, which is the RSSDI journal, and also the organizing chairman for the Diabetes Research and Solutions and scientific chair for Women and Diabetes 22 and 21. So may I invite her to do a presentation? I can't see her on the panel.
Yes.
Good afternoon, everyone, and a big thank you to Dr. Rajiv Chawla, sir, as well as Dr. Shalini for having me at CMRE, one of the most watched conferences the world across. So today my topic is DPP-4 inhibitors, safe and simple, and I'm going to really prove that to you that how the statement is absolutely true. And for that, I'm going to use gliptins and DPP-4 inhibitors interchangeably. Okay, so the increasing global prevalence of diabetes has clearly shown us that it is a significant health problem world over, and to individuals, families, and the society. The era of gliptinization, right from 2006, where the first gliptin or first DPP-4 inhibitor got the approval, has ushered in absolutely paradigm shift in the way we look at managing diabetes. So it has changed our perspective. And you can see this is a timeline of anti-diabetic agents and their discovery. And the early 2000s saw a lot of innovation, and that trend has not stopped. So how do these DPP-4 inhibitors really work? Well, in response to an orally ingested meal, the incretin hormones, or the GLP-1 and GIP, which are the incretin hormones, are released from the gastrointestinal tract, and they in turn bring about this stimulation of insulin secretion from the beta cells in a glucose-dependent manner. So, and they also have an effect on the glucagon and inhibit its release, both leading to lowering of blood glucose. Physiologically, they are cleaved by the DPP-4 enzyme, which renders them inactive. And what DPP-4 inhibitors or the gliptins do is they block this enzyme leading to long-term blood sugar regulation and reduction in micro as well as macrovascular events. To just simplify that further, the left graph is one in healthy subjects, where the yellow indicates the rise in insulin in response to an IV glucose infusion, whereas the red is the insulin spike seen in response to an oral glucose load. And this difference is brought about by the incretin hormones. They are responsible for more than 50% of the insulin released in response to a meal. So this is the incretin effect, which in those with type 2 diabetes is quite diminished. And DPP-4 inhibitors block this and restore the incretin effect, or restore it or increase it beyond physiological levels. To summarize as such, the pathophysiological impact of DPP-4 inhibitors, they address 6 out of the ominous 8 of Ralph Diffronzo's octet of all major pathophysiological defects in type 2 diabetes. The effects of DPP-4 inhibitors is far and beyond the pancreas, where it increases the insulin biosynthesis, it preserves or increases the beta cell proliferation, and also decreases the beta cell apoptosis importantly. But the effects are seen far and beyond, even on the brain, in the muscle and adipose tissue, the liver, and important effects even seen in the cardiac tissue as well. On the beta cells, we know it stimulates the glucose-dependent insulin secretion, induces beta cell proliferation, and resists the apoptosis. As far as the alpha cells are concerned, it suppresses glucagon release in a glucose-dependent manner, enhances the glucagon release in response to hypoglycemia, and overall improves the alpha cell sensitivity. This is just a list of the DPP-4 inhibitors, or the gliptins as we call them, available on the market. At least 12 of them are available, and I'm going to show you the data with most of them. And these are the ones in development. So you can see how crowded the space is, but how effective and simple they are, and that's the reason why we're still developing them. The ADA guidelines 2023 clearly reinforce their use and position, whereas first-line therapy or even second or third line, they do have a place in managing diabetes, and so does the RSSDI ESI therapeutic wheel. These are all the available anti-diabetic agents, and DPP-4 inhibitors are right up there. Just looking at the comparative pharmacokinetics, the only thing striking is they're all very well orally bioavailable. The pharmacokinetic properties are such that all of them have to be given once daily, except for vildagliptin, where the T-half is too short and requires twice daily dosing. Again, they are all selective to DPP-4 receptor versus the DPP-8 and 9, and bring about more than 70 to 80% DPP-4 enzyme inhibition or inhibition of the activity over a 24-hour period. As far as efficacy is concerned, DPP-4 inhibitors, it depends on the extent of plasma DPP-4 enzyme inhibited over 24 hours, and at least 80 to 90% of inhibition is required. Higher glucose levels and BMI levels also imply higher DPP-4 activity. Here you can see that sitagliptin is responsible for more than 90% inhibition of DPP-4 enzyme in over a 24-hour period, and most of them bring about 70 to 80% inhibition of the enzyme activity over 24 hours, except vildagliptin brings about more than 90% only when dosed twice daily. Now coming to the efficacy of DPP-4 inhibitors, on the left is a meta-analysis of 83 randomized controlled trials, where you can see that they are all more or less comparably efficacious in terms of HbA1c lowering. However, we see that subsets of the Asian population, particularly Indians, are more responsive or show better reduction in HbA1c at the end of the study. Again, meta-analysis have shown that this may be due to different BMIs or the insulin secretory defect, which is more prominent in Asians, particularly Indians, with the low beta cell mass, higher visceral fat for a given BMI or waist circumferences. Again, whether it's drug-naive patients as seen on the left or metformin-treated patients, adding a gliptin or DPP-4 inhibitor further reduces the HbA1c by 0.5 to 0.8% as monotherapy. Again, in combination with different OHAs or even with insulin, there is a further reduction in HbA1c noted with each of the gliptins, some more efficacious than the other. As far as, there is even a reduction in the insulin dosage seen with each of the gliptins, again, some more than the others. As far as early combination therapy goes, again, there are two major trials which I would like to just quickly summarize here. Verify, the first study that investigated the long-term clinical benefits of early vildagliptin and metformin therapy versus metformin monotherapy, and adding the second drug only based on the threshold criteria. It found that the median time to failure was 3 years with initial monotherapy as compared to 5 years with initial combination therapy, clearly showing us that less patients fail when they are on an initial combination therapy, and that glycemic durability is much better with this, both approaches being safe and well tolerated. The initial trial was a 24-week real-world study to look at the efficacy and safety of the combination of vildagliptin and metformin in drug-naive patients. Again, this study was across South Asia, and they found that initial combination therapy with vildagliptin and metformin in the young drug-naive type 2 diabetes patients was associated with statistically significant reduction in HbA1c that was well maintained, and also with weight control. The Virtue study, vildagliptin experience compared with sulfonylureas during Ramadan, and this was in Muslim patients who were fasting during Ramadan, and again in Middle East and Asia, and they found that with vildagliptin there was less hypoglycemia seen as compared with sulfonylurea therapy in this largely representative cohort of fasting patients with type 2 diabetes, and this was also associated with good glycemic and weight control as well, and overall vildagliptin was well tolerated in this population. As far as glycemic variability goes, again, this is a very important parameter that is coming up. And we can see that as compared to pioglitazone, vildagliptin here brought about meaningful changes in the MAGE or mean amplitude of glycemic excursion, indicating glycemic variability in changes, and changes of standard deviation were also much better with vildagliptin as compared to pioglitazone. The time in range, which is also an important glycemic measure that's coming up, usually measured with continuous glucose monitoring. And we could see here that with vildagliptin as well as sitagliptin added on to metformin, time in range has considerably improved, a little more with vildagliptin as compared to sitagliptin. Even when insulin is used and we add a gliptin to it, well, vildagliptin was associated with an additional 9% increase in time in range when compared to insulin alone. The selectivity profile of DPP-4 inhibitors. Now, to understand the safety of DPP-4 inhibitors, this is an important consideration, and more or less all of them are highly selective for DPP-4 DPP-4 activity as compared to DPP-8 and 9 or FAP, fibroblast activating protein. And why is this important? Because inhibition of DPP-8 and 9 or FAP leads to clinically adverse off-target effects in different tissues like the heart, also the skin and lungs, etc. and we want to avoid them. Another important concept to know here to understand the low risk of hypoglycemia associated with DPP-4 inhibitors is the fact that with hyperglycemia, the level of glucagon is very low with gliptin use as compared to placebo. And in response to hypoglycemia, the glucagon levels are increased as compared to what placebo can induce with gliptin use. And this is an example of when sitagliptin is continued with insulin therapy, there is not only a further reduction in HbA1c, but also there is a decrease in the hypoglycemia events in the sitagliptin plus insulin glargine arm as compared to placebo and insulin glargine. And this is true across a range of DPP-4 inhibitors that the incidence of hypoglycemia is lower and lower with DPP-4 inhibitors and also associated with a reduction in insulin use. Again, the effect is across the group but slightly differential in intensity. Interestingly to note that even in the elderly who are more prone to hypoglycemia, the HbA1c reduction as seen here in 60 to 75 years, 65 to 75 years, and then above 75, the HbA1c reduction has not been compromised at all. But the level of hypoglycemia seen in these elderly vulnerable subjects has been much lower with the use of linagliptin as compared to placebo. As far as drug interactions go, there are clinically relevant drug interactions which are seen with most of the anti-diabetic agents, but not with sitagliptin and vildagliptin. Some amount may be seen with linagliptin and saxagliptin, but no dosage adjustment required with sita and vilda. In CKD, now we know that more than 2 million patients of diabetes have chronic kidney disease, and we can see that across a range of oral anti-diabetic agents, there are lots of considerations and limitations, but with gliptins, they are not only efficacious, but hardly any safety concerns, and some may be used throughout the stages of CKD with some dosage changes. Again, important to note here that linagliptin is the least renally eliminated as compared to all other gliptins, and no dosage may be required, no dosage adjustment may be required in renal impairment as compared to all others. And this is a chart just showing you that across the spectrum of renal impairment, we can use linagliptin safely, but the others may require minor dosage changes. In fact, in renally impaired patients, we can see that the HbA1c reduction or the therapeutic efficacy of gliptins or DPP-4 inhibitors is not compromised. And there might even be a modest albuminuria reduction, even though the GFR and cardiovascular risk may remain unchanged. Again, as compared to other oral medications, gliptins are fairly safe, although vildagliptin and tenaligliptin may not be used in hepatic dysfunction. And with linagliptin, no dosage adjustment may be required, but the others, mild dosage changes may be required, but they may be used. The next special population is the elderly, and this study shows that with the not only the change in HbA1c is statistically significant, but it is durable over 48 months, as seen in this study in elderly type 2 diabetic patients who were drug naive. As far as cardiovascular safety is concerned, this meta-analysis comparing sulfonylureas and DPP-4 inhibitors clearly showed that they are cardiovascular safe. And again, the individual cardiovascular outcome trials have also shown that they were safe. However, saxagliptin was associated with an increase in hospitalization for heart failure. So again, no specific concern with sitagliptin as such. There are no cardiovascular outcome trials with vildagliptin and tenaligliptin, for example, but linagliptin is overall safe. And saxagliptin, I already told you the increased risk with hospitalization for heart failure. Again, there are several studies that show that DPP-4 inhibitors seem to be a promise to represent a promising therapeutic approach for treating vascular diseases in addition to glucose control, because they have beneficial effects in preventing atherosclerosis or even causing endothelial healing and some benefits in dyslipidemia. They are also associated with a reduction in the inflammatory cytokines like IL-beta, IL-1 beta, and this is an important biomarker in coronary artery disease. As far as pancreatitis is concerned, a lot of preclinical studies and work has been done in this regard, and the long-term cardiovascular outcome trials also did not show any increased risk of pancreatic cancer or pancreatitis. So to present a safety summary, I already told you about hypoglycemia. They're also weight neutral in mono as well as combination therapies. We spoke about the cardiac effects, the immune system, there is a reduction in inflammation, and saxagliptin may even induce lymphopenia. Pancreatic cancer and pancreatitis, we discussed, there may be a slight increased risk of acute pancreatitis as per some studies as we have seen. Liver disease again and renal disease, we have already reviewed the same. COVID-19, now this is a special case and across the spectrum of anti-diabetes drugs, DPP-4 inhibitors stood out for being well tolerated and were safely continued throughout COVID-19 in addition to insulin as well. So overall, we have so much of documentation, so many studies, and the global availability of these drugs is also excellent. So indeed, DPP-4 inhibitors are simple and safe. And let me summarize by giving you all the advantages. As you can see in this diagram, it's not just the glycemia, but also anti-inflammatory, beta cell protection, repurposing even for COVID-19 may be possible, safe in elderly, etc. All these advantages are there. And very quickly to summarize, highly efficacious oral drugs that positively impact glycemic control, durability, glycemic variability, time and range as monotherapy, add-on therapy, combination, early combination, and other situations as well. They address at least 6 major pathophysiological defects in type 2 diabetes while preserving beta cell function. They are associated with minimal hypoglycemia risk due to the action on glucagon as well. They are weight neutral or even cause weight loss. They're cardiovascular safe and have some benefits in cardiovascular disease and may be safely used in special situations like chronic kidney disease, liver disease, and also in the elderly population, associated with pleiotropic benefits as we've discussed, and overall safe and well tolerated with low risk of pancreatitis and no risk of pancreatic cancer. So I'm sure you will agree with me at the end of this. And once again, I thank Team CMRE very much for this patient hearing.
So thank you, Dr. Purvi, and all the speakers for doing a very comprehensive overview of drugs used in the Indian context. We are running woefully short of time and being instructed by Dr. Chawla to just wind up. A quick word from Dr. Girish Khurana, and then we wind up this session and over to the next session. Thank you very much.
Thank you, Dr. Sen. It was great listening to all the speakers, and they have done justice to their topic. And we have been using all these drugs, and the only message which we would like to give that one should use the drugs judiciously in sulfonylurea chapter and according to the comorbid condition. That's all I want to say, and let's wind up.
Yeah, the guidelines, the guidelines are there, but we have to see our own patients and tweak the treatment accordingly as per the clinical situation. So thank you very much for the patient hearing, and over to the organizers and Dr. Chawla. Thank you.
Thank you, Dr. Sen. Thank you, Dr. Girish, and all the speakers, Dr. Pratap, Dr. Purvi, and Dr. Meena. I think they've done a wonderful job. With that, we go to the next session, that is is to be chaired by Dr. Maria and Dr. Vipul Gupta. Dr. Vipul is a founder and medical director, Gupta Ultrasound and Heart Care Center in New Delhi. Dr. R.K. Madia is a consultant physician and diabetologist at National Heart Institute and Maria Clinic, Hoskas, New Delhi. And both of them have been very, very close friends over the last 25 to 30 years. So over to you to please conduct the session smoothly. And I welcome Dr. Vijay Panikar and Dr. Neglur also. Thank you.
Thank you, Rajiv. Thank you.
Thank you, Doctor. I think Dr. Vipul is not visible, so I'll start the session. Thank you, Dr. Rajiv, Dr. Shalini, and the CMRE team for giving us this opportunity to be involved in this prestigious conference. And we'll now request the next speaker, Dr. Vijay Panikar. He'll be talking on in-hospital hyperglycemia management. As you all know, the chances of a diabetic getting admitted in a hospital is more frequent than a non-diabetic, maybe for surgical, medical condition, maybe critical or non-critical. So let us listen from Dr. Vijay Panikar. Dr. Vijay Panikar is a MD, DNB, FRCS London. He's an honorary consultant, endocrinologist at Lilavati Hospital, Mumbai. He has been ex-professor of medicine at KJ Somya Medical College, Mumbai, ex-president Research Society of Study of Diabetes in India, and all other laurels are in his name. And he has a number of publications to his credit, including in books and journals. So over to Dr. Vijay Panikar. We'll be talking on in-hospital hyperglycemia management.
Thank you very much, Dr. Maria, for a kind introduction. At the outset, I must congratulate and thank Dr. Rajiv Chawla and his entire team, including Shalini, for having invited me to give a talk on in-hospital management. Let me just share my slides, please.
Sir is a lead author for in-hospital hyperglycemia management guidelines in 2016 in IJJDC journal. Over to you, sir.
Can I share the slides? Have I been given the sharing facility?
Yeah, it is with you. The green button at the bottom, share screen. Neelam, can you help, sir?
Yes, sir.
There is no green button at the bottom here.
Yes, sir. There is a green button. Green button.
Yes, now I.
Yes.
Can you see my slides?
Yeah, we can see. Put it in slide mode, slide presentation mode, sir.
Can you see the full slide?
Not yet.
Not the full.
Can you see it?
No, it's not the full screen, is it?
Now? Now is it the full screen?
Not yet, sir.
Does the slide move?
Let's try move it, then only we'll come to know.
No, I have moved it.
No,
It's
sir.
not moved. Not
just unshare and share again, sir.
Okay.
Just unshare and share again, sir. Now.
Okay. Share.
Yes, sir. Now it is in slideshow.
That's
Visible?
good.
Yes,
Yeah.
sir. Done, sir. Perfect.
Right. This was the RSSBI clinical practice recommendation for management of in-hospital hyperglycemia, which was published in 2016. And it's part and parcel of that particular clinical recommendation. So basically, to introduce the hyperglycemic burden in hospital setting will be seen classification of hyperglycemia during hospitalization, the glycemic monitoring, and the targets recommendation based on landmark clinical trials. Basically, if you look at the burden of hyperglycemia in the hospital setting, it's roughly about 25% of 12 to 25% of patients admitted to hospitals will turn out to have hyperglycemia. And hyperglycemia in the hospital has been defined.
Join kar le, 15 minute mein unka session aa gaya.
Rajiv,
ये
Rajiv, you're mute karo.
Rajiv, mute yourself. Rajiv, mute yourself.
In hospital has been defined as any blood glucose more than 140.
अच्छा, busy थे क्या कैथ लैब में?
Rajiv, can you switch off your audio?
कहाँ?
Rajiv, can you switch off your audio?
Sorry, sir.
What is the impact of hyperglycemia? If you see hyperglycemia and ICU mortality, as the blood glucose levels go on increasing, you will find the mortality levels go on increasing. It's a direct correlation. This has been studied, shown in 2003 by Kingsley. What about the hyperglycemia and rate of infection? Post-CABG, what they find is if the sugars remain above 200, the chances of a sternal wound infection increase. What about the hospital mortality? Now, when you have compared to a normoglycemic, which is in red, a non-diabetic, which is a light blue, and a new hyperglycemic, newly diagnosed hyperglycemic, and what they have seen is that the maximum mortality is in the newly diagnosed diabetics. Now, this was a study done way back in 2002. And I remember as a postgraduate, when we had some patient who was newly diagnosed as diabetic, our teachers would say, oh, kuch nahi, this will be all right, nothing to worry. And it was taken lightly. And that is probably the reason why mortality used to be high. But I think today that scenario is different. So whenever you look at the etiology of hyperglycemia in a hospitalized patient, there are basically three. You could have a previously known diabetic who gets admitted, who gives you a history that I am diabetic. Previously undiagnosed, he is for the first time discovered to be a diabetic during hospitalization, and a stress hyperglycemia. And how do you really distinguish? Previously diagnosed with an existing hyperglycemia, which is prior to hospitalization, which you know from the history. When you have at admission a sugar fasting more than 126, random glucose more than 200, but an HbA1c more than 6.5 tells you that this is an undiagnosed diabetic. But if you have the same format here in a stress hyperglycemia, you will have fasting more than 126, random more than 200, but the HbA1c will be less than 5.7, telling us that he was not a diabetic before. This is probably a stress-induced diabetes. So getting an HbA1c done in all patients at admission where you have suspecting diabetes, it will tell you a lot of good things. It will assess the glycemic control prior to admission. Somebody who has a high HbA1c, we know he's had poor control at home. It will assist with differentiation of the newly diagnosed diabetic from stress diabetic, stress hyperglycemia. And it could obviously felicitate the design of optimal regimen at the time of discharge, because you know at home he was not controlled. So recognition of inpatient hypoglycemia, do a lab plasma glucose testing for all patients at admission. If the blood glucose is more than 140 in a non-diabetic patient, monitor with capillary blood glucose for 1 to 2 days to see whether this was just a random 140 or really is he a diabetic. You can monitor capillary blood glucose 1 to 2 days in non-diabetic patients who are on glucocorticoids, octreotide, enteral or parenteral nutrition. And patients with diabetes stress hyperglycemia, assess the HbA1c if unavailable in the preceding 2 to 3 months. Do an HbA1c. And how do you really monitor? A bedside capillary blood glucose is the preferred method. You can use consistent site and device. And when do you do it? In those who are eating, generally test before the meals, before breakfast, before lunch, before dinner. And it should not be earlier than 1 hour before the meal. And you can also do one test at bedtime, or a postprandial test can also be done. But those receiving enteral or non-parenteral who are NBO, milk by mouth, you should do it at least every 4 to 6 hours. And you need to do this more frequently if you have a continuous insulin infusion, patients on glucocorticoid use, where there's an abrupt stoppage of enteral nutrition, because many of these enteral nutrition have a good glycemic load. And all those patients who have frequent hypoglycemia need a more frequent monitoring of their blood glucose. So basically, the recommendation for in-hospital management of diabetes is classified into 3 categories. the critically ill, that is in the ICU, non-critically ill, that is the non-ICU patients, and special circumstances, perioperative conditions, patients with enteral parenteral nutrition, patients on glucocorticoid therapy, patients having CKD, transplant patients, peripartum situations. So these are special circumstances. I obviously, for shortage of time, would not be able to cover all of them, but I will go quickly through critical illness patients. And what really started this thing about glycemic control in the ICU? It was Greg Vandenberg's paper, which showed us that if you keep the blood glucose level strictly between 80 and 110, there was a significant decrease in mortality by 34%, sepsis reduced by 46%, renal failure by 41%, need for blood transfusion by 41%, polyneuropathy by 44%. But this success of tight control was basically in a surgical ICU. All these patients were on a ventilator and they were on a Riles tube feeding. So all the other parameters were constant. The feed was constant, patient was on ventilator, and they could achieve these targets of 80 to 110. So then Vandenberg did a confirmatory study in the medical ICU. And this time the results were less clear. Overall mortality was not improved by this intensive insulin therapy. And in fact, more deaths occurred in the intensive group and among patients with those with ICU stay less than 3 days. So these are some of the RCTs which showed that a tight glycemic control of 80 to 110 is not really beneficial at all. Then came the NICE study which compared the tight glycemic control where the goal was to keep it between 81 and 108 and the mean blood glucose achieved in them was 118 as compared to a more relaxed less than 180. That was the conventional glucose where the mean blood glucose achieved was 145. And they showed that the ones who had tight control of less than 110 had an increased mortality. So based on all this, the NICE sugar study, the ACE and ADA guidelines, what are the glycemic targets? The glycemic targets for the ICU setting is 140 to 180 milligram per deciliter. In the non-ICU, fasting 80 to 120, a pre-meal about 140, and post-meal less than 180. These were the targets which were set. Now, managing patients with ICU, critically ill. Here we would look at insulin IV protocol, starting insulin infusion, adjusting the dose, and the recommendation for limited care, which I have. So basically, what is our objective when you're treating a patient in the ICU? You want to restore stable glycemia. You want to minimize disruption of the metabolic state, and you want to minimize the adverse outcomes. That needs a good glycemic control. So for majority of critically ill patients in the ICU, insulin infusion should be used to control hypertension. A blood glucose more than 180 should trigger insulin initiation. I repeat it. A blood glucose more than 180 should trigger insulin initiation. Once the IV insulin is started, the glucose level should be maintained between 140 and 180. So your trigger is 180 and the maintenance is 140 to 180. There are several protocols. Yeah. There are several published protocols for insulin therapy, but basically the exact protocol is probably less important. What is important? It is presence in an institution and adaptation to individual hospital needs. So every hospital should have an IV insulin protocol. So we have an IV insulin protocol in our hospital, which was prepared by us, and it's basically based on our guidelines here, wherein we use an insulin pump where we use 50 units of regular insulin and 50 ml of normal saline, which will give you 1 ml is equal to 1 unit. And generally a short-acting regular human insulin is used. There is no indication to use a short-acting analog when you're giving intravenous. and your main primary target is to maintain the glycemia between 140 and 180. Now, how do you start this insulin infusion? You need to give a priming bolus of regular insulin. That would be about 0.1 units per kilogram body weight if the blood glucose is above 300. So 0.1, suppose it's a 80 kg man, you will give 8 units of regular insulin as an IV bolus if the blood sugar is more than 300. If not, if it is less than 300, you do not have to give a bolus. So infusion titration, the initial infusion rate would be the current blood glucose minus 100. I'm giving you the example here. So it is current blood glucose is 200. Initial infusion rate would be 200 divided by 100. That is 2 units per hour. So that is 2 ml per hour because each ml is 1 unit. And now how do you really adjust this? You do an hourly capillary blood glucose. And what do you look for? The current capillary blood glucose level, compare it with the previous capillary blood glucose level, and look at the current rate of insulin infusion. The rate of change or lack of change between the current and the previous blood glucose reading is what will guide your titration. So if the blood glucose increases compared to the prior capillary blood glucose, you have to increase the infusion. How much to increase, I will tell you in the next slide. If the blood glucose comes down by less than 30 milligrams from the previous capillary blood glucose, you have to increase the infusion. If the blood glucose comes down by more than 30 from the previous blood glucose, the same infusion will continue till the blood glucose comes down to below 180. So basically, you're looking at the change in the current blood glucose compared to the previous one. If it increases or if the change is less than 30 milligrams, you have to increase the dose. If it is more than 30 milligrams, you have to maintain the same dose till it comes down to below 180. And this is a beautiful adaptation from Guillermo, which we have modified a little. If the blood glucose increases or decreases less than 30 and the sugars are about 240, you increase the rate by 3 units. If it is between, it is 240, 211 to 240, 2 units, and 180 and above, it is 1 unit. If the decrease is greater than 30, no change till it comes down to 180. Then if it comes to below 180 and the decrease is by 30 to 50, reduce it by 25% and so on. But once it comes down to below 140, you reduce the rate to 50% of your previous dose. If it comes to below 110, you suspend the insulin. And what do you do then? You just suspend the insulin, wait for the sugars to come up above 140 and restart the insulin infusion at 50% of the previous dose. Now, if it goes to below 90, you suspend insulin and you check the sugar every half an hour till the blood glucose goes above 90. And then you can check after 1 hour and you restart infusion at 50% of the previous rate. Now, hypoglycemia. I'll just show you the previous slide. If it goes to less than 70, suspend insulin and you give 25% dextrose. But how much do you give? Most of the times I have seen in the ICU, they say, all right, give 50 cc, 25% dextrose, or you give 100 cc. No, it has to be a calculated dose. Otherwise, you will get a rebound hyperglycemia if you give excess dextrose. So there the dose would be 100 minus the current blood glucose multiplied by 0.8. So this is how it is. Suppose the current blood glucose is 40 milligrams. You will give 100 minus 40 into 0.8, and that is 60 into 0.8. That is 48 ml of IV 25% dextrose. You will repeat the blood glucose after 15 minutes until the blood glucose goes above 70. If it has not gone above 70, if the blood glucose is still below 70 after 15 minutes, you will repeat the same formula and give 25% dextrose as per the calculation. Again, check in 15 minutes. If it has gone above 70 milligrams, You will now check the blood glucose once in half an hour till it goes above 90. Once it goes above 90, then you will check hourly, hold the infusion. And once it goes to above 140, restart the infusion at 50% of the previous rate at which it had gone into a low sugar. So this is the way it works. And in fact, we have an app called Inspro, which can be downloaded from the Play Store, and it works beautifully with this. Now, how do you transition? You have the patient in the ICU, and he is now improved. He is probably eating regular meals, and he's been transferred to low intensity care, or maybe even transferred to the wards. So transition of insulin infusion to subcutaneous and or oral is our next thing. So how do you really say when is it safe? When you have a stable blood glucose less than 180 for at least 4 to 6 hours. The blood glucose has been stable on an IV infusion. There is no acidosis, even decay. The patient is hemodynamically stable without use of vasopressors. Whenever you give vasopressors, the blood sugars can really go up. Noradrenaline pushes up the blood glucose tremendously. So patient should be off vasopressor before you decide to shift from the IV insulin to a subcutaneous. There should be a stable nutrition plan. That means the patient should be eating and drinking normally. Stable IV drip rate, low variability. And transition is successful when the blood glucose is between 140 and 180 with an insulin drip rate generally below 2 units per hour. And transition can be very challenging in the elderly patients, patients with high pre-admission HbA1c, with high variability of blood glucose in 24-hour preceding period, and patients who are on corticosteroids. You can have wide excursions of the blood glucose there, and you may still need to continue with the IV insulin. And that is what is needed for it. And that total daily dose is divided into 50% basal and 50% bolus. So basal insulin inhibits gluconeogenesis, bolus is the nutritional, which facilitates the postprandial rise of glucose, and you have a correction insulin. I'll discuss that just now. The safest method to calculate total daily dose is to find a time interval of several hours, 4 to 6 hours in the infusion which is going, where you have a 4 to 6 hours window where the sugars have been decently controlled between 140 and 180. These are the blood sugar values which are stable and at target. So insulin requirement during this stable period can be extrapolated to a 24-hour period. That's how you calculate the total daily dose. So if you consider that in the last 6 hours, the total requirement in the 6 hours where the blood sugar was stable was 10 units, then 6 hours into 4 would be 24. So total daily dose is 10 into 4, that is 40 units. You take 80% of that, that is 32 units, and you will give 50% as basal and 50% as bolus. So 50% basal can be a long-acting glargine or detimol, which will be once a day dose, or intermediate acting, which would be NPH, you can give twice a day. 50% bolus is divided into 3 equal doses of short or rapid acting insulin. So for example, you could have a glargine at 16 units or an NPH insulin 8 in the morning and 8 in the evening, and a short acting insulin or a regular analog at 5, 5, 5. So that 16 has become 15 here, but that is the split. And then you monitor the patient and do the correction. Now, before you shift from the intravenous to the subcutaneous, you have to be careful because the half-life of IV insulin is less than 5 minutes. So to prevent recurrence of hyperglycemia during the transition, insulin infusion should not be stopped after the subcutaneous dose is given. In fact, it should continue. If the patient is on a regular insulin or rapid-acting analog, which have injected subcutaneously, continue the insulin infusion for at least 1 to 2 hours. Otherwise, you will get a severe hyperglycemia the moment you stop insulin, and again, everything will go haywire. If it is a long-acting insulin which you are injecting, continue the insulin infusion for 2 to 3 hours. Now, correction bolus. Now we have done that. We have got boluses 3 times and we have got basal, which is once or twice. And then we do the sugar checking pre-meal. And if the sugars are high, you have to increase that blood glucose based on a correction factor. And what is this correction factor? It is the degree of blood glucose lowering expected with 1 unit of insulin. So correction factor is, if you're using an analog insulin, it is 1800 divided by the total daily dose. For regular insulin, it is 1500 divided by the total daily dose. And the correction dose is actual blood glucose minus 100 divided by the correction factor. So to just give you an example, total daily dose is 30. Your estimated blood glucose is 250. 1500 divided by 30 is 50 units. 250 minus 100 upon 50 will give you 3 units. So the total meal dose would be 5, which you're already giving, plus 3. That would be 8 units would be done. And next day, that becomes your standard. Now, in a patient transition in stress hyperglycemia, if the patient requires less than 1 unit per hour of IV insulin, it is prudent to monitor blood glucose level and institute subcutaneous level insulin only if blood glucose levels are consistently above 180. Otherwise, you can wait and watch, because there is stress hyperglycemia which may resolve by its own. So again, here the targets of blood glucose are 140 to 180, which we had discussed earlier. The role of oral anti-diabetic drugs and non-insulin injectables in non-critically ill patients. Once the patient is stable, he has shifted out of the ICU, he is in his ward, he is eating normally. You could use oral agents, but these will present certain challenges in the hospital setting. In many inpatients who have sepsis, who are kept nil by mouth, who are going to have an IV contrast preparation, you would prefer to avoid the oral hypoglycemics and still continue them on insulin. So transition to OADs, patients on normal diet, blood glucose is stable with no ketosis, post-surgical where expected tissue damage is minimal, and no serious comorbid conditions. The selected patient may be candidates for continuation of previously prescribed OAD in the hospital, whatever they were taking, because those who are clinically stable and eating meals having no contraindication, you can go back to their original thing, but with a caveat that since he is in the hospital, he may not eat as well as he was at home, or will not get such a variety of food that he gets at home. Be slow in terms of sulfonylurea. Sulfonylurea or the magnetides can lower the glucose rapidly, and that is a big risk of hypoglycemia. There are only 2 molecules which will cause hypoglycemia, sulfonylurea and insulin. So you have to be careful with sulfonylurea. AGI, efficacy and side effects limit their use because patient has just recovered, he may get gaseous distension, bloating. So you don't want to do that. Patients on metformin, DPP-4 inhibitor, SGLT2 or glitazones before admissions. These agents are often restarted in the post-op period where hepatic and renal functions are stable. So if hepatic renal functions are stable, patient is eating normally, he has been taking these drugs at home, it can be safely restarted. Caveat is be slow on sulfonylureas. Now the discharge planning. I have shortened the whole thing. Discharge planning from the hospital. Whenever you are looking at discharging this patient, you have to look at whether he is a previously diagnosed HbA1c diabetic. If he is, assess his level of control, which the HbA1c will tell you. If it is good HbA1c, you may continue his own treatment. Adjust the therapy as needed, assess complications, and call in for an outpatient follow-up. If he is a previously undiagnosed diabetic, confirm the diagnosis, implement therapy and proper patient education, and you can go ahead. Stress hyperglycemia generally resolves in hospital and requires follow-up testing. So basically, the protocol for discharge would be HbA1c should be a very important factor in taking that decision. So in a previously diagnosed, if his HbA1c is less than 8, you can continue his pre-discharge medication, whatever he was taking at home. If the HbA1c is more than 8, you need to intensify the treatment with OHA and insulin. If HbA1c is not available, look at the glycemic control. If the glycemic control in the hospital on his pre-admission treatment is good, reintroduce the pre-admission treatment and let him continue. And he can get back in the outpatient and report. If there is poor glycemic control, intensify the pre-admission treatment. If you have a previously undiagnosed patient, HbA1c 6.5 to 7, institute lifestyle modification, metformin, and follow-up. And if he is confirmed that he is diabetic, you may add some more OHS depending on your discretion. Continue treatment with OHA insulin as per guideline. Stress hyperglycemia, maintain follow-up, treatment as per recommended pre-diabetes. Now, on discharge, review self-management of the patient, educate the patient well, issue discharge summary with clear instruction, discuss about prescribed drugs, instruct on SMBG and keeping a proper record and being in touch with us on a regular basis. Whenever a patient is discharged from our hospital, the number of our resident is given to them and they are asked to do their SMBG and report back for help, and which we do on a very regular basis in our institution. Clear instructions regarding insulin treatment, dose, technique, frequency, various formulation. Patient should be taught how to take his insulin properly if he is on insulin, the dosage adjustment and the frequency. They should be also instructed regarding management of hypoglycemia at home, how to prevent or minimize the risk of hypoglycemia. That is, take your medicines on time, have your food on time, do not delay your food, do not miss your food. All these advices have to be given before the patient goes.
Dr. Panikkar, please try to conclude.
Yeah, this is the last slide. Discuss regarding blood glucose targets required for good control, importance of regular follow-up. So basically, in-hospital management is unique in itself, but it can be done properly with the due things which we have. Thank you very much. Thank you, Dr. Madhav.
Thank you, Dr. Vijay Panikkar, for a brilliant talk telling us about how to manage our patients with hyperglycemia who are admitted. And you have very nicely and very simply, in a very simple manner, you told us about the patients who are previously diagnosed, previously undiagnosed, or stress-induced diabetic. You have told us about the targets which we need to achieve in both critical and non-critical patients, and how to introduce insulin and then transition from insulin to the oral medications. Thank you very much for a brilliant talk, sir.
Thank you.
We'll have the question answer session in the discussion. So now I'll request my co-chair, Dr. Vipul Gupta, to introduce the second speaker. I think Dr. Vijay Train is not available. So I think Dr. Vijay Naglur will be there. Dr. Vipul Gupta, please.
Thank you, Dr. Madia. Now we have our next speaker, Dr. Vijay Naglur. He is MBBS, MD Medicine, Fellow of Diabetes UK. Dr. Vijay Naglur is the co-founder of and Medical Director at Naglur Diabetes and Thyroid Specialist Center. He is an honorary associate professor of medicine since last 20 years at Rajiv Gandhi Medical College. He is currently one of the leading teachers in PHFI Public Health Foundation of India. He is on the advisory board of various Indian and international pharmaceutical companies, and he has earned the title Syndrome Man and Gentle Giant of Diabetes by his students and colleagues on account of his impressive diagnosis and treatment. Dr. Vijay Naglur would be speaking on, do we need extra care in elderly patients with diabetes, because this is a very important subset of patients. And I would request Dr. Vijay Naglur for his talk, please.
Thank you, Dr. Vipul Gupta, for your kind words. Let me share my slide. My slides are visible? My slides are visible?
Yes.
Thank you. So thank you, of course, Dr. Vipul Gupta, for your kind words. And I must say that I must express my thanks, sincere thanks to Dr. Chawla and Dr. Shalini Jaggi for a kind invitation to talk on a very relevant and interesting topic that we need extra care in elderly patients with diabetes. That's what today's talk is. And this is a lady called Marjorie Warren, who was the first surgeon and a geriatrician and considered to be mother of a geriatric medicine. In 1950, she was one who was responsible for making a geriatric medicine as a part of training to the various patients who are more than 65 years of age. So I pay tribute to this lady who was responsible for taking care of the elderly population. The roadmap for today's discussion is the burden of diabetes in elderly population. I'll talk about, is it necessary to look into these groups separately, the challenges in the management of these people, and pharmacological approach in these patients. So we see that longevity is rise in India. In 1961, we had the expectancy survival was 42 years. In 2018, it becomes 69. And 2050, we expect to have the expectancy of survival of 76 years. In other words, the Indian population is growing at 3 times higher rate than the entire population. And the life expectancy is going to rise from 18 and 77 years respectively to the projected 21 to 8.5 years by 2050. So that is what we're going to have, an expected rise in the life expectancy of people. Now, if you look at the burden of diabetes in the elderly population, in 2019 it was just 9.3 million. In 2030, it is 10.2% of the population. That means from 136 million to 195 million. That's the population burden that we're going to have in the globe. Talking about India, above 65 years, there's a 50% of the patients of diabetes fall in the group above the age of 65 years. And if you look at the 5 top countries with the elderly population of diabetes, India stands third after China and USA, and then followed by Germany and Brazil. So we have the rising population of the elderly in the diabetes segment. Why is it important to consider the elderly as a separate group? The reasons are that the pathophysiological links between aging, obesity, and type 2 diabetes is very important. If we look at aging, it contributes to multiple factors. Namely, you have sarcopenia, you have the skeletal muscle dysfunction as you start aging, and then you have frailty also as a part of aging. There's a central obesity in these patients. They have malnutrition because either they stay alone or they have a poor appetite. There's no one to take care of them, and they have physical inactivity as a part of the osteoarthritis, or they have other problems of mobility. And then they have also a matter of obesity, which is probably because of the lack of physical activity, and therefore they also have central obesity, and that's why they have a chronic inflammatory state, and that brings in beta cell dysfunction. What actually it results in? The aging results in the poor secretory function of beta cell, because the aging process itself, and the adiposity brings about insulin resistance. So both put together, you get chronic hyperglycemia and the micro and the microvascular complications. Therefore, the pathophysiological links between aging and obesity and diabetes is that the aging causes progressive worsening of diabetes because of the beta cell decline. There's acceleration of the pathophysiological process because of adiposity and the insulin resistance and the pro-inflammatory pathways in the adipose tissue and the muscles. The skeletal muscles and beta cell function is lost, and therefore you have a progressive micro and macrovascular complications, along with other geriatric comorbid conditions, which we'll study in little more detail as we go along. Okay, so common condition that you see in the elderly population is 60% of the elderly population will have at least one comorbid condition, like their cognitive decline, polypharmacy. More than 4 drugs is what generally is prescribed in this population, disability and depression. And if you look at the 40% of these population, they have concurrent illnesses, namely urinary incontinence, hearing and the visual impairment, falls and fractures, and the cardiovascular disorders. So therefore, these are the conditions which coexist, which makes the treatment of diabetes difficult. Now, the presentation-wise, they're a little atypical. you don't get osmotic symptoms in these patients. That's because there's the increased threshold of the kidney for the glycosuria. And therefore, the patients do not have the manifestations of polyuria. They also have impaired thirst because of the hypothalamic dysfunction. And in the supraoptic region, we have a thirst center, which also is affected. So therefore, they do not have symptom of polydipsia. 50% of these patients are asymptomatic, like any other diabetic patients of type 2 variety. And if they have symptoms, they're non-specific. They complain of fatigue, lethargy, and usually mistaken for aging, anemias, thyroid disorders, so on and so forth. And diabetes-related complications such as visual loss, neuropathy, and unexplained fall may be the first presentation that these patients can come to you. And the diagnosis is best made by a 2-hour plasma glucose, 2-hour oral glucose tolerance test is the right way to make a diagnosis because the fasting sugar is usually normal and the A1C is not reliable in elderly population. It is less sensitive. In addition to that, you must always remember in mind that you should screen for the complications of diabetes. When you diagnose diabetes for the first time, maybe the vascular disease, the physical and neuropathic function, and the mental cognitive function should be screened every time you see diabetic patients. What is again very important aspect in the elderly populations of diabetes is that there is what is called as the reciprocal and the synergistic relationship between the mental dysfunction, physical neuropathic complications, and a vascular disease. There's a bilateral or a bidirectional relationship with each other. For example, a patient with dementia can have a physical and neuropathic complications, and they also can have frailty. Or they have vascular complications like microvascular disease will lead to, again, a fall because of neuropathy. And therefore, retinopathy, neuropathy, all these complications have a association both forward and backwards between these three problems. They are synergistic and reciprocal. And that brings about disability in the visual loss, immobility, and falls. These are the other peculiar problems that you see in the elderly population. So what are the challenges that you have? The first challenge that you have is the progression of the diabetes and its complication, and there is a coexisting geriatric syndromes, and the facility of setting the processes is also important. And these factors are cumulative and can mask one another and can be combined, and therefore makes it very difficult to manage these patients. So therefore, the comorbid conditions that you see in these patients are, for example, a delirium condition, frailty, depression, and skin infections. And there the consequences are quite difficult. For example, they take meals irregularly, and therefore the regime of medication should have to be simplified and simple. Many times they do not do monitoring very frequently. So therefore, you have to give medication such a way that you avoid hypoglycemia in these patients. They also require the deconditioning for the decreased mobility, the pressure ulcers, and they require assistance for the toileting. Therefore, the optimized activity, repositioning if mobility is impaired, and assessment of treatment of pressure ulcers are very important. Depression, as mentioned earlier, also have impact on these patients because of depression. They don't take medicines regularly, or if they take, they might take deliberately higher dose and can end up with hypoglycemia. Skin infections and the foot problems are also very important, and that requires a good control, a good hygiene, and a frequent monitoring, which becomes challenging in these patients, not forgetting the nutrition aspects of the disease. So we always know that tight glycemic control is always good. That's what we felt when we saw the UKPDS trial. And the ACCORD trial said the other way around, that it is not important to control diabetes in a very tight fashion. And therefore, in the elderly population, who are old and frail individuals, do not achieve a very tight glycemic control because that can produce complications like hypoglycemia, falls, and fracture. So it's important that not to have too aggressive control in these patients, especially if they're very frail and they cannot be managed easily. This sarcopenia is again very important, which I touched upon earlier, that every patient when he starts aging beyond the age of 40 years till 70 years, there's about 10% of the muscle mass loss for every decade. And that gets further worse to 15% when you age beyond 70 years. So that brings sarcopenia. When you have type 2 diabetes also is worse as you start aging. And the problems in type 2 diabetes also, there is a dysglycemia, there is advanced glycation end product, there's involvement of the muscle in these patients with diabetes. And because of that, there's a further progression of sarcopenia. So that compounds the problem further, that these patients have excessive of sarcopenia. And because of sarcopenia, the insulin resistance also goes up. And therefore, these patients need to manage very carefully so that they can be controlled well without having problems of hyperglycemia. And diabetes also with risk of the increased sarcopenic obesity, and that's because of the sarcopenia, as I told you earlier, and that causes lack of physical activity, which brings about local inflammation, that worsens insulin resistance, and therefore these patients have sarcopenic obesity, where incretin drugs can be useful here. Important to realize that de-intensification of treatment is also important, especially the short life expectancy with low cognitive functions, low functioning status, and they will need to reduce the medicine or switch to the drugs which are safer, and de-prescription of the drug is very important in these patients. And one such example is insulin. So therefore, whenever you give insulin, if there's a basal insulin is given in the night time, shift that insulin in the morning time. Avoid giving insulin at night. If the patient is taking premix insulin, only 70% of that insulin should be given again as a basal insulin. And if the patient taking mealtime or a short-acting insulin, if the unit of insulin less than 10, then stop insulin therapy. If it's more than 10, try and add a drug which could bring less amount of hypoglycemia. That means try and avoid sulfonylurea insulin, because these are the drugs which can bring in hypoglycemia. And we monitor these patients again with the fasting blood sugar every 3 or 4 days, and increase the dose either by 2 units or 1 unit, depending on the patient's blood sugar. And always remember that hypoglycemia is a major problem and that we need to de-intensify these patients' treatment. In patients who are menopausal, women also have increased amount of obesity because of drop in the BMR. And because of that, there's increased amount of adiposity. And that brings in endothelial dysfunction. And that also gets into depression because of change in the hormones, or a drop in estrogen and progesterone brings about psychiatric manifestation like depression, and they also have vasomotor symptoms and sleep disturbances. Again, here, important aspect is a good lifestyle modification, a good glycemic control, management of comorbid conditions like hypertension, repeat disease, and of course, the antiplatelet therapy is important. Inpatient, Dr. Panikkar discussed just now in great details, but the elderly population requires 3 times more hospitalization beyond 65 years of age, and that usually because of the hyperglycemia. And as we know that the increased hyperglycemia also is responsible for increased mortality and morbidity, increased length of the stay in the hospital, and increased risk of infection and overall complications. And what is important is that you need to be also careful about hypoglycemia. And that is, again, you have to strike a balance between the two ends of the spectrum of hyper and hypoglycemia. You need to have patient-centric, individualized approach, insulin therapy regardless of the patient age, because that's the key standard of in-hospital management. DPP-4 drugs can be given, as Dr. Panikkar just mentioned about it. Talking a little bit of pharmacological drugs and the goals that is there, you need to get the goal around 7% depending on the patient's need, but there are different guidelines by different organizations. By and large, most of them agree to get the A1C around 7%. Always have this 4M framework, that what matters, the mobility, medications, and mentation. SMBG is very important. Injection technique should be taught properly. All those technical aspects of injection therapy should be taught properly. The aspect of management of these patients depends on how good the patient is maintained. If the patient is independent, then they have tight glycemic control. If the patient partially dependent, then get the A1C around 7 to 8%. If the patient is totally dependent, then get the A1C around 8 to 9%. And every time see that the patient gets adequate nutrition, and there should be a good amount of protein in a diet with every meal, because if you consume good amount of protein with every meal, The sarcopenia is much less, so therefore the protein consumption is again important, besides, of course, glycemic therapy. So the ADA recommends that you should have very careful about hypoglycemia. Overtreatment is dangerous. De-intensification is the key, and the cost of therapy is also very important, especially in patients who are living in the home for the aged or they're living by themselves is also important. And quickly, last 2-3 slides of metformin to be used in elderly population. Remember, there's a B12 deficiency which is likely to occur. In the past, we used to screen every 4 years. Now we screen every 1 year. In the chronic kidney disease, the GFR dropped below 45%, reduce the dose to 50%. If it dropped below 30, then stop metformin, and it may be useful in patients of cardiovascular disease. Sulfonylurea is again caution of weight gain, hypoglycemia. Use short-acting drugs. Do not use long-acting drugs. Drug like glibenclamide should not be used in elderly population. Glitathons can be used in elderly population. They do not cause hypoglycemia. There's increased risk of fractures in the elderly population, especially postmenopausal women. Can cause retention of fluid, can cause congestive heart failure. Of course, in CKD can be used, but be careful about fluid retention. And patients with cardiovascular disease, that drug can be used, except in those patients who have heart failure, where it can produce heart failure because of retention of fluid. DPP inhibitors are the best drugs because they are quite safe. They do not produce hypoglycemia. They might require reduction of the dose, especially if you're using other than linagliptin and the teneligliptin, then they might require dose adjustment in patients of kidney impairment and cardiovascular disease. They're quite safe, except the drug like saxagliptin and alogliptin, where there's increased incidence of heart failure. SGLT2 inhibitors are again good drugs. They can reduce cardiovascular events. They are very good for the renal. They're quite safe now. We can go up to right up to 20 GFR with empagliflozin. There's a data on that, especially empakidney disease. Empakidney is a study. And use of patients with cardiovascular disease. These are very good drugs, excellent drugs for heart failure, both patients with or without diabetes. So this is the ADA, my last slide, of the standards of care in 2023. The new language is added to outline those with frailty at the high risk of hypoglycemia, target of more than 50% time in range and 1% below the range is now recommended. This is to remind you, every 1% in time in range equals to 15 minutes a day. De-intensification is the real mantra. You should remember that. Reduce the risk of hypoglycemia is the most important keyword of the entire discussion. Glycemic goals may be reasonably relaxed, but symptomatic hyperglycemia leading to complications should be avoided, and focus on screening complications, which is very important, that may lead to functional impairment. That's again important. With that, I thank you very much for the patient listening.
Thank you, Dr. Naglur, for your nice talk, simplifying and just making it aware that this is a special population where the needs are different, the targets may be different, and if you see of glycemic variability, then your time in range targets are also different. You don't need to be over aggressive in treating those patients to cause more hypoglycemia and more complications, and see what is the support system of those patients, and then tailor-made the therapy for those patients. 3 cheers for Dr. Naglur. It was a nice talk.
Thank you very much.
Dr. Madia for and
next. I think Rajiv is Vijay there? Trihan is there or not? Dr. Rajiv? I think
next speaker is Dr. Vijay Trihan. Is he there?
The third Vijay is not there. We have heard Dr. Vijay Panikar, Dr. Vijay Naglur, but third Vijay is perhaps busy in the cath lab. So in the meantime, I think we can have some questions and the question and answer from the audience if there are any. But I'll just to begin with, I'd like to ask Dr. Vijay Panikar. Sir, what you told was very brilliant and very nice in a hospital where all those facilities are available. What would you recommend for a setup in a patient for an indoor patient with hyperglycemia where you do not have an insulin pump? How would you like to manage that patient? And in case you want to give, say, glucose, insulin, potassium infusion, do you recommend that or not?
See, basically, what you could do is you could just have a normal saline, 5%. You could put X amount of insulin in that, and the rate at which, suppose you put, say, you're giving the drip at 80 ml per hour. That means that 500 ml normal saline will get over in 6 hours. If you put 6 units of insulin, you are going to give 1 unit per hour. If you put 12 units, you will give 2 units per hour. Suppose you put 12 units, you can adjust the speed and then titrate what is the dose that you require to give. So it is doable in a even in a limited resource setting, very convenient.
I think the GIP, may I add to that?
Yeah.
That because insulin potassium infusion concept is no more. In the past, we used to use it, especially when Vandenberg did the trial. They felt that by giving insulin, there can be risk of hypoglycemia. And they also gave glucose, insulin, potassium in these patients because insulin is supposed to push the potassium into the cell and can prevent the episodes of hypokalemia and also stabilizes the membrane of the cell to prevent any ectopics if the patient gets by hypokalemic episode. But nowadays, we have such a good glucose monitoring device and therefore we don't need that GIK. And why it was used only GOK, God only knows why it was first invented. Now it is of no use much value.
Right.
Another question for Dr. Neglur. In special subset of patient, how would you combine a oral, hypoglycemic agent with insulin and your targets, do you relax the target once you try and relax the targets to HbA1c of maybe 7.2 or 7.5, then you increase the, chances of the complications as well. So how do you think we should try to balance not going far away from the targets and then trying to avoid hypoglycemia? This is a very tricky situation in elderly subset of patients.
Yes, I think Carolina Blum was a lady who first designed how to manage these patients, elderly population, and she divided them into 3 groups. One group where the patient is totally independent. Patient can do all the activities, activity was good, and patient could manage himself adequately. In those patients, she said, you can get the A1C of 7% because the patient is active. Those patients are partially active, not very active, but partially, but requires some kind of assistance. There, the problem of hypoglycemia could be dangerous. So she said, you get the A1C around 7.5 to 8%. And those last group of patients who are totally dependent or bedridden and who have other comorbid conditions like chronic kidney disease or they have ischemic heart disease, they suffer from a stroke, they have pressure ulcers on the bed sores, or they have ulcers, trophic ulcers on the leg. Those patients, she said, can go up to 8.5%. Because here the comorbid conditions are so many that the aggressive glycemic control is of no much value. And there, the point is you give them control in such a way that the risk of hyperglycemia is minimized and there is no risk of hypoglycemia. So this is what Caroline Blum has decided how to treat patients who are elderly and how to get the target to these patients.
May I add here? See, basically, the only fear that we have when we are treating elderly or debilitated people is hypoglycemia. There are only 2 molecules which will cause hypoglycemia, insulin and sulfonylurea. If without the use of these 2 molecules, you can control their sugar, you can go to HbA1c of 6.5 also without any problem.
No, in elderly population, the A1C is also not reliable. And therefore, the A1C should not be also used as a monitoring methodology to see what the glycemic control is. You rely more on prandial sugars. Even the fasting sugar is unreliable in elderly population. So therefore, I think the best way to monitor the prandial sugar, and I agree with Dr. Panikkar, that the hypoglycemia should be avoided in these patients. Therefore, there is a de-escalation of therapy. And even the guidelines, the American Diabetic Association guideline also mentioned that to de-escalate therapy whenever you feel there's a risk of hypoglycemia. And you can't monitor this patient frequently for like CGM, it's not possible, then nocturnal hypoglycemia can be dangerous to these patients. They can have death in bed syndrome. And therefore, it's important to see that you avoid hypoglycemia, to strike a balance between hyper and hypo.
I think we have to be cautious combining the agents which cause more hypoglycemia like sulfonylureas and insulin, keeping the targets little relaxed in those patients, and those who are unattended probably would be the key. Patients who are attended well and well preserved, maybe the same targets as in the younger population can be achieved. What do you say, Dr. Maria? to close
I
it.
think Dr. Panikar made a very valid point, because if in the elderly, if you want to use agents, you should preferably use agents which are not likely to cause hypoglycemia. The usage of DP4, let's not even, I'm not talking about GLP-1 receptor agonists, because many of them will not be able to afford it. I'm talking about the affording part also. The usage of DP4 inhibitor and sulfonylureas and metformin, kidney functions permitting, would be a safer bet, unless they have hyperglycemia of a catabolic stage or something of that type. I agree with Dr. Panikar. We should use agents which are less likely to induce hypoglycemia. And we all know the DP4 inhibitors and metformin and all these are fairly safe. They have a hypoglycemia risk almost as good or as bad as a placebo.
One more point, Moreji. I want to add one more point here, that the WHO has said that if patients taking more than 4 drugs, then the risk of drug-drug interaction is very high in elderly population.
Yeah.
In fact, it cautions that the 4th most important cause of mortality in elderly population is polypharmacy. So drug-drug interaction. So therefore, drug to be minimum, because patient could be having kidney disease, ischemic heart disease, stroke, osteoporosis. All these problems will be requiring some medications. So as you keep on adding drugs, there will be additional so many drugs. The patient will have complications because of drug-drug interaction, and because of poor renal function as a part of declining GFR, all these drugs will accumulate in the body and cause problems. So therefore, that caution has to be exercised.
I think we are coming towards the end of our time, but before that, I'd like to have one final view from Dr. Panikar. Even still, we see a lot of doctors, the anesthetists and all, when the patient going on, this advice, even treating physicians, they are advising sliding scales in the patients who are being thing. Do you still, or in any situation, recommend them or not?
Sliding scale is the most foolish thing ever. It should not be done. I'll give you a simple example. What sliding scale says is, if the blood glucose at any given time is 300, you give 10 units of short acting. If it is less than 100, don't give anything. So suppose the fasting was 300, you have given 10 units of insulin. Before lunch, it becomes 100, and you don't give any insulin. Then again goes up to 300. So it has been given up. Across the world, it has been given up.
It is supposedly given up, but still very frequently used. Because and the most foolish thing about it is you are chasing the glucose, and rather than dictating your terms to the glucose.
True.
I think
what you need is a correction bolus at that time.
Yeah, that is very true. But
what is called in the loose language is like a policeman coming to in the site of the crime after the crime is over.
Yeah.
Who did the murder? How the murder was over? So that's called post effecto. So this is how the police coming on the scene after the crime is over is particularly what is called a sliding scale method.
I think we have reached the end of our time. We're already 5:50, and the third Dr. Vijay is not available. So, Dr. Vipul, any comments from your side, or should we close the session? I think Dr. Vipul is also not there. So I think we'll close this session. We had a wonderful talks from both Dr. Vijay Panikar and Dr. Vijay Naglur. Their talks were excellent. Both in content and delivery. They were brilliant in their presentation. We must give them both a very, very big hand.
Perfect Vijay scare.
Thank you, sir. Thank you, sir.
It was supposed to be a Vijay Q, but the Vijay square delivered.
The Q part is missing.
He's the master of cardiology, true father of cardiology, but unfortunately, he's in cath lab in an emergency case. We missed him.
Yeah, saving somebody's life.
Thank you, Dr. Maria.
The third Vijay is my class fellow. We did our graduation and post-graduation together. I would have loved to hear him today, but anyway, that's a chance.
No, but Vijay Naglur is my class fellow.
So the Vijays are very popular.
No, my class people come on time.
Thank you so much, sir. It was a pleasure to have excellent academics from the doyens, and I think the Vijay Square delivered it very well. Thank you, dear chairpersons Vipul Gupta sir and Rajesh Maria sir, as well as our speakers Dr. Vijay Panikar sir and Dr. Vijay Naglur sir. So with that, we come to an end of this very, very stimulating trilogue, and we move on to our next session, It is an insulin symposium, and to chair the session, may I request Dr. Vijay Negalur sir to continue. He has been introduced, co-founder and medical director, Dr. Negalur's Diabetes and Thyroid Specialty Center, Mumbai, and my dear friend Dr. Ami Sanghvi from Mumbai, director and consultant diabetologist at Sanghvi Eye and Diabetes Care Center. Welcome, chairpersons.
Thank you.
So the hall is all yours.
Yeah. Ami, I think that you do, I think I'll stay for some time because I got one more talk.
No worries.
First, I'll hand over to you, Ami,
Sure.
and you carry on. Okay.
No worries.
So what's the...
Can I start the introduction?
Yeah, sure.
So a very good evening to everyone. In regards to Dr. Vijay Negalur sir and Dr. Vijay Panikar sir. Thank you organizers, Dr. Shalini Jaggi and Dr. Rajiv Chawla for having me again today. So after a beautiful session on a mixed bag, now let's get onto something about insulin. We all know with so many OHs available, insulin is getting pushed a little behind with so many OHs available with us right now. So to understand the right use of insulin, let's start on with none other than Dr. Shalini Jaggi. So a dear friend who is a consultant diabetologist and director. I would like to introduce her in brief because she's the one who has been the torchbearer of this whole conference. So I think, Shalini,
thank you so
beautifully
much,
organized
Ami.
conference, heartiest congratulations. And
Thank you.
we will be discussing on insulin initiation, the doing it right the first time. And that's what the need of the hour is. Over to you, Shalini.
Thank you so much, Dr. Ami and Vijay sir. Of course, we are obliged to each and every one of you for joining us and partnering with us in making this conference a great success. And I'm sure the delegates who are logged in from everywhere are enjoying the academic feast that we are delivering. So without wasting much time, let me start with the topic that has been assigned to be by us. So we are going to talk on insulin initiation and doing it right the first time. And why this is important is because we all know that if we are going to initiate insulin well in time, as they say, a stitch in time saves 9. You can actually prevent a lot of dreaded complications rather than introducing insulin once the complications have set in. So let me start with a case scenario. This is Mr. Satish, a 57-year-old lecturer, type 2 diabetic since 2010, dyslipidemic, and he's come to you because of an urgent need, because he needs to undergo a cataract surgery in the immediate future. Otherwise, maybe, like most of our typical patients, he wouldn't even have bothered to visit you now. So if you just go into the details of Satish, like I said, he's a lecturer. You can see here, his BMI is 24.8, has had diabetes for more than 13 years. And if you look at his bloods, you can clearly see this is uncontrolled diabetes at 10.2. And that is why the eye surgeon refused to do a cataract surgery before he actually gets his glucose numbers right. If you look at his SMBG, you can clearly see it is not only the fasting, but also the post meals, which are definitely out of range, contributing to his high HbA1c. You can see his creatinine is fine, but eGFR is 100. What is he currently on? He is on 3 OADs, which means metformin, 1000 milligrams per day, empagliflozin, 25 milligrams per day, and glimepiride, 4 milligrams per day, along with an atorvastatin, 20 milligrams. So the main concerns that you identify in this patient are, of course, uncontrolled diabetes. And of course, you need to get the things on target as early as possible so that you can help him undergo his cataract surgery, because of course, blurred vision is something which can be very, very disturbing for your patients. So now, how do you manage this case is the first question that you ask yourself. He is already on 3 drugs. Do you still want to add another drug? And even if you add a 4th drug, coming from an HbA1c which is more than 10, how much HbA1c can you bring down by adding another oral agent? Because this is somebody who really needs a tight glucose control. Or do you actually initiate insulin for this patient so that you can hit it hard, you can bring it down fast, and not only does that help in preventing complications in the future, but the immediate need, that means getting his cataract surgery on time. Well, if you look at the scenario in diabetes, let me just take you back to the numbers. And this is something that we keep discussing in all our CMEs and conferences, the rising burden of metabolic disease in India. And as you can see, the projections, we are definitely showing up very, very dismally. We already have 101 million people with diabetes, and what is more worrying is 136 million people with pre-diabetes, and this is a time bomb that is waiting to explode. So you can just imagine the burden of diabetes that we carry, besides all those other metabolic problems like dysglycemia, hypertension, generalized obesity, abdominal obesity, cholesterols, and dyslipidemia in terms of high LDL cholesterol. Now, coming back to our patient, like I said, he's on 3 OADs. Normally, what we do is keep adding one OAD and then a second and then a third and then a fourth. But what we now know is that adding on OADs may not really be the right situation. And this is because there is a term called the lessening effect of OAD inadequacy, which means a clinical situation where, in spite of concurrently adding OADs, when you've actually added 3 oral glucose lowering agents of different classes, one of them being a metformin, second one most probably being a sulfonylurea, along with maybe whatever choice of the third agent, besides normal diet, exercise, besides, no other comorbid condition that could actually be worsening or contributing to hyperglycemia, your patient still stays above goal. So the A1C is still high in spite of adding OADs. So when you add a second OAD to the first drug that is happening, you see a good HbA1c reduction almost to the tune of 1% or more. When patient is already on 2 OADs and you add a third one, you see a slightly lesser reduction in HbA1c, almost to a tune of 0.5%. Beyond 3 OADs, when you start adding a fourth OAD, you hardly see a huge HbA1c reduction, whatever agent you're adding, So almost a 0.2%, which is like kind of a negligible when you come to a 10.2, which needs to be brought down to at least a 7 or a 7.5. Insulin is the only agent where you can actually get a big drop in HbA1c, you can get it fast, and you can maintain it. So the RSSDI recommendations on insulin initiation after 3 OADs actually address this problem and clearly say that when you have a patient with type 2 diabetes who's already on 3 oral agents and is failing to achieve his target, this is the time when you really need to think of insulin therapy. Additional oral agents, you can think in a subject where, you just need a reduction of maybe 1.5, provided he's not on the more potent agents. Clinicians must consider the limitations of individual oral agents or their combinations in terms of the quantum of A1C reduction. So it's very, very important that when your patient is failing on 3 OADs, and his HbA1c is still much way beyond the target, this is the time you really need to think of insulin. I'm not even talking of the other indications for insulin. And it's important that you don't use insulin as a threat. Don't make it feel like, you need to punish him for not maintaining his glucose well, or maybe, he's failing in, those negative thoughts should not happen, because you need to explain that insulin is going to not only improve his glucose control, but it is going to prevent complications or even alleviate the impact of complications. So you need to educate him on the hypoglycemia. You have to tell him that it is not something that you're going to be dependent upon. Talk about the pain, the newer instruments. So I think you just need to educate your patient and make him accept insulin and not use insulin as a threat. And now that we have new delivery devices, I think life becomes easier. With that, let me now move on to the insulin that we are going to discuss today, Ideg-Aspart, the world's only co-formulation insulin, which can be a good insulin for initiating when it comes to a patient who is failing on OADs and you're thinking of one shot of insulin. Now, this is a combination of an ultra-long-acting degludec, 70%, mixed in the same injection with a 30% fraction of a short-acting aspart. So basically, you have 2 different insulin components that are present in a solution together, but they do not interact with each other at all, either in the solution or even in the subcutaneous tissue after you've injected. Therefore, even after injection in the body, they retain their individual properties and work. So the degludec takes care of the basal requirement, and the short-acting aspart is able to address the post-meal jump in that particular meal where you are giving it. So when it comes to the question of, you've decided that you need to add an insulin, if you have to make a choice between which insulin to start as an insulin of initiation, Do you start with one shot of basal insulin along with other oral agents? Or do you start with one shot of this co-formulation of idegespart and then titrate? Well, this is data which shows the differences in glycemic responses in Asian and non-Asian people with type 2 diabetes initiating on basal insulin. And as you can see, that despite similar fasting plasma glucose reduction with basal insulin, much less Asian patients achieved their HbA1c target as compared to the non-Asians, with no significant difference in dose requirement. So this is something that tells us that maybe in the Asian patients, there's something which is still preventing them from achieving an HbA1c target in spite of adding a basal insulin and getting the fasting plasma glucose under control. Because, you know, we've all thought of the dictum of fixing fasting first, which takes care of the post meals. But in Asians, this does not really seem to be happening much. And why does this happen? Is something that we need to understand. The high carb diet that all of us eat. North, South, East, West. START study by Dr. Shashank Joshi's group clearly showed us that most of our diets are composed of almost 65 to 70% carb. Be it a South Indian thali or a North Indian thali or a West Indian meal or an East Indian meal, it is essentially the carbohydrate component which is very, very high, and this contributes to the postprandial levels. This is the India Diabetes Care Index, again a study of 3.5 lakh participants in the 55 to 60-year age group with an A1C of 8.5 plus minus 1. Fasting plasma glucose, you can see 172, postprandials 253. So you can clearly see that in this study also, the main contributor to this A1C was the postprandial. More than 83% of the patients had postprandials, which were more than 160. So clearly we eat a lot of carbs, and that is why simply a basal insulin, one shot, may not be sufficient to bring down our glucose levels as well as our HbA1cs. Now, this is a study with insulin-naive patients with type 2 diabetes, 296 patients, one arm given one shot of idegespart along with OADs as an initiating insulin, and the other arm on the glargine U100 with OADs at initiation, followed up for 26 weeks. And as you can see here clear, the patients in the idegespart arm fared much better, superior long-term glycemic control compared to glargine 100, significantly better postprandials coming down almost to the tune of 57, and HbA1c reduction of almost 1.4% with a similar fasting plasma glucose component with 70% basal. And what is best is 72% more patients were able to achieve their target A1C with one shot of idegespart added to OADs compared to the glargine U100 arm without experiencing hypoglycemia, which is a major barrier to insulin initiation and intensification. Now, this is another poster presented in the 2019 IDF Congress on insulin initiation in patients who are failing on OADs, where idegespart in the subcontinent actually seems to fare better. As you can see here, compared to the glargine U100 or glargine 300, what you see is a much better reduction in HbA1c, as well as a very good significant reduction in the fasting plasma glucose postprandial when you compare idegespart initiation to glargine. So idegespart faring much better compared to the glargine as a first shot insulin to be introduced. Now, when it comes to switching to idegespart from glargine U100 or U300, what you exactly see is not only a lesser insulin dose requirement, because the numbers also have a psychological impact on the patient. You know, when you tell them to keep increasing doses, they feel, how high should I go? So this is a study which clearly tells you that compared to baseline to the end of study, you see much lesser insulin dose is required in terms of basal as well as prandial component over 26 weeks, but the diabetes therapy related quality of life improves once the A1C comes down. So the patients feel a significant improvement in their total quality of life, and almost 75% patients actually preferred one shot of idegespart to their previous treatment once they were able to achieve good A1C and a better quality of life at a much lesser insulin dose. Now, this is again another study from Dr. Rajiv Kovil's center looking at the impact on the quality of life and the treatment preference. And you can see adults treated with type 2 diabetes, 94.2% of the patients were easily able to manage their day-to-day activities better once they were initiated on idegespart. 89.8% had improved quality of life with reductions in the number of pricks, and 86.7% found it very comfortable to inject Idegespart in different social situations. And that's because of the excellent device. And I'm sure all of you would have seen that beautiful device that comes with this insulin. So much lesser pricks, much more flexibility and simplicity of dosing with Idegespart, translating into a better treatment compliance and a better quality of life for most of our patients. Now, this is another study in patients with type 2 diabetes, almost 500 plus patients who were uncontrolled on basal insulin. So in the one arm, Idegespart was added to the orals. In the other arm, it was the basal that was ongoing, and a shot of Espart was added in the treatment period over 26 weeks. And then if they were not on control, then the Idegespart, a second shot was added to a few patients out of these. And then in the other arm, a second shot or a third shot of Espart was added on baseline OADs. So you can see at the end of treatment period, Idegespart achieved similar improvements in fasting plasma glucose and HbA1c when you compare it to basal bolus, which means 4 shots versus 2 shots. 6.6% achieved significantly lower dose was required with Idegespart compared to the basal bolus at the end of study, and fewer mean number of daily injections. Of course, like I told you, 2 shots of Idegespart with OAD compared to a basal bolus, which means 3 Esparts plus 1 glargine on top of OADs. So you need lesser injections and you are on target. Now, cost sometimes seems to be a big concern because we all feel that it's an expensive insulin, but this is a study, this is an abstract by Dr. Barua's group, clearly calculating the yearly total cost of medications and healthcare resources based on the Indian cohort. And as you can see here, when you have a patient who is initiated on Idegespart compared to all the other baseline treatments together, the yearly total cost is lower, because if you look at the emergency room visits that may happen, outpatient visits, the hospitalizations go down, the work days missed go down. So if you have a good insulin that is helping the patient achieve a better target control, all these visits will be much less. So the cost, long-term cost, becomes much less. So it does serve as a cost-effective treatment when it comes to patients with type 2 diabetes who are not on glycemic control with therapies in routine clinic practice. And therefore, Idegespart does not really come out to be very expensive. Now, when you go back to Mr. Satish, you go and do a meal recall. And what do you see? What is his breakfast? Maybe a cup of tea with 2 to 3 biscuits. His lunch is usually a porridge or maybe a dal or a sabzi that he takes, hardly any carbs in terms of a roti or a rice, because this is all that he eats for lunch. Dinner, of course, is his heaviest meal. So he has his rice and, a portion of meat or maybe dal or sabzi for dinner. So dinner is one meal that he enjoys and relishes once he's back home. So this is where you position the Idegespart to be taken with the biggest carb meal of the day. So the beauty of using this insulin is one shot which can be given with the largest meal of the day. So if your patient has a heavy dinner, you can time it at night. If your patient has a heavy lunch, you give it at lunch. And if he has a heavy breakfast, you give it in the morning. So you can initiate with 10 units of Idegespart once a day with any major meal in the day. Idegespart can be administered with the most carb-rich meal. So once you do a dietary recall, you decide which is the heaviest meal contributing to the postprandial hyperglycemia the most, and that is where you time it. So on a day when he's probably not going to have a heavy dinner, but if he's going to have a heavy lunch, then on that particular day, you can actually give it for lunch. So it gives you that flexibility of giving that one shot with the biggest meal of the day. So that's again a very, very big advantage of this insulin. So, and if your patient is still not on control with that one shot, when you want to intensify treatment, when you want to up titrate, what you can actually do is give it with the second biggest meal. So you've already started it with the first meal, which is the biggest meal. And then with the second biggest meal, you can give 2 shots. So 2 most carb heavy meals, you can give it at that time. So if your patient has a heavy lunch and a heavy dinner, you can give 1 shot in the afternoon and 1 shot in the night. Suppose he has a big breakfast and a big lunch, you can time the doses there. Or if he's somebody who has a very light lunch but a heavy breakfast at home and then goes to work and comes back and has a heavy dinner, you can give 1 shot of this co-formulation in the morning and the second shot in the night. So it's very important that the meal size and the postprandial glucose response should actually dictate the ratio of the 2 doses. It does not have to be like a complete 1:1 split. So what are the practical recommendations when it comes to the weekly titration? You can use a simple algorithm. So if you've initiated the insulin and the fasting plasma glucose is still not on target, you can keep adding 2 units. If the fasting is on target, you maintain the dose. Of course, if If he gets a hypo, you have to reduce the dose after ruling out other contributors to the hypo. So when it comes to once a day IDGS part, you just need to look at the fasting plasma glucose, time it with the biggest meal of that day and give one shot until the fasting is on target. You can keep up titrating the doses. Suppose your patient is on two shots of IDGS part, twice daily shot of IDGS part. What do? You look at the pre-dinner glucose levels to decide the pre-breakfast or the pre-lunch dose. And you look at the pre-breakfast level to decide the pre-dinner dose. So depending on which glucose levels are beyond range, that is how you up titrate or down titrate the IDGS part dose. Now, a very important question is, if you are giving it twice, will it actually lead to a tailing effect? Will there be an additive effect? Well, the answer is IDGS part can easily be given once a day or twice a day, because if you look at the steady state, once the steady state is achieved, the basal component, the deglutide component, the glucose lowering effect of this basal component or deglutide component is similar. So there is no tailing, there is no adding on. So there's no potentiation of the deglutide, because we know it forms long chains which keep dissociating very slowly. So therefore, the glucose lowering effect of deglutide is similar regardless of whether you give it once a day or twice a day, as long as you're not really majorly changing the total daily dose on a daily basis. So the S part takes care of the two bigger meal surges, and the the deglutide component takes care of the basal component part, and there's hardly any hypoglycemia or additive effect of the deglutide doses. So coming back to Satish, remember, he came to you for a cataract surgery with uncontrolled diabetes and an HbA1c of 10.2. What did we do? We, of course, reduced the sulfonylurea dose from 4 milligrams to 2 milligrams of glimepiride, and we added an IDGS part. I told you, the dinner was his heaviest meal. So we timed it at 10 units before dinner. And then we kept up titrating his dose based on his SMBG value. Finally, by 3 months, he was on an IDGS part dose of 26 units, and he was down to an HbA1c of 7.8, which is pretty good. You would not have achieved that by adding another oral agent or even increasing the dose of the orals that he was on board. Fasting plasma glucose was down to 110, post breakfast was 124, post dinner was almost 146. So friends, keeping in mind the Indian reality of diabetes management, the kind of food we eat, the timings of our food, the lifestyle that we lead, this is one insulin co-formulation IDGS part. This can be a beautiful choice at initiating for a patient uncontrolled on 3 OADs. Therefore, when it comes to the Indian scenario, it comes as a prudent choice, not only in terms of lowering the hypoglycemia, achieving a good glycemic control in terms of a good fasting plasma, postprandial, as well as an HbA1c reduction, offering the patient mealtime flexibility to be taken with the largest meal of the day. So, and different meals, if he's going to eat a heavy breakfast one day or a heavy lunch, you can time it accordingly. A very simple regime, just a once a day shot. Doses, I told you how to titrate. Convenience of the device, it's a beautiful device if you've seen it. And of course, once the glucose levels are on target, a better quality of life at a much cost effective when you come to the long-term costs. Thank you so much. And with that, I'll stop sharing and we go back to our chairpersons.
Yeah. Thank you, Dr. Shalini, for this wonderful presentation of making us understand the co-formulation and the right time to start this co-formulation. So moving on to our next talk, we have with us Dr. Meenal Mohit, who is going to be talking to us about designing the insulin regimens in our patients with type 1 diabetes. I think a very important topic, and she's going to be talking about an endocrinologist gimmick.
I think Meenal is in transit. She'll be joining us in a little while. Meanwhile, we can have Dr. Sanjay Agarwal.
Okay. I'm sorry.
Fine.
So we
take
no Dr. Meenal a while later. So then let's move on, and I invite Dr. Sanjay Agarwal, who is going to be talking about insulins in patients with type 2 diabetes, the dichotomy of evolution and adoption. So, sir, you all know, is a well-known diabetologist. He's the head Department of Medicine and Diabetes at Ruby Hall Clinic, honorary secretary of Governing Council of National RSSDI, member of writing committees of our RSSDI guidelines on various topics, author of book clinical atlas in diabetes, chief editor of RSSDI's insulin monograph. So the best person to be speaking on this topic, I invite you, sir, to kindly take over.
At the outset, I would like to thank Dr. Rajiv Chawla, Dr. Shalini Jaggi, and the entire team of the meeting for this invitation for the prestigious meeting, to speak at the prestigious meeting. I would like to give a little premise about my talk before I begin. We are quite familiar with the use of insulin, and we use this in our day-to-day practice. Over the years, there have been a number of insulin innovations with the intent how to make it better effective, more sort of to get more patient compliance and make it easy in terms of dosing. The hardest part has been, of course, adoption of these insulins by the doctor as well as by the patient. So in the course of next 20 minutes, I want to walk you through this presentation, which outlines all this, what I've just spoken about, the different innovations that we have got, how effective they are, how can we motivate our patients as well as doctors to use them, and then I'll conclude by leaving behind some of my own thoughts. So this talk has been supported by Novo Nordisk, and I thought I should mention this conflict of interest while giving the presentation. Now, this is going to be the agenda of my talk. We're going to talk about delayed insulinization, the dire situation, hurdles and solutions, the physician and patient barriers. We're going to talk about 100 plus years of evolution of the insulin molecule. And then, of course, we're going to talk about the conclusions of what we really need to take home points to use in a clinical practice. This data from the IDF outlines that the diabetes prevalence is increasing worldwide. And while we had about 537 million people with diabetes in 2021, it's projected that we will have about 700 plus million by the year 2045. And of the total burden of diabetes, type 2 diabetes remains the most common type, accounting for almost about 90% of diabetes worldwide. Now, if you look at all the different regions of the world, you can see here that no region is spared by the increasing prevalence. And obviously, we are looking at a whole pandemic of diabetes. And unless we do something better in terms of preventing diabetes, but having said that, if people have diabetes, how can we prevent complications? By giving them a better control. Ultimately, we do know that despite all the innovations that we have had in terms of medications, insulin remains the mainstay of treatment. Now, this paper by ICMR INDIAB, which was published this year, clearly outlines the status of India, and 11% of our population has diabetes, and 15.3% could be having pre-diabetes. So we're sitting on a volcano of people who are just waiting to convert to diabetes. And we obviously need to do more. One, of course, to prevent diabetes, but how can we prevent conversion of pre-diabetes to diabetes so that we can keep them as normoglycemic as possible? Now, if you look at the insulinization trends in India, we know that only about 31.3% of people with diabetes are being managed with insulin, despite a higher need for doing so. And 46.7% of patients with uncontrolled diabetes delay their insulin therapy. And we're going to see subsequently in my talk why this really happens. So let me sort of set the tone of my talk by illustrating a case. Dinesh is the name. His age is 55 years, has diabetes duration of 8 years. And you can see his blood glucose profiles. His fasting plasma glucose is 190, post-meal is 246, and A1C is 9%. His other labs are urea is 14, creatinine are 1.2, EGFR is 92, lipids, cholesterol is 140, LDL is 90. And his current medications are metformin 2 grams per day, tenaligliptin 20 milligrams daily, and empagliflozin 25 milligram daily. So while we can see that the patient is already maxing out on oral medications, his A1C continues to remain high, which is 9%. So is there a case of escalating to 4 drugs, or is it time for this patient to move on to insulin treatment? This is the moot question that we need to ask ourselves. So the question that I just mentioned is, if we do have to manage hyperglycemia in this patient, then what should be our next choice? And I'm sure that each one of us sees similar patients in our clinical practice. So let's look at some of the data, what is available. So unlike insulin, addition of subsequent oral agent does not really lead to any great benefit. So while you may think that if you move from 2 agents to 3 agents, there may be a doubling of the effect. In reality, it does not happen. So if you look from 2 agents to 3 agents to 4 agents, there's hardly any benefit that you can see. So 0.5 to 0.2. So there is a very marginal benefit that you tend to get. So the dictum being that if you have maxed out on good 3 oral agents, of which one of them may be a newer kind, then if you have an uncontrolled hyperglycemia, then it's time that you start looking at insulin as the next possible treatment that you need to give your patient. Because obviously, when you sort of start insulin, you're reducing the glucotoxicity, and you may benefit the patient in terms of preventing complications by a better tight control. What does poorly controlled diabetes really lead to? So we know that you may have microvascular complications like retinopathy, and we know that 35% of people with diabetes, it is one of the leading cause of the diabetic retinopathy is one of the leading causes of vision loss in working age population. Again, 60% of lower limb amputation in adult are caused by type 2 diabetes due to nerve damage, which can lead to ulceration and lower limb amputations. Nephropathy is a leading cause of chronic kidney disease, and both conditions are interlinked. And we had the CKD registry in the past, which was discontinued, and they looked at the prevalence of diabetic nephropathy across the country, and it's almost to the tune of 30% in different regions, and the overall prevalence being close to about 30%. So we need to pick up these patients by diagnosing a simple test of albumin creatinine ratio early and initiate treatment so that we can get the sugars to better control. And you may have patients who may present at the time of diagnosis with macrovascular disease, and most prominent of them is a cardiovascular disease. Patients may have angina, coronary artery disease, myocardial infarction, stroke, peripheral arterial disease, and failure. And people with diabetes are 2 to 3 times more likely to have a cardiovascular disease. Let me come to the next point, that what are the hurdles and solutions, and could there be physician-related or patient-related barriers? So while we do agree that insulinization is the way to go, but we have a dismal sort of, number of people who are on insulin. We just saw that. Now, there could be physician-related barriers that may be present, and we need to look at this very carefully. So one of the reasons is insufficient resources, that doctors may not have the required availability of insulins, the newer insulins, or regular sort of supply of insulins to give the patient. The other thing is, whenever we sort of initiate insulin treatment for our patients, we need to spend time to counsel them. Now, typically in a busy practice of doctors, you're not able to give that much time so that you can explain the need for insulin. Why does the patient need it? What could be the possible, outcomes of it, the benefits, as well as the risk and adverse events? So all this needs to be outlined to the patient. Now, most of the patients who see a busy practitioners may not get that sufficient time. They may have a lot of questions, and because of lack of satisfaction in terms of getting the required answers, they may feel that it's not really something that I would like to do. So it is important to build teams and have your team sit down and talk to the patient and counsel them as to why they need to take insulin, how they can take. It's very simple that they need to be reassured. And if they have problems, then how they can handle them. So troubleshooting needs to be talked about. But what is the reality? Most of our clinics do not have trained paramedical staff for patient education and counseling. So it is left to the doctor not only to clinically examine the patient, but also to give the necessary education and counseling. And possibly this tends to get compromised because of lack of time. Now, there could be other concerns. Remember that one hypoglycemia with the patient, that patient tends to get extremely scared and pushes back any intensification of treatment. And for the doctor, hypoglycemia is one of the most important side effects that he needs to monitor. So almost about 75% of HCPs mentioned that hypoglycemia was a barrier to insulin therapy when they needed to initiate for the patient. Now, this could be because they felt that the patient may not be adequately educated or literate enough to understand or recognize hypoglycemia and may end up causing more harm than good. The other aspect is, of course, weight gain. We know that insulin is an anabolic hormone, and majority of the type 2 patients are overweight, and hence the concern that insulins will add to an extra weight that the patient may gain. Then, of course, the delay in insulinization may be felt because the complex regime that follows insulin therapy may reduce the patient's quality of life. So the barriers and complexities may be also stem from the knowledge that they may not be adequately guided on the guidelines that are there on insulin use. And this is confusing because we have a number of societal guidelines. In each of them approaches from their perspective, and the physician is not very sure what he should be looking at. Also is the fact that over a period of time, we have been changing our target goals and what should be the target goal that somebody needs to intensify treatment. Now, these are sort of variable. Even in the same patient, it can be sort of different situations. So, for example, a lady for a pregnancy may have different targets. When they are young, they may have taken different targets. When they are old, they may have different targets. If they have associated comorbidities, they may have different targets. And it is very important for the physician to get familiar with what are the newer therapies that are available for the individual patient. Now, the solution is, of course, building teams, right? You need to create a bandwidth of paramedical staff, which may have nurses, pharmacists, educators, and this may help the doctor to get a more sort of better information to the patient to get the compliance to use insulin. So you need to give, if you have this sort of group of people which fill up the gap, it may free up a lot of time for the healthcare professional for doing professional consultations. Also, patients may have a frequent review of their data. And if there was a need to frequently change the insulin dosing, then somebody is monitoring that. Somebody is keeping a watch on also hypoglycemic episodes and need to down titrate insulin. So it is very important that the teams are constantly monitoring the patient. Now, having a good team with you, it builds a lot of trust with the patient because he knows that there is somebody that he can fall back to. So it builds a strong foundation for a therapeutic relationship. And this sort of reduces non-compliance to therapy. The solution has also been that there have been great improvements in the types of insulin that we've got now, and we'll talk about it. But what has this led to? Lesser incidences of hypoglycemia, lesser weight gain, and better quality of life. So the education now that we do, and particularly from RSSDI, and a lot of us KOLs that we sort of do it in different parts of the country, we try to get doctors to attend CMEs and do workshops so that they get training on the right approach to insulin therapy and how should they guide their patients for it. Also, they would probably be able to have workshops for teams, which will help them to guide patients in terms of insulin safety, the correct methodology of administration, and how can we monitor the insulin dosing to make it very effective and keep the blood glucose in a tight, narrow range of good control with less of glycemic variability. So these are all important because very often we write the guidelines, but they stay as a publication. We need to get those guidelines right to the doorstep of the doctor and teach them what do the guidelines mention and how can they use it in their clinical practice. The other barriers are, of course, patient-related barriers, and we term this as psychological insulin resistance. Now, PIR can be defined as a psychological opposition towards insulin use, and it stems from a complex set of beliefs. they are unaware about what insulin therapy is all about. So there is a pushback that they're not really ready to take it. Also, is a fear that they may not have adequate skills for managing their own insulin, or that may come from the fear of injections, or perhaps they've given a wrong perspective about insulin therapy by their fellow colleagues and other friends. And sometimes they just term it that they feel that it's probably the end of the road for them, and they really don't feel that they want to start insulin and would be happy to use oral agents. So PR is common, and approximately 30% or more of insulin-naive type 2 patients report a PIR. Now, we're just going to list out some of the patient-related barriers. So it could be anxiety to injection, perceived lack of control, low self-efficacy. They term this as a personal failure, that they couldn't keep their diabetes in good control. And they feel that positive gain may not be expected with insulin. And there could be concerns about adverse events, particularly hypoglycemia. And in a cost resourceful country like ours, or poorly cost resourceful country like ours, cost remains an important barrier for trying out newer insulins. Now, almost 3,000 odd insulin-naive patients with diabetes were recommended insulin. In this study, they just tried to take a questionnaire-based survey. And what they did find was that the mean time to insulin initiation was almost 790 days. And of these, almost about 374 people who initially declined, but eventually accepted to start insulin therapy. 610 people declined and never started insulin therapy. But a large majority of the people did accept without declining. But you do have almost about 30% of the people who were very apprehensive and were not ready to start insulin therapy. So what could be the impact of PIR, right? It is one of the major etiologies explaining both the reluctance of the patient to initiate an intensified treatment, and this leads to prolonged periods of poor glycemic control among individuals with diabetes. What is the end result? There is a poor glycemic control and increased risk of complications. So obviously that, we need to talk to patients and say that this is not so difficult, but it has huge beneficial effects, and they should not worry about starting insulin rather than blame themselves of what has happened and that the fact that they needed to take insulin. So they shouldn't blame, but probably accept it as a continuation of the treatment. Now, there could be sort of psychological insulin barriers that may be present, and we need to sort of differentiate psychological barriers from other reasons. So when you sort of write a prescription for insulin and the patient is resistant to take it, there could be a knowledge barrier, and perhaps this may be stem from the fact that there is lack of awareness of the benefits, or this could be a low priority for the patient. The other barrier could be the cost barrier or the socioeconomic barrier. And finally, of course, the psychological barrier, because insulin is conceived as a perceived inadequacy, and they feel that, hey, I don't need insulin. Why can't I just continue oral agents? Maybe you can step up the dose, add more oral pills, but I'm not yet ready to start insulin therapy. It could also come from the fact that they are worried about the side effects and hypoglycemia, or they may just be scared about injections. So these are sort of some of the concerns that patients tend to have, which makes it a huge barrier to start insulin treatment. So the key is, of course, that whenever the patient comes to you, right from the onset of the disease to any time in between, we always need to start conversations with insulin. And this is very important because I always start insulin conversations when the patient comes to us. You may not need to start insulin then, but it's good to talk that, okay, right now, your sugars are not really bad, your A1C is not bad, you can be managed on oral agents. But remember that diabetes is a progressive disease, and there could be a situation or time when the oral agents may not be adequate, and you may need to move on to insulin therapies. So the conversation, if you're preparing your patients well in advance and tell them that it's not bad, don't use it as a threat. And if you guide them well, you may find that the transition to starting insulin treatment may not be so difficult. So always understand from the patient, what does he know about insulin? And if he has totally lack of knowledge, you need to explain and educate it. Do some problem solving with the patient and develop a plan. And then they need to be given realistic goals that they can achieve. Remember that you always need to examine the insulin sites when the patient comes to you, but there could be a lot of local problems that the patient may have, like hypertrophy, or it could be possible that because there is a sort of induration that tends to happen when the patients inject themselves out there, there's no pain, and they prefer to inject in the indurated area. But what is the net result is that when you inject in such areas, the absorption of the insulin tends to get affected, and you find that the patient is really not getting to the goals because the insulin not getting absorbed, and due to no pain, the patient continues to inject in this in indurated areas. Now, lipohypertrophy looks a bit cosmetically bad, and patients are very concerned about this unsightly look. So that may sort of push back the patient in saying, I don't want to continue because it's making me look bad. I'm going to come to the next point, and we're going to discuss that what is a sort of a journey of insulin that has happened in the last 100 years, because we celebrated the centenary of insulin discovery last year. And obviously, over a period of time, right from the time that Banting, Best, Collip, and McLeod discovered insulin, there has been over a period of time a big journey in all the types of insulin. So if you look at the evolution of basal insulins, we have moved from animal insulins to monocomponent insulins, and then we have now moved on to analog insulins. Not only that, we have sort of now a longer duration of action. So when we had initially NPH, it was required to be taken twice a day. Then came Glargine, which was once a day, but it was not truly a 24-hour insulin. And now we've, of course, got an ultra-long-acting insulins like U300 Glargine and Degludec. So this has now made giving basal insulins a lot more easier, because you can give it once a day. It is flat and peakless, so the risk of hypoglycemia becomes extremely low. And as we're going to talk a little later, that there could be a flexibility of dosing time that you may have with the insulin, which makes it so much easy that the patient may not really miss insulin and may be able to take the insulin maybe a little ahead or later from his schedule. So let's talk about Degludec, because obviously that's a huge change and an innovation. And remember that when you have innovation of this kind, it is important that we should use it for the benefit of our patients. Now, various studies have shown that Degludec has proven to have a hypoglycemia benefit, and they have patients on Degludec have very low rates of hypoglycemia versus Glargine U100 or 300. There's much less glycemic variability day-to-day and intra-day with Degludec versus Glargine, and both U100 and U300. And as I mentioned earlier, there could be a flexibility of dosing, where Degludec can be taken plus or minus 8 to 48 hours. For U100, there is no flexibility, and for U300, there's a plus or minus 3 hours that the patient can take Glargine U300 if he misses it at the specified time. Now, we've also, remember that we do have a market for premix insulins, and a lot of us tend to use premix insulins in our clinical practice. And this comes more from the sake of convenience, because the patient is not ready to take multiple shots. Or it may be that the job profile of the patient does not allow the patient to take 3 times a day. So premix insulin is there, and it'll always be there. But we need to understand that, you have to make it safe. Because if you compare premix with a basal bolus, the rates of hypoglycemia with premix tends to be high. So you need to titrate your doses of premix very carefully. And you can see the journey of premix insulins, where you have gone from animal insulins to recombinant human insulin and then analog insulin. And now we, of course, got co-formulations, something akin to what we talk about basal plus. We've got a combination of Degludec and Aspart as a co-formulation. So IDEC-ASP is a very unique co-formulation, and this is almost to the regime that we talk about basal plus, where we look at what is the highest glycemia that a patient tends to get after a meal, and accordingly for that particular meal we give the the co-formulation, so that you get a blunting of the prandial response. And because of the long action of the degludec, the patient will get a basal coverage. So what does this result into? Lower hypoglycemia, mealtime flexibility, simple regime, convenience of dosing, improve quality of life, it becomes cost effective, and in most situations extremely effective. This has been all the delivery devices. So gone are the times when we were using glass syringes and a short, shaft of needle, which was sort of a steel sort of needle that was screwed on to top of the glass syringe. We then, of course, had more finer needles with finer gauges and plastic syringes. Then came, of course, the pens, which made it so much easier for people to get insulin. And then, of course, there were a period of time, we've got pumps, connected sort of insulin pens, and it makes it easier for a patient to know whether he's missed the insulin, how much is it taken, when did it take. So the connected pens are now becoming more and more sort of popular, although we don't have that in India. And then we're talking about artificial pancreas and many other discoveries, which are closing the loop. And these are sort of innovations that are for the future, and we hope we'll get them to use it pretty soon. So, I mean, when patients and physicians identify that, insulin injection is a burden, you find that with good controls, you find these sort of barriers tend to become lesser and lesser. So, we would obviously like insulin regimes where the patient may feel comfortable of not frequent dosing, but much lesser number of injections, which makes his life much better. So one of the most important barriers that you tend to have with patients as well as for doctors is that, there are too many injection shots that the patient needs to take. Imagine a type 1 taking 4 times a day all his life and the number of injections that he needs to inject himself. Similarly, patients who have on basal bolus needs to take 4 shots permanently, and that can be quite a deterrent. So we need to have technology where you may be able to get similar effects with much lesser number of injections. And today we've got insulins like Icodec, where you can give it once a week, and that would suffice. And we have done the trials for Icodec. We find that there is no change in effect or adverse events when you look at it from a daily injection like glargine. And almost 33% of the patients omit that dose or are non-adherent, again, because of too much of frequent dosing, or, they don't have the time, or they find it difficult to adjust the insulin and the meals within their work timings. So you need to have a more simplified insulin regime, which makes it easy for the patient to take. So I'm going to leave you behind with a
I think it got disconnected. So, Ami, can we introduce the next? Or are we done? Yeah, Meenal is there.
Yeah. So after this wonderful talk by Dr. Sanjay Agarwal on insulins in type 2 diabetes, we move on to the next talk by Dr. Meenal Mohit. She's going to be discussing about designing insulin regimens in type 1 diabetes patient, which about an endocrinologist gimmick. So introducing Dr. Meenal Mohit, she's the consultant and head Department of Endocrinology at Manipal Hospital, Jaipur, and been a mentor of Team India, which won the Osler Cup in ACP 2021, pioneer of the Cloud Clinic, been a reviewer and editor of various journals, founder of Women Practitioners Forum, governing council member of RSSDI Rajasthan chapter, and has many affiliations and publications to her credit. Over to you, ma'am.
Thank you, Ami ma'am. Thank you so much. And thank you, Dr. Rajiv sir and Shalini ma'am, for inviting me to this platform. And I'm sorry for a little disturbance that the talk had to be shifted. Can you, ma'am, allow me to share the screen, please?
Neelam, dekho, please.
Yes, ma'am, you can share your screen.
Yeah, ma'am. Yeah. So my screen is visible, I hope.
Yes, it is.
Yes, ma'am. So the topic that has been assigned to me by the organizers is talking about type 1 diabetes and designing insulin regime in type 1. So let me do justice to the topic. So I would begin with a little introduction of the disease. It's a condition which is autoimmune in nature, resulting due to the destruction of beta cells due to autoantibodies. And the prevalence of the condition is around 10% of the total burden of diabetes. The condition is seen in children who are genetically predisposed, though it is an idiopathic condition because we do not have a definite cause of the underlying disease. But it is said that there are some predisposing factors in the genetically predisposed children, something like viral infections, or it can be some early dietary introduction, some environmental toxins, which can lead to type 1 diabetes. The symptoms remain almost as type 2, that is polyuria, polydipsia, weight loss, fatigued, all osmotic symptoms actually. One big clue is that suppose a child has overgrown the age of bedwetting and then restarts bedwetting, there's a very strong pointer that the child is developing hyperglycemia. So there can be stomach aches, which can be one pointer towards ketosis. Then again, nausea, vomiting, a condition of ketosis, maybe feeling drowsy, significant hyperglycemia with acidotic breathing or Kussmaul's breathing. So these are the pointers towards the seriousness of the condition. Now, what are the major antibodies that we come across in this condition are the GAD antibodies or the islet cell antibodies, insulin antibodies, and the zinc transporter 8 antibodies. These are the antibodies we look for in the condition. Now, the role of these antibodies are that these antibodies are actually the primary markers. If you look for the antibodies, though we do not routinely look for the antibodies, but if you look for the antibodies, you will find that these antibodies are present much before the clinical initiation of the disease. So before even the hyperglycemia or the dysglycemia begins, there is presence of antibodies. So these antibodies play a significant role in as a clinical pointer or as a lab pointer. These antibodies are responsible for the destruction of the beta cells and autoantibodies, which lead to the ultimately destruction of beta cells and lead to hyperglycemia. So the disease progresses from stage 1, which is a preclinical stage, to stage 2, and finally the overt hyperglycemic or type 1 diabetes as we know it. Now, coming to the management of the condition is not a one-man's job. It is an army, the army requiring the presence of a doctor, a diet coach, a psychologist. We require a diabetic nurse. We require the entire school support. At times, the teachers play a very important role because the child spends a significant time in school. Then, of course, we as doctors counsel maybe once a month or once in 3 months rather. The major role is played by the family because the mother or the father or any guardian has to act as the nurse and inject insulin, monitor sugars. So ultimately, diabetes or type 1 diabetes is not one man's job. It requires a whole spectrum of, it requires a team, actually it's a teamwork. And coming to the teamwork and coming to like what all is required, you begin with glycemic management, of course. The first thing is hyperglycemia is there and we need to manage sugars. So to manage sugars, you need to have the normal values and then you have to monitor sugars. Then 3-monthly HbA1c needs to be done. Following up these children for the initial 5 years, maybe there are no complications as micro and macrovascular complications, but after 5 years, you need to look for conditions like nephropathy, retinopathy, neuropathy, even macrovascular complications. They are not aloof from that also. So macrovascular complications will also set in eventually if the disease is not, if the glycemia is not controlled. So you have to keep looking for blood pressure, lipids, and adolescence is a very important part. All children are the growing children. So there will come a stage when you need to counsel them for alcohol intake, for smoking, the no smoking, no alcohol. Then lifestyle changes will take place. The puberty will set in. The puberty might be delayed if the sugars are not controlled. The height, the growth parameters have to be looked into. So type 1 diabetes management is actually a huge burden for the consultants also. And we need to have various parameters in our mind when we are managing type 1. Then being an autoimmune condition, other than type 1 diabetes, there are other autoantibodies also present. So there is at times a spectrum of coexisting autoimmune conditions, and the most common ones being the hypothyroidism or even the wheat allergy or the celiac disease is coexisting. Then, of course, there very rarely you can also find other autoimmune diseases existing. So you might have to look for the other conditions also. So keep your vision open. And there are guidelines which suggest that at least at diagnosis and then in follow-up annually, you must screen these children for thyroid antibodies, that is the TPO antibodies and the TTG antibodies. Now coming to the topic, that is the glycemic management. As per the SPAT guidelines, you have various parameters have been laid down. If you're looking for a random prick, then your sugars should range between 70 to 180 milligram per DL. The HbA1c targets, though in children we take a liberal target, we do not target actually 6%, but definitely there's no harm in keeping a good control. Now we have a newer parameter in view of the CGM, that is the time in range parameter. So we target keeping our children almost 70% of their times within range. So the 70% of TIR or time in range correlates with your HbA1c of 7. So these are the latest SPAT guidelines. Now coming to the insulin regimes or the treatments. So insulin is the prima facie treatment and the only option we have available. And as of now, we have only injectable insulins. So insulin therapy is the major pillar of the treatment. Along with insulin, we need to have a continuous monitoring of sugars. Regular may not be the continuous word. We should have a regular sugar monitoring. Then we have to focus on the dietary part, that is the medical nutrition therapy also, and the regular exercise, though it is type 1, but the importance of exercise cannot be undermined. Now the insulin therapy. This is the physiological phenomenon, how the insulin is released in our body. So we have a basal insulin level, which persists in our system all 24 hours. And every time we consume some meal, there is further insulin release from the pancreas. So there is a first phase release, and then there is a late phase, a second phase release. So every meal is followed by insulin release from the pancreas. So there is a prandial peak, and then there is this is the first phase, and then the second phase of insulin release. So what we do, we try to mimic this physiology whenever we are trying to manage our children with type 1 diabetes. I'm repeatedly using the word children because we have the burden of children as type 1, though I'm not denying that we have type 1 and at a later age also, the late onset also nowadays. So age is no more a criteria, but keeping to the burden, the preponderance of children in that parameter. So I'm using the word children here. So we try to mimic the normal physiology. So how do we do this? We are always aiming that the sugars should remain in the target range. The targets we have already discussed. So we try to mimic physiology. Very rarely there are prescriptions coming across when we do see split mix regimes or the pre-mix insulins, or rather when the children grow up and they are into adulthood and they have a very definite pattern of meal, a very definite routine, disciplined life. At that time, they themselves at times request and switch over to the split mix or pre-mix insulins. But the standard treatment plan or the insulin regime that we prescribe or we use or we design for children with type 1 is a basal bolus regime or a multiple daily injection regime. So MDI regime or the basal bolus is a standard of care in type 1 diabetes management. So what are the various insulins that we have that we are using for children? Though Dr. Sanjay has talked about various types of insulins available, I will just make a small repetition. So we begin with the regular insulins, that is the prandial insulins. So this regular insulin are the older conventional insulins, which have an onset of action around 30 minutes. They peak in around 2 hours and they wane off around 6 to 8 hours. So these are the insulins that we are using for meal to control the hyperglycemia or the glycemic burden of the meal. Then after along with the regular insulin, which is given in 3 divisions, like with breakfast, lunch, and dinner, we are using a basal insulin. So the older basal insulin that was available to us was NPH, that is the neutral protamine hagedon. NPH, as we all know, had a slower onset of action. So it started working around after 2 hours, peaked in around 6 hours, and acted for around 14 to 16 hours. Now with this older insulins or the conventional insulins, that is the regular and the NPH insulin, there was not exactly mimicking of the physiology because the first phase release could not be mimicked with insulin, which is starting to act after 30 minutes. The first phase is definitely not there. NPH is not a true basal because it does not act for more than 14 to 16 hours. So we needed to give it twice at times. So there were in all some 5 pricks. Then we moved on to the genetically engineered insulins or the analog insulins as we know them. And we came to have some rapid insulins in our basket. The three of them, the Lispro, Aspart, and Glulysin, they are the three rapid-acting insulins. They start acting within 5 minutes, peak in 30 minutes. So now that becomes the normal physiological peak, that is 30 minutes, which it is exactly mimicking our normal physiology. And they do act for next 2 hours and they wane off in the next 2 hours. So total duration of action is around 4 hours, 4 to 6 hours. So these are the rapid acting insulins. Now to add to that, though the figure is not depicting here, we have ultra rapid acting insulins also available to our asset. And we are also using the ultra rapid acting insulins at times. At the same time, for the basal insulins, we have moved from NPH to the basal insulins, which were also genetically engineered analog insulins. The first of them was Glargine. Glargine was a boon actually, and it was starting to act within 1 hour. And after 1 hour, it was having a plateau effect, and the action lasted almost 20-22 hours. So it was waning off by the time the day was over, nearing around 24 hours, but at least it gave us a plateau, and it was almost a plateauing effect. So the hypoglycemias were avoided, and a good euglycemia was maintained for pretty long hours, like almost around 20-22 hours. Then after Glargine, we had another new molecule, which was another engineered molecule, analog insulin, that is Degludec. Detamir was another molecule which was introduced in between, but Detamir did no wonders. It was no better than NPH. It always acted around 16 hours. So after Glargine, the new molecule which was of great asset was Degludec. The Degludec is a molecule which is acting for almost 36 hours. It is a true peakless insulin. It does not give any hypoglycemias, and it does not allow hyperglycemias. So we had a normal actual physiological mimicking with rapid and Degludec. So these were the insulins we are now using regularly. Now coming to the regimes actually, if you talk of only using basal, so you can use only basal, that is once daily, but this will only control your fasting and will give you a smooth control over the next few hours, 24 hours, but the prandial peaks will not be covered. So though it remains one of the simple regimes, there will be no hypos, but you cannot avoid the prandial hyperglycemias. So this is not a very good regime in itself, but basal insulin is one of the component of the regime which we actually are prescribing. Then comes the premix insulin. Now, premix insulin is one of the very good insulins because it is relatively easy. It is decreasing your number of pricks, and it is only taken twice a day, the low premix, or it can be taken thrice a day if you're using a high premix. But in children, the dose does not actually go up to high premixes. But then premixes are not the insulins for children actually. It is not the recommended insulins and not justified also, because these premixes are very difficult to adjust. If you up titrate one component, the other component is also up titrated. And that leads to fluctuating hypos and hypers, and the ping pong effect exists. So this is not one of the regimes that we are recommending regularly or routinely for children with diabetes, that is type 1 diabetes. So the standard of care is the basal bolus regime, which mimics physiology. So it gives us better control without, I should not say it's giving more hypos, rather it's giving a very smooth control. The only thing is you should know how to justify the dose or calculate the dose. So that brings us to how to calculate the dose. Okay. Before we go to how to calculate the dose, let's have a look at our MDI regime or the basal bolus regime. So the plasma insulin, the basal insulin gives you that basal mimicking, and the prandial insulin gives you these prandial peaks which are covered. So combining the basal bolus, you get something which is mimicking the normal physiology. So this is again a repetition. If you are using Glargine, this is giving you a basal control. Then if you are using NPH, NPH will give you a peak and then there will be a dipping. So at the peak, you will have a hypoglycemia, which can be a midnight hypoglycemia. Whereas when it wanes off, you will have a hyperglycemia. So this will be a fluctuating effect of sugars. It will be clinically seen as a sugars are fluctuating significantly. If you are using a premix, again, you will have a the 30% component will give you a prandial control and the 70% will give you a longer control. But then again, you will have the same hyper effects. So these are not the regimes which we are recommending in children. We are using the basal bolus regime. So when you are prescribing a basal bolus regime, how do we begin? We begin with body weight. So with body weight, you begin with either 0.7 to 1 units per kg, depending upon the hyperglycemic status, depending upon the child, depending upon the background. You can choose whether you want to begin with 0.7 units or you can begin with 1 unit per kg per day. And this gives you the total daily dose. If the child is around puberty, you can begin with 1 to 2 units per kg per day, because around puberty, there are other sex hormones which are into play, which are the counter-regulatory hormones, which also give a rise in the sugars. So always aim that your sugars are bringing down the sugars to the normal range. And whenever the child will have meal, the meal will give a rise of sugars to around 30 to 60 milligrams. Rise will be there.
Minal ma'am.
Sorry.
Can we wind up in another 2 or 3 minutes, please?
Okay. So this is the dose. Okay, no worries. So this is the dose. I will just tell you how to use it. So these are the insulins which we have, the 40 units and the 100 IU syringes are available, but these syringes we are not using anymore. We have the wonderful devices available. We have the insulin pens available, which we are using. So these are the sites. The rotation is mandatory. You have to keep rotating. So these are the various sites of insulin injection. We know the abdomen is the fastest and the buttocks is the least slowest to act. Now, the dose calculation, you have to keep in mind two important things while calculating the dose. One is the insulin sensitivity factor. So to calculate the ISF, you have to have the TDD, that is the total daily dose, which you get from the body weight. And then 1800 upon TDD, that is the ISF. ISF is like 1 unit of insulin will lower down the blood glucose by 60 milligrams. So every child will have a different ISF that we have to know. Along with ISF, that is the insulin sensitivity factor, you should also know what is the insulin carb ratio. So insulin carb ratio is like for 1 serving of carbohydrate, how much unit of insulin is required. So ICR is calculated from 500 upon TDD. So TDD is mandatory to know, that is a total daily dose is mandatory to know. After knowing the TDD, you should calculate your ISF and the ICR. Having ICR and ISF with you, you can calculate how much insulin is required. I'll just take one example so that the things are clear. Suppose we have ICR of 1 unit is giving us covering a carb of 16 grams, and ISF of this particular child is 60, that is 1 unit will drop down the sugars by 60. And the carb meal that the child is going to consume is 75 grams. So for 75 grams, as per the ICR, because 1 unit is required for 16 grams, for 75 grams, the child will require around 4.5 units. And if the sugar is already 200 and the target is around 100 and the sugars you need to bring down that sugars from existing to the normal, you have to know the ISF. So by dividing by 60, you will get the 2.5 units is required to achieve the target value. So the total insulin that is required by this child to consume 75 grams of carbohydrate is 4.5 plus 2.5. So that gives us the 7 units. So this is how you have to know. You should know the carb count. You should know the ISF and ICR values of every child, every patient. And you can teach the patients, teach the mothers or the fathers, and make them do the homework. Now we have the advancements in technology, that is insulin pumps are available. You can introduce the pumps to patients if they are affording. This is a little pricey device, but you can definitely use it. Sugar monitoring is mandatory because of lacking short in time. I will not go into the details, but yes, SMBG is mandatory. Teach the child, motivate the family to monitor sugars, keep a record of all the sugars and the targets, explain the targets. At fasting sugars, we need around 70 to 130. Post meal, we are targeting 90 to 180, and bedtime sugar is mandatory. Do not allow the child to sleep without a bedtime sugars because we don't want any midnight hypoglycemias. So these are the advancements. We have moved from this to this technology, right? The CGMs are available, but the time Neelam is saying I should wind up. So let's
wind up. So sorry.
No, ma'am, that's fine. Of course, I have to keep to time. So this is how we are designing insulin plans for type 1 children. And one important message before I leave, the sick day, if the child is sick, vomiting, or in any other condition, don't skip insulin. You can reduce the dose of insulin, keep monitoring, increase the sugar monitoring, but don't skip insulin. Otherwise, the child will go into diabetic ketoacidosis. So some amount of insulin is definitely required. Go on feeding the child as small quantity as possible and replace the fluid. And please you can reduce insulin, monitor sugars, but don't skip insulins. So that is about regimes in type 1. Thank you so much. Once again, Shalini ma'am, Rajiv sir, thank you for inviting me here. And this is about type 1 and diabetes management.
Thank you so much, Dr. Meenal, for that very comprehensive talk. And I'm sorry we had to cut you short because we are all exceeding time and we have the next session very soon. So thank you so much, chairpersons, Dr. Rami Sangvi and Dr. Vijay Negalur, sir. And of course, my speakers, Dr. Sanjay Agarwal, sir, and Dr. Meenal, for that wonderful deliberation in the Insulin Symposium. And I'm sure our audience goes back much richer. So thank you so much. And we move on to the next symposium, a very, very important trilogue on diabetes management beyond glucose control. And to chair the session, we have none other than Dr. Anil Bhoraskar, sir, a very senior faculty. Can I have his CV here? Welcome, sir. Dr. Bhoraskar, as all of us know, has been the ex-chairman of IDF Southeast Asia. He's Honorary Secretary, Scientific Section, Diabetic Association of India, member, Executive Managing Council, Diabetic Association of India. And to co-chair the session with him, may I invite Dr. N.K. Singh, sir, EC member, National RSSDI, diabetologist, physician, director, Diabetes and Heart Research Center, Dhanbad, and our very own founder member and the administrator of the CME India group, where all of us interact and learn a lot on a daily basis. So welcome, chairpersons, and I request you to invite our speakers for this trilogue.
Good evening. I think, can I start or sir, that Anil sir can I start? Yeah.
So anyway, you can start.
Yeah. So I think this is a great pleasure, Dr. Salni and Dr. Chawla sir, for inviting for, I think this is one of the most important session you have today. The first talk goes to Dr. Anshul Kumar. He's DM Endocrinology, Consultant Endocrinologist at Maharaja Agreshan Hospital, Punjabi Bagh. He has attended and participated in various national and international conferences. He is a member of ESI, that is RSSDI and other organizations. He is very well updated with all the latest advancements and done so many prestigious works and awards he has won. So I think his talk is very, very important today. What is the diabetologist perspective today with this diabetes management which goes beyond the glucose content? So Dr. Anshul Kumar, please. The stage is yours.
Yeah. Thank you, sir. I just start sharing my screen. So I hope the screen is visible to everyone.
Yes, it is.
All right. So hi. So I'm Dr. Anshul, and today I'll be talking about diabetes management beyond glucose control, a diabetologist's perspective. So we are the first point of contact mostly for diabetes patients. After that, once they develop complications, they tend to diversify to cardiologist, to nephrologist, but the first point of contact is a diabetologist. So today, we'll be talking on various topics, varying from patient education, medication management, regular monitoring. We'll also talk about the various complications that occur in diabetes, as well as the long-term management and psychosocial support. So starting off, patient education. So effective conversation is always the key. So we need to start conversation shortly after diagnosis. So we need to ascertain how the patient feels about diabetes. There's a stigma which is attached to diabetes, and the patient always has several questions which vary from how diabetes is going to affect his lifestyle, his work, and then his major stigma which is attached, and like Dr. Sanjay Agarwal was also talking about, is the patient needs to be reeled in that there might eventually be a stage where he needs to be put on insulin, and this stigma needs to be done away with initially. We need to explain and educate the patient and tell the patient what the disease is and what can be done by the patient apart from medications to control the disease. We need to sit down with the patient and solve the problem of diabetes. Then we need to develop a plan together. So major concern here is that most of us, what we do is we give the patient a diet chart. But the patient, as we know that in India, the patient could be from any part of India and with the staple carb could be different, the protein intake could be different. So we need to sit down with the patient, tell the patient how and what changes can be done to the diet. And then, of course, we need to set expectations. So with the remission, diabetes remission, and all of these platforms selling even diabetes reversal, which cannot be done. Diabetes remission, which has come in vogue, we need to tell the patient what can be done, what are the steps that can be taken to go into diabetes remission, and what diabetes remission actually means. So then moving on to lifestyle modifications. So first of all, of course, there is nutritional therapy, medical nutritional therapy, which we've already talked about. It includes various kinds of diet. That could be Mediterranean diet, DASH diet, but the most effective is a change which is done to the patient's preferred diet. Because we can ask the patient to switch to Mediterranean diet and tell him all the benefits that there are, but shifting the diet completely is something that we need to consider near about impossible. Physical activity, again, more than 150 minutes of moderate intensity physical workout. Whatever the patient prefers, we need to tell him what moderate intensity workout means. Then strength training needs to be added to the physical regimen. Weight management, as we all know, weight loss is one of the major disease modifying factors. In fact, the only disease modifying factor that we have. 5 to 10% of the weight loss can lead to even control of sugar levels, control of dyslipidemia, control of hypertension, and a loss of more than 15% of the weight can even lead to diabetes remission. Alcohol and smoking, both are habits which along with diabetes, increase the risk of cardiovascular disease, which Sir will be talking in the next lecture. And patients should be asked to desist from drinking or smoking. And of course, psychosocial support and psychological support. Patient needs to be told that he's doing okay, and a little, if the patient, even the HbA1c is high, patient needs to be prodded along, and that what the patient is doing, he should be told what the patient is doing wrong. We should tell him in a better way does not stigmatize the patient. So what are our expectations from the newer anti-diabetic drugs? So with the advent of GLP-1 RAs and SGLT2 inhibitors, we know that we have agents with us which are not just cardio safe, but in fact cardiac protective. In fact, nephroprotective as well. So we need to balance the glycemic control, which is an HbA1c of roughly 7, and along with a low risk of hypoglycemia. We also need to look at off-target effects. So, for example, SGLT2 inhibitors and GLP-1 RAs are now prescribed irrespective of their HbA1c control in patients who have CKD or are at a high risk of atherosclerotic cardiovascular disease. We need to also consider agents which at least are weight neutral or cause weight loss. So this would somehow deter us from using sulfonylureas early on in the treatment. So moving on. So this is the famous ominous octet of type 2 diabetes. Pancreas decrease beta cell function leading to decreased insulin secretion, increase alpha cell activity leading to increased glucagon secretion, increase hepatic gluconeogenesis, neurotransmitter dysfunction leading to appetite control and appetite affecting the appetite. Skeletal muscles leads to decreased glucose uptake. Again, increased glucose reabsorption in the kidneys and increased lipolysis. So we need to focus, and especially when the patient comes to us with an HbA1c which is 7.5 or 9, where we are at the outset, we need to use multiple drugs. So the combination should be rational. So we need to target various arms of this octopus. So the drugs which affect the impaired insulin secretion, GLP-1 RAs, they cause glucose-dependent insulin release, along with DPP-4 inhibitors. Sulfonylureas directly act on the beta cell and increase insulin secretion. Increase hepatic glucose production by GLP-1 RAs, metformin, DPP-4 inhibitors. Same goes for impaired appetite regulation with GLP-1 RAs, decreased glucose uptake. Again, there's GLP-1 RAs, SGLT2 inhibitors. So what we looking here is GLP-1 RAs affect roughly around 6 out of the 8 arms of the octopus. lupus, and SGLT2 inhibitors are affecting two arms. So what we need to look at while using the various drugs and various salts is that the salts should not work against each other or should not belong to the same group. So if we are using drugs, so GLP-1 RAs and DPP-4 inhibitors is one such example where we should not use the same drugs. The same goes for sulfonylurea. So I'm sure most of us have seen prescriptions where there is gliclazide along with glimepiride, along with meglitinides. So these are irrational combinations which should not ideally be used. So these are the pleiotropic benefits of insulin. It has anti-inflammatory, antioxidant, anti-thrombotic effects. Good glycemic control tends to prevent all of these complications that can happen because of dysglycemia. So initially, like we were talking, there was a glucocentric management. The focus was on HbA1c control. Then we moved on to a CV safety criteria. That this was the post-pioglitazone, rosiglitazone era, where it was mandatory that we need to prove that the drugs that we're using are CV safe. So HbA1c lowering should be done without weight gain, hypoglycemia, or side effects. And now we are in an era of vascular glucocentric approach, where, like I just spoke, that irrespective of the HbA1c, if the patient is at a high risk or has an existing atherosclerotic cardiovascular disease or CKD, we need to add a protective agent like an SGLT2 inhibitor or GLP-1 RA, with proven benefits, of course. So we now monitor blood pressure, LDL cholesterol, glucose lowering with the agents of proven safety and efficacy. We need to make personalized care plan, breaking the one-size-fits-all mold. So glycemic control with minimum risk of hypoglycemia. We need to consider several factors like age, life expectancy. So we don't tend to target an HbA1c of 7 or 7.5 in an elderly individual because the risk of hypoglycemia increases. So same goes for glycemic targets. So glycemic targets certainly for a younger individual would be much tighter as compared to an older individual who has a greater risk of falls due to hypoglycemia, even brain injury for that matter. Diet patterns, cost, motivation, becomes an issue, especially in India, where GLP-1 RAs are involved. We talk about GLP-1 RAs a lot, but for most of the people, cost is a major deterrent for a majority of Indian population. Motivational aspects, of course, patients need to be motivated repeatedly regarding what the drugs, the sugar control, sugar monitoring, like Meenal ma'am was talking, and flexibility and simplicity of the regimen. So comprehensive medical evaluation, you just skip this. This is a decision cycle for person-centered glycemic management, which was just published in Standard of Care by the ADA. So regular monitoring and prevention of complications. So despite availability of numerous treatment options, diabetes management is a major challenge. It is still the 9th major cause of death. So they have 50% of the people present with microvascular complications. There are macrovascular complications. 25% of people have diabetic kidney disease. So what are the lab investigations that we need to do? So lipid profile, including LDL, HDL cholesterol, need to be done annually and at the initial visit. Liver function test, again, repeated annually, spot urinary albumin creatinine ratio. So we'll talk about this individually. So first of all is screening for nephropathy. So annual creatinine and eGFR calculation need to put and label the patient as CKD stage 2 or stage 3 with the microalbuminuria, of course. And diagnose. So this needs to start a diagnosis for type 2 and 5 years after diagnosis of type 1 or at puberty, of course. Management is ACE inhibitors, ARB. I'm sure sir will be talking about this in much detail. Serum creatinine and creatinine clearance for GFR. Patient may even need a 24-hour urine protein. So and a referral to nephrology, which especially becomes very important if we are suspecting a non-diabetic cause for the kidney disease, which might be the case, especially in diabetic kidney diseases which are present without retinopathy and develop much earlier with a very high protein excretion or no protein excretion in both cases. Retinopathy, it needs to be done by a fundus examination always. Management is, of course, A1C, maintain an A1C of less than 7 and laser photocoagulation by ophthalmologist or retinologist. Neuropathy screening to be done at diagnosis and annually. We need to be aware of the less common presentations like Brugh-Galvin syndrome, for example, or truncal neuropathy. foot inspection on every visit plus annual peripheral neuropathy testing, filament testing, vibration testing, reflexes. So these need to be done at least annually if it's not already present. Management includes, of course, drugs like pregabalin, gabapentin, duloxetine, amitriptyline, capsaicin cream in case of truncal neuropathy. B12 deficiency needs to be ruled out. Hypothyroidism needs to be ruled out. Alcohol use needs to be ruled out. And we need to, of course, optimize blood glucose control. Diabetes foot exam needs to be done at every visit. Visual inspection of skin, nails, lesions, color, deformity. Then we come to liver disease. So NAFLD and type 2 diabetes, now it's known as metabolic syndrome associated liver disease, of course. So less than 5% fat is what is normally found in liver. As non-alcoholic fatty liver or metabolically affected fatty liver progresses, this fat deposition increases to more than 5%, leading to steatosis, inflammation, which progresses to NASH, then fibrosis, and finally cirrhosis and hepatocellular carcinoma. All of this increases the risk of cardiovascular diseases as well. So this is something which I don't think most of us do, and I certainly did not, is the calculation of a FIB4 index. So FIB4 is a mathematical formula using SGOT, SGPT, known as AST, ALT, and the platelet counts. And it is classified into 3 categories. So less than 1.3 is a low risk patient. And for a low risk patient, a diabetologist or a physician or an endocrinologist can take care of a patient who is at a low risk. Indeterminate risk with the FIB4 of between 1.3 and 2.6, the patient needs to be referred for a fibroscan or an ELF blood test. So this usually requires a referral to a liver specialist. And finally, somebody who is at a high risk is somebody who has a FIB4 index of more than 2.67. Of course, in conjugation with this, we need to look at the other risk factors as well: age, BMI, metabolic risk factors. So all of these patients invariably need a referral to a gastroenterologist for further management. How do we manage is the primary, the pillar of management of NAFLD is, of course, the weight loss and a healthy diet, physical activity. GLP-1 RAs, SGLT2 inhibitors, even pioglitazone has a role. Vitamin E, to an extent, in a non-diabetic has been shown to improve even fibrosis. And whereas in cirrhosis, the management is mostly symptomatic. Another screening level that needs to be done is celiac disease and thyroid, especially type 1 diabetes. So we need to address multifactorial challenges. We need to improve CV outcomes, increase glucose intake, glucose uptake by heart, vasodilation. So these are all the effects which improve the cardiovascular safety. So as we know, since 2016, the guidelines have evolved towards a paradigm shift. So initially, the ADA-ASD guideline were focused on glycemic control, which then moved to CV and mortality benefits. Then in 2018, benefits in atherosclerotic cardiovascular disease and chronic heart failure. In 2019, now GLP-1 RAs and SGLT2 inhibitors were even proven CVD benefits were even introduced before metformin in the European Society of Cardiology. And since 2020, now independent of HbA1c levels in patients who are at risk of atherosclerotic cardiovascular disease, have heart failure or CKD, GLP-1 RAs with or SGLT2 inhibitors with proven benefit need to be added. So multicentric framework for diabetes management is recommended. So finally, what the take-home message would be is that the patient-centered approach needs to be used to guide the choice of pharmacological agents. We need to individualize. We cannot follow the guidelines blindly, depending on what the patient profile is, what the patient's economic health is, what the patient's weight is, and what the patient's age is. All of these factors need to be taken into account to decide what drugs are to be given. Considerations include, of course, like I said, atherosclerotic cardiovascular disease, heart failure, chronic kidney disease. Among patients with type 2 diabetes who have established atherosclerotic cardiovascular disease, SGLT2 inhibitors or GLP-1 RAs with demonstrated cardiovascular benefit needs to be recommended. Among patients with atherosclerotic cardiovascular disease who are at a high risk of heart failure or in whom heart failure coexists, SGLT2 inhibitors are preferred. For patients with type 2 diabetes and CKD, consider use of SGLT2 inhibitors and GLP-1RA, which have been shown to reduce chronic kidney disease progression and cardiovascular events. Thank you.
That was a very comprehensive summary of what a good diabetologist would do in his clinic. I only want to ask you one question. That I don't know in your setting, how the things. In my setting, there are many patients who come to see me. They are basically coming after passing their PhD from Google University. And their basic objective is to come to judge whether Dr. Boroskar has got adequate knowledge. And the questions also are highly focused because they have got 4 or 5 different schools which teach them keto diet, which teach them something fat diet, they teach something different diets. And the fat diets which are prevalent, so rampant, which are unregulated. The regulated press, there is no control. And this kind of people create a lot of problems. Second thing, I think you have possibly because of a large amount of studies that you have presented. I always tell my students, if the patient has got HbA1c of 8, but his systolic blood pressure is more than 160, you run after that systolic blood pressure. A systolic blood pressure of more than 160 is a bigger risk factor, particularly in type 2 diabetes, that we see so much of nephropathy now that we have to really, and we have got such excellent antihypertensive agents, multiple drugs. So we have to target a good tight control of hypertension along with lipids. And of course, NASH is also very common. Non-alcoholic steatohepatitis. I feel almost 40% of Bombay's population has got one finger palpable liver when they come in clinical examination. Of course, we don't investigate through FibroScan and all those fancy things, but we tell them to reduce their weight reduction, and the salaglitazole is another good drug which we are using, and we find good results. So very nicely put, doctor, and I'm very happy you brought some very, very important points, and I really congratulate you. Thank you very much.
Thank you, sir.
I think we will have now moving to the next session. Can we have the CV of the next speaker? Yeah. J.C. Mohan is currently chairman of Institute of Heart and Vascular Disease in New Delhi, consultant emeritus Fortis Hospital, Shalimar Bagh. So we are basically colleagues. I am also from Fortis Hospital. Over 370 index publications, 3 books and 87 chapters. So I think the word Mohan goes with severe academicians and astute clinicians as well as scholars. Past president, Indian Academy of Echocardiography, current president of Apex Society of CME in Cardiology, Lifetime Achievement Award by the Indian Academy of Echocardiography, and Lifetime Achievement Award by Cardiological Society of India. So we have such an illustrious and such a learned, scholarly gentleman giving us his viewpoints on associated comorbidities of a diabetic patient. Over to you, Dr. J.C. Mohan.
Thank you, sir. And let me just get myself up. Okay. Thank you. The mandate given to me is to talk about diabetes management beyond glucose control, a cardiologist perspective. We, of course, have very recent data from India published 2 months back by Ranjit Mohan Anjana showing that diabetes there in 11.4% of the adult population, hypertension 3 times more common, 36%, dyslipidemia and 81%, and obesity 28.6%. Obviously, that states that these cardiometabolic health of Indian society is quite poor. When you talk of newly diagnosed diabetes in India, the interesting thing is virtually everybody is dyslipidemic. And this is data by Dr. Unni Krishnan published few months back again, showing that CKD stage 3 or more is present in 22%, hypertension in 42%. Virtually every diabetic in this country has dyslipidemia, 96.5%. So there is coupling of multiple cardiovascular risk factors when you see a patient with diabetes. So there is no surprise that there is a pandemic of type 2 diabetes and atherosclerotic cardiovascular disease that appear to parallel the widespread prevalence of vascular mortality and heart failure. The lifetime risk of developing cardiovascular disease in diabetes is 75% or more, and 70% of all deaths in diabetes are cardiovascular, unlike non-diabetic individuals where 70% deaths are non-cardiovascular and only 30% deaths are cardiovascular. Cardiovascular deaths in diabetes are both because of macroangiopathy, or you call it atherothrombosis, which is myocardial stroke, and pulmonary embolism, or because of microangiopathy or non-atherosclerotic cardiomyopathy and heart failure. The data now suggests that there is share of 50% to each of these phenomena with regard to cardiovascular death. We have heard from the previous speaker the journey from risk factors to diabetes to cardiovascular disease, including the role of lifestyle, bad lifestyle, and of course, also the role of conventional risk factor, including environmental pollution, and the mechanism through which diabetes causes cardiovascular disease. But the situation at the moment is that every time you see a patient of diabetes in clinic, 1/3 of these patients would have cardiovascular disease, 90% of that is atherosclerotic cardiovascular disease, and every 6th patient has heart failure. So when you see a patient diabetes in OPD, it is true that there will be no structural or functional change in the heart in 30 to 50% individuals. You would see overt atherosclerotic cardiovascular disease in 30% of these individuals, and the rest individuals will have structural or functional change in the heart, so-called diabetic cardiomyopathy, which largely is preclinical. To some extent, it may be clinical and present as heart failure. And there has been a paradigm shift, as Dr. Anshul said, that now we focus on vascular-glucocentric approach towards managing diabetes, and there comes the role of cardiologist. So what are we going to discuss? How to risk stratify diabetes patients with regard to cardiovascular risk? What are the available therapeutic options according to new ESC 2023 guidelines issued 3 weeks back? And what do the latest guidelines recommend? And when do we escalate or switch therapy? 2019, the European Society of Cardiology categorized patients with diabetes into 3 categories: very high risk, and moderate risk. Depending upon the duration of diabetes, depending on the presence of atherosclerotic cardiovascular disease, target organ damage, and risk factors. This was a pretty simple way of risk stratifying diabetic individuals. However, it has been improved recently, just few months back, by SCORE2 diabetes risk calculator, which largely applies to Europe, hasn't been validated in India. Besides the conventional risk factors for cardiovascular disease, the 3 more factors are taken in account, and that is age at diagnosis of diabetes, HbA1c level at the time of evaluating the patient, and of course the eGFR. The SCORE2 diabetes has been given a class 1A recommendation by the European Society of Cardiology in 2023 that the calculator should be used in every diabetic patient. Remember, this is a situation in Europe, and of course they have categorized patients in 4 different categories with more than 20% risk of cardiovascular disease in 10 years, very high risk, 10 to 20%, high risk, 5 to less than 10% moderate risk, less than 5% is low risk. So this is clear that these individuals suggest aggressive, or this ESC body suggests being more aggressive in patients who are very high risk and high risk individuals. Now it so happens that the SCORE2 risk calculator shows that in Europe, 61 to 96% men have a 10-year risk more than 10%. Women have 51 to 94%. Although there is a regional variation in Europe. But my submission is if we use an ethnicity multiplication factor of 1.5, then in India, more than 90% patient will be high risk or very high risk. What kind of evidence have we got? Well, first thing is that UK Biobank prospective cohort study shows that coronary artery disease is 2.5 times more common in South Asians, and heart failure is almost twice more common in South Asians compared to Caucasians. And of course, the cardiovascular disease in general occurs 4 years earlier, although we keep harping on the fact that it occurs 10 years earlier. But the data published shows that compared to European, South Asians develop cardiovascular disease 4 years earlier when they are residing in United Kingdom. This data from Dr. Unnikrishnan is very interesting. This is talking about newly diagnosed diabetic individuals with a mean age of 42 years. Using the Lipid Association of India criteria of risk, 60.5% patients have very high risk for cardiovascular disease, and that means more than 20% 10 years risk of cardiovascular disease, and rest have high risk. There are no moderate risk patients in India. There are no low risk patient diabetics in India. This is data by Dr. Unnikrishnan, and the mean QRIS-3 score actually of the population studied. These are newly diagnosed diabetes. Remember, they are not the patient whom you have been seeing for 5-6 years. The mean QRIS-3 score is 15, indicating that most patients already have 10-year risk of more than 15%, putting them into high risk or very high risk category. Mean number of risk factors of 1.7. Again, by any criteria, that would mean these are high risk individuals. So how do we manage patients of diabetes to prevent cardiovascular disease or manage cardiovascular disease? Dr. Anshul did take you through the target dominant components: glycemic control, blood pressure control, LDL control, and of course, therapy directed towards cardiorenal protection. There isn't any doubt that therapeutic lifestyle intervention plays a big role. We, of course, talk a lot about it. Unfortunately, patients do not follow that therapeutic lifestyle, and we don't see outcome coming. But nevertheless, the new guidelines are very, very interesting. And the guidelines suggest that you should actually follow PACE, which means therapy in diabetes with regard to cardiovascular protection has to be personalized, agile, comprehensive, and effective. But what are we having at the moment? And this again is a publication of last year from Dr. Mohan's group showing that whether you talk of diabetes, glycemic control, or LDL cholesterol control, the target achieved are less than 50% of these individuals. And my guess is that that number is also probably an optimistic guess. Lifestyle risk factors in diabetes have been well covered by Dr. Anshul, and there isn't, I am not going to talk a lot about that, except that it is easy to talk about lifestyle risk factors which promote cardiovascular disease in diabetes. It is tough to organize a structured program in which patients can benefit from changing these things. 2023 ESC dietary guidelines to improve cardiovascular health are there. And in general, the interesting part is class 1A status recommendation has been given for a Mediterranean diet. Unfortunate thing is Mediterranean diet in this country cannot be followed by most of the patients. The ESC 2023 guideline also suggests that the carb should be reduced to 40%. And of course, in this country, to promote cardiovascular health, in this country, again, that would be a tough job. The ESC 2023 recommendation also suggests physical activity to promote cardiovascular health, which is 150 minutes of moderate physical activity or 75 minutes of brisk, vigorous activity, and of course, 2 sessions of resistance training per week. And all have been given a class 1 recommendation indicating that there is data to suggest that these will reduce cardiovascular death. And of course, there is data from UK Biobank showing that 5-year risk of cardiovascular disease incidence goes down as you increase the amount of vigorous exercise in minutes per week. As you move from none to 60 or more, the curve tends to go down and down, indicating significant benefit of vigorous exercise in diabetic individuals. With regard to LDL targets, the ESC 2023 guidelines again suggest having less than 55 milligram LDL in very high-risk individuals, less than 17 high-risk, and moderate risk less than 100 milligram. And remember, as I said, Dr. Unikrishnan data says there are no moderate risk diabetics in India. So we are talking about everybody to have an LDL cholesterol below 70, which means high intensity statin therapy and SMI probably in everybody and PCSK9 in some. Keep in mind that the ESC guidelines do not talk about two things, bempedoic acid and fibrates, which are completely out of guidelines because the data is not convincing enough to reduce cardiovascular risk. With regard to blood pressure, the guidelines are having a blood pressure of systolic of 120 to 130 in individuals below the age of 65 years, 130 to 139 above the age of 65 years. And of course, suggestion that every blood pressure needs to be confirmed by repeat tests or preferably home blood pressure monitoring and or ambulatory blood pressure monitoring. With regard to glucose lowering therapy, the very high risk individuals are candidate for SGLT2 inhibitors and or GLP-1 analogs. And of course, high risk individuals are candidates for metformin, SGLT2 inhibitor, GLP-1 receptor analog, the class 2B indication. Metformin has a class 2A indication. So how do we manage a patient of diabetes with atherosclerotic cardiovascular disease according to the ESC guidelines? The SGLT2 inhibitors and SGLP-1 receptor analogs come as a class 1A indication. And if you still are not controlled, the class 2 agents to be used are metformin, which is class 2A, sitagliptin, linagliptin, the only cardiovascularly proven drugs, and basal insulins. And of course, even pioglitazone has a 2B indication. There are no class or recommendation for glimepiride or gliclazide, but the guidelines say that these are safe. What about heart failure? Pretty much similar kind of guideline, except the fact that now you also have pioglitazone as a class 3 and sexagliptin as a class 3B indication. That means these need to be avoided. But the class 1A is SGLT2 inhibitors and not GLP-1 analog. GLP-1 analogs or receptor analogs have class 2A status when the patient has a heart failure. They have safety, but there is no evidence of efficacy. With regard to heart failure in diabetics, the four pillars of therapy are, of course, ARNI or ACE inhibitor, beta blockers, MR, and SGLT2 inhibitors. And the guidelines strongly suggest that you should do rapid initiation, preferably all four drugs simultaneously, and full up titration within 6 weeks of having diagnosed heart failure. That is again a tall task, but I thought I would let you know that the guidelines have changed in last 3 weeks. What about diabetes with kidney disease? Four class of agents have been given a class 1A recommendation. Statins, everybody with DKD needs high intensity statin therapy. SGLT2 inhibitors, finerenone, ACE inhibitor, or ARB, and there are of course studies quoted, which I, because of want of time, wouldn't be going in details. The finerenone data, of course, is impressive for diabetes with DKD because of the fidelity pooled analysis showing a reduction in composite outcome of 14%, cardiovascular outcome 14%, and of course, much more impressive renal outcome. What about glucose control in patient with acute coronary syndrome, which is important? I was carefully listening to the use of insulin in previous presentations. The guidelines suggest frequent glucose monitoring, but when it comes to glucose lowering, it does not recommend that you should be using insulin. It says you can use any of the glucose lowering agent. Short-acting or otherwise insulins have no recommendation. The guidelines have found no evidence that any form of insulin in acute coronary syndrome helps these patients. And this is a new and interesting guideline. With regard to the fact that if the patient don't have atherosclerotic cardiovascular disease, but they are at high risk, it is interesting that is a 2BC indication for SGLT inhibitors and GLP-1 receptor analogs. So if you are looking from a cardiovascular viewpoint, that is a pretty low level of recommendation. You have to have atherosclerotic cardiovascular disease before SGLT1 inhibitors or GLP-1 may be considered as the mandatory drugs. Of course, as I said, that the guidelines also say that gliclazide and glimepiride are cardio-safe, but no recommendations are made, and no recommendation short-acting insulins and other sulfonylureas, although basal insulins have a class 2 indication because safety has been shown in Origin study and DEVOTE study. What about using other drugs like icosapentaenol ethyl in preventing cardiovascular disease in diabetics? For primary prevention, it has a class 2B indication, largely based on REDUCE-IT trial and JELIS trial, but the low recommendation is because of two opposite trials, STRENGTH and RITAL, which haven't shown benefit. So you may use icosapentaenol ethyl 4 gram a day, costing 200 rupees a day in diabetics with hypertriglyceridemia to reduce cardiovascular events. Rivaroxaban is a thing which has been given a reasonably good uplift, class 2A recommendation, low dose rivaroxaban in patients with diabetes and chronic coronary syndrome or diabetes with peripheral vascular disease, because that would further reduce mortality by 20% diabetics. Low dose aspirin, as usual, remains a class 1 recommendation atherosclerotic cardiovascular disease. No recommendation for aspirin in group anyone other than those with atherosclerotic cardiovascular disease. So this way, it differs from ACC, which has given a 2B recommendation for selected high-risk diabetics. ESC says there is no role of primary prevention, no role of aspirin for primary prevention in diabetic individuals. And as I said that for both GLP-1 analogs and the SGLT2 inhibitor and finerenone, the new data suggests strong evidence and high quality of data, and the quality of evidence over time is going to get better and better. What about individuals bypass surgery or putting stents in patients with stable coronary artery disease and those who have diabetes and kidney disease, or those who have diabetes and moderate to severe stable coronary artery disease? Equipoise is there between intensive medical therapy or invasive strategy. Both are equal. So you can choose one. You can choose one of the two, and the patient will do equally well. There is nothing which suggests that one is better than the other. So, ladies and gentlemen, to summarize, the ESC 2023 algorithm for cardiovascular risk stratification in diabetes tries to put patients into 4 categories: very high risk, moderate risk, and low risk. My submission is that in India, more than 90% would have high risk or very high risk, and Dr. Unnikrishnan data says 100% are very high risk or high risk. And we don't need any calculator. There is hardly any need to risk stratify from a cardiovascular risk viewpoint diabetics. There is much lower value of insulins in cardiovascular disease prevention than, of course, diabetology, endocrinologists talk. And we have newer cardio and renoprotective agents like finerenone and, of course, SGLT inhibitors and GLP-1 analogs. Substantial underutilization of proven therapy is going on in diabetics, but there is overuse of unproven therapy like fenofibrates, aspirin, keto amino acids, Q10, and vitamin D. Thank you very much.
I think, Dr. Mohan, it was a very, very illuminating talk, and you updated us.
Your audio is not there, Dr. Singh. Your audio. No, I think you still have to speak louder.
Audio is poor, I think.
Dr. Anil sir, can you go? I think that this will, yeah. So I think Dr. Mohan, you have updated us very nicely. You have come, sir.
Can't listen.
Dr. Anil sir, can you proceed?
Yeah, I will just tell you something which is very important. I think Dr. Mohan brought up certain issues which are of a great importance. And I tell you we face this problem quite often because cardiovascular safety is a primary concern of all modalities of treatment. Now, we see today cardiovascular safety trials are also so elaborate that a drug has to pass in so many cardiovascular safety trials that interferes with the treatment quite a lot. But I have to also submit that, they say diabetes and heart disease are two faces of one coin. And so very rightly said that you have a diabetes, sooner or later, you're going to be on the cardiac table, either for plasty or some intervention. Or what very nicely put that many times the coronary appear to be normal, angiographies are normal, they're not plastable lesion, but they have a small vessel disease of the heart. Cardiomyopathy is secondary to microangiopathy of the heart, and that is very common in Indian with the cardiac failure patients. And a patient with cardiac failure really prepares a very high risk group because first failure is okay at treated at home, second hospitalization, and third usually a catastrophic event. So cardiac failure is a very serious condition, more serious than anginal pain and ischemic heart disease. So we have to take care of that. Now there are all the factors what Dr. Mohan has brought, that so many things that you need to intervene, and there is a really strong evidence that Indians are at a very high risk of developing coronary artery disease as well as cardiac failure, and we have to address that issue. I have to also request, I think since you are talking about the comorbidity problems of type 2 diabetes, I always say that number one cause of death in, at least in Bombay, is going to be not heart disease, but it is going to be cancer. You know one thing, there is a linear relationship for high postprandial blood sugar, coronary artery disease, and if they survive coronary artery disease, cancer is waiting for you. So cancer is a third serious comorbidity that we have to really address, and we have to make an effort to have early diagnosis of cancer because many cancers are treatable today, and therefore this is my particularly humble request that we have to focus on cancer as well. Thank you.
Sir, am I audible, sir?
Yeah.
So I think, Dr. Mohan, I think one or two things which you illuminated about the role of the cardiovascular risk reduction, and also you touched upon very importantly about the role of this new non-steroidal MRA. So I think although the renal perspective will be dealt by Dr. Tripathi, sir, so how, Dr. Mohan, you see the role of this new molecule in the day-to-day practice?
So finerenone has been approved for diabetic kidney disease in ESC, and also in India also the Drug Controller General has approved it for diabetic kidney disease, especially patients who have albuminuria. We have data which suggests that the drug reduces the hard renal endpoints and hard cardiovascular endpoints. However, we are awaiting data from fine art study with regard to heart failure. Whether we can use at the moment ahead of the data is a moot question. But my definite feeling is that because of low propensity for causing significant hyperkalemia, finerenone uptake would definitely increase across the board in patients with diabetes, more in diabetic kidney disease and diabetic with heart failure.
Thank you. One more question I would like to ask you, that you very rightly said that we have moved from this traditional up titrating of the 4 drugs in the heart failure. So you also told that we should start at the same time, the moment we diagnose a case of heart failure, we should start both the beta blockers, SGLT2 inhibitors, and these 2 more drugs. So I think, should we go for up very slowly titration, or from the first day of the therapy, we can start all 4, that wonder 4?
So the guidelines have been very clear. In fact, the ESC had an update on heart failure guidelines 3 weeks back, and so are the update on diabetic and heart failure. They suggest rapid initiation of all the 4 drugs, which actually means maybe you can give a gap of 1 or 2 days to start 4 drugs in heart failure with reduced ejection fraction. but the guidelines based upon the very good randomized study called Strong HF suggests that within 6 weeks, you should be at the maximally tolerated dose of all 4 foundational pillars of heart failure. I think this is a very...
If you permit, I'd like to ask one question to Dr. J.C. Mohan. I'm Dr. Maria.
Yeah,
sir, as you very rightly pointed out, as you pointed out, that we Indians are at a very high risk. And the guidelines about aspirin uses are for the Europeans. What are your recommendations for people in India who are, all diabetics you said are very high risk? Should we be considering aspirin for them? Yes or no? Because we are different from the Europeans and we should not follow European guidelines for that.
So we looked at the subgroup analysis of the ASCENT trial where they tried to categorize patients in very high risk and moderate risk by this lady from Oxford actually. And we saw that even within the groups, aspirin wasn't providing any great benefit. So if you don't have manifest atherosclerotic cardiovascular disease, data as of now does not support the use of aspirin for primary prevention. And the ACC data is also 2B indication, which you may use in high-risk selected patients, certainly not above the age of 70 years. Certainly not, because the ESPRI data is so powerful, showing nearly 40% increase incidence of intracranial hemorrhage without any benefit in individuals above the age of 70 years. And remember, 30% of the ESPRI patients were diabetics.
Thank you. Thank you.
Thank you, Dr. Mohan, for illuminating us. So we will move on. Can you share the CV slides of Dr. Tripathi, sir? I think I have a great pleasure in inviting Sir Padma Shri, Dr. Kamlakar Tripathi, sir. I think it is a long list you see. He was the ex-professor and head Department of Medicine, Division of Nephrology, and his publications more than 300 international, 110 invited lectures, more than 600 international, 100. So he ex-president UP Diabetic Association, now president of the Indian Society of Wound Healing, Indian Society of Hypertension, Indian Society of Chronomedicine, and lots of research products. I am really very thankful that today we are going to listen him, and a very important topic, that is the renal perspective for in diabetes management. So I think great pleasure again, sir, inviting you. So please
Thanks.
share the slide. Yeah, thank you.
Thankful to Dr. N.K. Singh for your, and then I have heard few celebrities. And one celebrity is what we have known, Dr. Bhoraskar, have seen many times, heard him many times, and heard his presentation, very critical and very academically full of academics. And Professor J.C. Mohan, wonderful. And most part of the subjects have already been covered. Are you seeing my slides?
Yeah. Yes, sir. Yes, sir.
Can I, I'm going to share it. Now, can you see now?
Yeah. We can see.
Good, thank you. So what I would be doing, it would be a crisp presentation, a short presentation, and then I would not be touching those parts which already have been spoken by Dr. Mohan and Dr. Prior to the previous speaker. So would be talking on the beyond glucose control in relation to renal primarily, because heart has been taken care of, kidney, this endocrine part has been taken care of. I would be concentrating to the renal part, nephrologist purview. What does it mean to control blood sugar and see the effect on the renal function? This is what we have been seen in different studies from different parts of the world, from the USA, Australia, which is a nephron study, from the Italy, and then from the global total, as well as Australia and the Central South Africa and Europe. Almost 56% patients have association of diabetic kidney disease. It could be 63% from Australia, US 46%, 68% again, another study from Australia. And they have shown close to, if you walk into any nephrology or dialysis unit, at a time, more than 2/3 patient would be contributing from the kidney disease and as the cause of chronic kidney disease. So if one has to select a molecule right from the beginning, when the dysglycemia started, it's better to select a molecule which protects the heart and also takes care of the renal function and the kidney. And rightly, Dr. Boraskar said just before the presentation, my presentation, that most of these patients have a cardiac myocyte dysfunction, microangiopathic disturbances. So some of these patients with normal coronary arteries, they develop heart failure and they also develop the cardiac complication. So story starts much earlier. We have, looking at the natural course, and this slide have been also repeated many times, but this has not been in this presentation. It is the preclinical phase in which GFR increases. It's called supernormal GFR. From 120, it can become 140. This is because of the increased proliferation of the microvascular bed. How does it happen? It happens because of the site on which the endothelial cells stay in the microvascular capillary. They proliferate because of the very poor collagen fiber and the basement membrane. So they give the way, and one can start with the retinopathy and nephropathy. Here the kidney size increases and proteinuria remains within the normal range. But over the period of 10 years after the first stage dysglycemia has been observed, GFR remains normal from supernormal to becomes normal. There's increased mesangial matrix. There's the expansion of the mesangial matrix, and that's why the glomerular sizes increases. There's basement membrane thickening. There is arteriolar hyalinosis. So the lumen is being, microangiopathy I'm talking. In macroangiopathy, it's a slow process. There would be adhesion molecule, there would be deposition of the platelet, then would be deposition of the fat, and then there would be narrowing of the lumen, and gradually the circulation would be impaired. But here what is happening, the matrix, the collagen fiber and the basement membrane from where the filtration is occurring gets involved right from the beginning, and that is the reason why these patients, they start losing protein earlier, much earlier than the drop in the glomerular filtration rate. And after 15 years, close to 15 years, though GFR remains normal, serum creatinine does not increase. If you do the GFR, it remains about between 90 to 60. Still, patients start losing slowly the protein in the urine, and we get over diabetic kidney disease. So after 10 to 15 years, you get, if you do a biopsy, you get Kymel-Steele-Wilson syndrome, meaning by there will be nodular sclerosis and tubular interstitial fibrosis. This is the time when a clinician happens to see a patient. And by this time, enough damage has been done. And if enough damage has been done, then it reflects badly on the part of the perfusion, the heart, as well as the brain and the microangiopathy. Therefore, the molecule is to be selected right from the beginning. It's not the treatment that you control blood sugar from 120 fasting to bring it down to the less than 100, postprandial less than 200. Let us take other metabolic parameter, especially the kidney, the filtration process, because by the time kidney goes into stage 3+, the perfusion is affected. The arteriolar hyalinosis is advanced. It doesn't listen to any vasodilator drugs or any drugs which would dilate the perfusion, either afferent arterial or efferent arterial. You use whatever amount you feel, you use ACE inhibitor or ARB, that would not alter, and there would be a stage of intraglomerular hypertension. Intraglomerular hypertension would lead ultimately to the increased angiotensin as well as the base angiotensinogen, and that would lead to the destruction and poor perfusion of the heart. So this is how we start. Stay at the 0 time, this is a bell, but you look at the capillaries, the number of capillaries in this micro slide, they have increased, tremendously increased than the normal. This is the hyperperfusion and hypertrophy. Urinary protein is not there, and GFR is super normal. This is the silent stage after 5 to 4 years in which nothing happens. But gradually, when it prolongs, at the incipient stage, the basement membrane gets thickened. You can see it in the on the slide. They are the thickened one. There's increased mesangial matrix. Lot of dark stain cell in between the loop of the blood vessels and the capillary. They increases, and that gives a problem to the filtration fraction. And then we get overt nephropathy and ultimately end-stage renal failure. This is a better diagram. A story starts, the basement membrane is here, and the podocyte. Podocyte comes from the origin of the epidermis. Lengthwise, there is invagination of the part of the tubule in the embryo system, and from the collecting system, you get capillaries. You get capillaries which come from the mesodermal origin. So you have a two embryological different site: epidermal origin, mesodermal origin. Mesodermal origin has a lot of fibroblasts, as well as these cells which are called histiocyte converted into bigger cell, and then they take the role of the secreting and modulating lot of immunoglobulins, the idiotypic antibodies. So what happens? Albumin it starts because of the disruption of the basement membrane. There's increased secretion, increased excretion of the albumin. It comes to the tubule, it damages the tubule. So there's tubulointerstitial injury, lot of heparin sulfate from the basement membrane. The food process is destroyed, and we have the early markers. The mesangial matrix, which start increasing, there is a deposition of the histiocyte converted into cells, which is now taking the part of the matrix and the modulating cell and the glycocalyx, and that would lead to the disruption in the basement membrane, increase the pore size. So it would be a lot of losing albumin. On the other side, the vascular endothelium. So this is the epithelial part, which comes from the epidermal origin. This is the endothelial mesodermal origin. And apart from that, there is a lipid accumulation like happens in other capillaries. There's a podocyte damage, there's a detachment and apoptosis. And also there is, because of the fat accumulation, there is insulin resistance. And all these would lead to the increased fibroblast, and there is gradually glomerular sclerosis. So what happens ultimately? The afferent arteriole has to compromise. Kidney has two sets of the blood vessels supplying. One is called vasa recta, which supplies the medulla, and then the normal, which supplies the arcuate artery, and there is an intra artery which supplies the external and the cortex part. There's a short circuiting at the time of the pressure regulation to maintain the pressure regulation between the two. And because of short circuiting, these patients often go into acute stage of the cortical necrosis. So what happens? We have series of drugs, and these drugs have been talked time and again. And that's why I was talking to pick up the molecule at the beginning. We have been using traditionally sulfonylurea, and maybe Dr. Boraskar also could have written a prescription on the tolbutamide. We have, as well as we at that time used fenformin, and they did the initial early 70s study showed that the UKP resist, that study of UGDP from the US and the Framingham study, that they do a lot of harm to the cardiac myocyte. But nobody cared for the perfusion, and nobody cared for the microangiopathy. But what happens to these patients? Gradually, we have second generation sulfonylurea, third generation sulfonylurea. Some sulfonylurea do have the protective property. But then we had novel molecules, and one of the novel molecules was SGLT2 inhibitor that would improve the glycemic control and would also work on the ejection fraction, reduce ejection fraction. And also some of the publications now say that if the EFR is less than 20, they can be used. They would also be useful to reduce the albuminuria. So these are the two extra added advantages. Number one, on the heart failure, Dr. Mohan already talked it in a great detail. And then another advantage would be taking care of the albumin directly. It would reduce albumin it would take out a lot of sodium, it would take out a lot of water, and because of the resetting of the intraglomerular capillaries, these patients would be responding, at least the renal function will start improving. But initial part, because of these two drugs, the SGLT2 inhibitors and ACE inhibitors, ACE inhibitor is primarily for the blood pressure control, would also reduce eGFR. So initially, if the patient eGFR is low, less than 30, then there would be drop into the serum, increase in serum creatinine, drop in eGFR, and that would ultimately result transient rise of the serum creatinine, and patient might be disturbed. So, but ultimately, after 3 to 6 weeks, one should wait up to 3 weeks. Gradually, it starts coming down, and then you get the advantage of these drugs. So this is the setting. In all these patients, we initially control the metabolic disturbances. Prior to me, the endocrinologist colleague talked about it, and the drugs would be acting on the advanced glycation end product and reactive oxygen species. And they would also be working on the gut micro changes, and there are now drugs available, especially the probiotics. The renal probiotics have advantage to set right the microbiome. They would be acting on the inflammatory factors, which are primarily responsible for the adhesion molecule, the vascular damage, the endothelial damage, and would be acting through TNF alpha, interleukin 1, 10, 18. They would also be settling the hemodynamic changes and the mediators, because I said, as you have advanced sclerosis, the surface area decreases, the basement membrane disruption, drop into the oncotic pressure, leak up the albumin. All 4 or 5 factors would lead to resetting of the intraglomerular circulation, and there would be secretion of aldosterone, endothelins. So these pro-fibrotic factors is responsible for enhanced fibrosis, decrease in surface area, and glomerulosclerosis. So there would be TGF beta, fibronectin, collagen 1, and this is called CTGF. This is the collagen tumor growth factors. Then we have also drugs acting on the what we call methylation and microRNA. The histone methylation and acetylation would be taking care of some of the component at the level of the microRNA, and then the inflammation and fibrosis, and there increase the MR overactivation, mineralocorticoid receptor overactivation. So ultimately, it leads to a vicious circle. There is pro-inflammatory markers, and there are the pro-fibrotic factors. Together, they lead to reduction into the surface area of the Bowman's capsule. So we have a 2-bed. There's the microvascular bed, and then you have macrovascular bed, which is in the brain circulation and the heart. So all these metabolic disturbances, the hemodynamic disturbances, and the inflammatory disturbances together would lead to increased extracellular matrix expansion, cellular hypertrophy and proliferation, sclerosis, and tuberointerstitial inflammation. So the molecules to be selected is from the scientific base. We need a molecule which takes care of metabolic disturbance, means try to bring the patient to the euglycemia. We choose a molecule which takes care of the intraglomerular hypertension, try to set the afferent and efferent arteriolar, the infusion pressure. We need a drug which also responds to some of the inflammatory markers, and then the fibrotic factors, and then would take care of the histone methylation and or acetylation and MR overactivation. And now we have already been talking, and our previous speaker has already talked about it. We would be talking about those 3-4 novel molecules, how they have added our knowledge in reduction of the kidney disease progression. So SGLT2 have been widely studied, and there are 3 major molecules which have been looked into. One is relation to the acute kidney injury irrespective of diabetes status, and there's relative appear to be modified by primary kidney diagnosis. The acute kidney injury, which does happen when you give the SGLT2 inhibitor drugs, because of the volume depletion, there could be transient rise in serum creatinine, but they are reversible. And what have been shown now when you use SGLT2 inhibitor in comparison to placebo and those with diabetes or without diabetes, this is 38% improvement in the event of the kidney disease progression, which includes both increased reduction in the proteinuria and improvement in the GFR than the placebo. When you look at the kidney disease progression with the all 5 landmark trials, Christensen scored has already been referred by previous Dr. Mohan, DAPA-CKD, EMPA-Kidney, and this is what you get the advantage of close to 20%. When you look at ischemic and hypertensive kidney disorder, DAPA-CKD, EMPA-Kidney, again you get advantage of about 30%. When you look at the glomerular disease primarily, that is in relation to the eGFR, then you get again 40%. In other diseases of unknown etiology, again you get the advantage of 26%. So therefore, these novel molecule, whether it is the dapagliflozin, empagliflozin, canagliflozin, and other gliflozins which are in the market, have potential to improve, decrease the protein and albumin excretion from the tubule, resetting the glomerular hyperperfusion into a normal perfusion, taking care of the afferent and efferent arteriolar pressure, and also regulating the oncotic pressure. See, the albumin is important because it adds on to the oncotic pressure and it is responsible for effective filtration gradient. At the afferent arteriole, we have the arterial pressure of 45 millimeter mercury. At the efferent arteriole, this is 15 millimeter of mercury. But the hydrostatic pressure to both sides, which also form the oncotic, is about 10 millimeter mercury. So the effective filtration gradient is hardly 10 to 15 millimeter, which is responsible for making urine. If there's a drop or there's increase beyond this, then there is a trouble, and some of these patients can also develop acute kidney injury. This is the empagliflozin, and that's what I was talking. Initially there would be drop, and gradually it would sustain slowly over the period, and ultimately it would improve over the years, which takes about 30 to 36 months in comparison to the placebo. And the GFR may drop initially, but gradually it takes over, and ultimately it sustains well. So if you look at the net gain, this is from the 40 eGFR. Ultimately, it has reached to 30 or 32. And then over the years, again, it has come back to 34, 35. What is said? That whatever molecule you choose, there would be continued slowly decrease into the effectivity of these nephrons. But it would delay. It would delay the progression as well as it would delay the excretion of the albumin. Looking at a systemic review and meta-analysis of these, all the in relation to progression, this is 38% in diabetic patient, and overall this is 37%, which favors SGLT2 inhibitor. This is again based on the eGFR, because then is it 38%. Overall, this is 37%. So there are two different arms. One arm takes care of the proteinuria and tries to return the protein to the normal values, or maybe even they respond very well much earlier rather than the responding to the eGFR. This is what we get in patient of CKD. Actually, what happened, the dapagliflozin, when it was initially introduced, it was primarily a drug which was favored by the cardiologist, and they got the result in relation to the heart failure. But subsequently, it was also noted that they could change the primary composite outcome up to 14.5% when it comes to the renal and heart together, kidney 11.3%, heart 6.4% when you take it composite cardiovascular event, and death rate for any cause is 6.8 with the placebo 4.7. Look at the difference, 14.5 to 9.2, 11.3 to 6.6. So there is a significant difference. In numbers, it looks But overall, because there is change, it is perceived that probably these molecules would be helping in long term. So among patients with chronic kidney disease, the risk of any composite kidney or cardiovascular outcome or death was significantly lower with dapagliflozin than the placebo. But there are questions in long term, what would happen? So we have to look another 1 decade. This was the canvas study, again in relation to the canagliflozin and with compared to placebo, where they have used with GFR up to 30 ml. And this has been what you calculate KDIGO risk classification. Then major adverse cardiovascular event was prevented per 1,000 patients over the 5 year. And this is what 23 overall, 17 with the low risk, 0 with the high risk, moderate risk, 42 with high risk, and 169 with very high risk. This was the deviation from what we have observed with previous 2 molecules, the EMPA as well as the DAPA. So absolute risk reduction for cardiovascular disease with canagliflozin are likely greater for individual at higher categories. These are the patients, and this is what the subset we see. Most of the patient who comes to the tertiary care institution, especially in the close by village area, district hospital, these are the patients whose creatinine value remains very high. And the first visit, you might be getting serum creatinine of 4 or 6, proteinuria, macroproteinuria, lot of peripheral edema, hypertension, cardiovascular problem, pulmonary edema, and these are the very bad patients. But if you look at the particular canagliflozin, then probably it scores over 2 gliflozin in this particular trial. We already have said about the 3 drivers, and one is metabolic, poor glycemic control, so that has been answered by any gliflozin combination, any one of the 3. The hemodynamic by taking care of the blood pressure, and then some of the action on the inflammasomes, and Dr. Mohan has already talked about MRAS, and this is what we have been using is spironolactone much earlier, about 15 to 20 years. It has high potency to MRA, it has a low selectivity, sexual side effects are much less, no gynecomastia. Risk of hypoglycemia would be, hyperkalemia would be a little more, but BP reduction would be here. But eplerenone was subsequently used, which seems to be a little better, lower incidence of sexual side effect and gynecomastia, but again it has a hyperkalemia. So these 2 previous molecules, the spironolactone, eplerenone, had hyperkalemia, but the finerenone, the Crandia, then this had advantage because there is a rare sexual side effect and moderately increased risk of hyperkalemia, moderate risk of BP reduction. And Dr. Voraskar also said about this, that the hyperkalemia would be less. Most of these patients of the chronic kidney disease have already pre-existing hyperkalemia, and they would make worse when you use ACE inhibitor together with Crandia. But if you use Crandia, not eplerenone or spironolactone, then they score over. But however, you have to be very cautious of the potassium value, and those patients with eGFR less than 30, it's always a warning. Between 35 to 45, you can prescribe, you can regulate the dose. Above 60 to 90, you are quite safe. But below 30, 25 people are using, then there could be problem with the hyperkalemia. And this is what they did. They looked at the different point Fidelio DKD trial with the type 2 CKD and used from the eGFR 40% onward. And here Figaro DKD trial where they look at the primary composite point, death from CV causes non-fatal MI. And then the comparison have been done, but about fidelity pooled analysis, which have shown that significant improvement in composite eGFR, renal failure, progression to end-stage kidney disease, even in the patient whose eGFR less than 15 ml. Though this has been written, but I was the part of DGCI decision board, and we still make a remark and a red line that you should be very, very cautious in dealing with those patients whose eGFR less than 50%. Here you see this is only 19%. And here it is 20% progression to end-stage kidney disease. Look at the 57% decrease in eGFR from the baseline comes to 30%. Here, when you compare the finerenone in the patient, when looking at the CV benefit, certainly it gives you a better than what we have seen in the previous group. This is the GLP-RA already have been talked before, and GLP-RA also improves renal function, whether it is liraglutide, semaglutide, or it is dulaglutide. All they have got improvement when it comes to the improvement in the progression of end-stage kidney disease, progression to the proteinuria. However, look at the death due to kidney. This particular has not been answered when the leader trial, but semaglutide seems to be doing better in all these group of the patient, especially delaying the renal replacement therapy and improvement. But mind you, it has been used in those patients whose eGFR more than 30%. This is the composite kidney outcome with GLP-RA. This is about 21%. And worsening of the kidney function is again improvement in 16%. So comparing the two, GLP-RA and when you compare it, looking at the kidney function eGFR, do not use, avoid if GFR is less than 30. Liraglutide can be used up to GFR 15. Exenatide should be avoided if further GFR is not at 50. Lixenatide have been used below 30. Dulaglutide can be used even with the low GFR. And subcutaneous semaglutide has also been used. So these are the two molecules I don't think many of us are using, at least the nephrologists are not using. But otherwise, they have been used by diabetologists and endocrinologists, and there have been good results so far as the GLP-RA is concerned. The tolerability has become better with the newer molecule, especially the oral semaglutide. It has shown a better tolerability and improving the renal function. So liraglutide, dulaglutide, and semaglutide can be used even with the low GFR of 15. I have no personal experience. I do not know my many other nephrologist colleagues who are from the little older generation also have not been very comfortable in the personal talk. So, but there is no publication from India. These are the publications from abroad where there is a meticulous follow-up. These are some of the now final slides. We have to go for a holistic approach for improving outcome patient with diabetes and CKD. And this already have been said that from lifestyle to the past drug history to the molecule which we choose, as well as the antihypertensive drug. So at least we need these 5 important information to improve the renal function, take care of the HbA1c, target the lowering blood pressure to 130/80. ACE-ARB is to be recommended, but with a big but that you must see that the eGFR is not below 30, and of course lipid lowering agent, stop smoking, exercise, and balanced diet. Thank you very much.
Thank you very much.
We now have the...
You know, I have to admit that Tripathi Sahib, you are really a Pandit. If I had a chance to be your student, maybe I would have become a very good nephrologist than an endocrinologist. You have taught us so well. You have taught the nephron. I have never studied the nephron so beautifully that you've shown that histopathology, which I thought none of my nephro colleagues have ever taught me anything. Unfortunately, we are in a multi-specialty hospital where the patient's creatinine goes to 2. The nephrologists have a different approach, and they all try to see that the patient can be delayed as far as dialysis is concerned, but their main interest is in dialysis and renal replacement therapy, unfortunately. Such holistic approach, Tripathi Sahib, I really salute you. You're a really Pandit, and I really am so glad that my friend Dr. Chawla today got me to chair this session. Let me tell you that it was a learning experience for me. I have learned a lot today. I thank Dr. Chawla for asking me to chair the session.
I
Thank you.
think your comments were full of prudence, and no doubt it has been a wonderful session with Dr. N.K. Singh, Dr. Anshul presenting endocrinologist perspective. Dr. J. Simon, as always, has been wonderful. And of course, Dr. K.K. Tripathi, I think we don't have any words for him, for his words of prudence and clinical pulse, which he really offered to all of us. It has been really very good learning. At least the way you said, we have learned a lot from this session. I'll request Professor K.K. Tripathi to please chair the next session, which is again going to be a wonderful session. So Dr. Tripathi is already introduced, but he's ex-professor and head Department of Medicine and Division of Nephrology, IMS Banaras Hindu University, Varanasi, a teacher of teachers and a Padam Shri. And Dr. Sanjeev Kapoor is again a very learned senior colleague, director and head Department of Internal Medicine at Marengo QRG Hospital, Faridabad. A very good clinician, very good internist, I'll say. Whenever we are in dilemma for any diagnosis, we tend to refer our patients to Dr. Sanjeev Kapoor. So I'll request Dr. K.K. Tripathi to please introduce both the speakers and start the session.
Can I have the slide?
Yeah.
Yes. This is Dr. Arvind.
Yes, sir.
So Dr. Arvind is going to
He's going to talk about inflammation and diabetes, role of anti-inflammatory drugs.
Yes, I have known Dr. Arvind for last more than 2 decades as a wonderful organizer, clinician, good publication, and has been in association of us, RSSDI, at many platforms. Has been director of Diacon Hospital, Bangalore. That's the name which Dr. Banshi and others have been establishing, trying to make it as a brand name. He is chief consultant of Diacon Hospital. Is a course director for the PG studies at the Rajiv Gandhi University of Health Sciences and RSSDI at the JNU University. Is the president of RSSDI 2015 to 16 and currently president of Diabetes India. He has conducted over 100 phase 2-3 studies, and his name is frequently seen with DGCI. When I was in the panel, I was getting a lot of proposal in which always his name would be there. Over 100 publication, authored many textbooks, has been in the Guinness Book of Record for the highest number of food screening in a day, and has a Lifetime Achievement Award on the diabetes area. So over to Dr. Arvind.
Thank you, Rajiv and the team, for having asked me to give a talk on the first year platform. The discussion and the topic today is not something very new, but then we have been talking about it for 2 decades. But people still need a little more push to accept that diabetes is an inflammatory disease. Now, the question is diabetes an inflammatory disease? Okay, so we'll start with that. Now, I'll take you through this particular slide. This is the Lancet Diabetes Endocrinology from June. Dr. Mohan's group is also called the ICMR in DAB study. Now, what it's trying to tell us is there has been a tremendous increase in the number of cases of diabetes. If you remember, the IDF at last told us it's about 73 million. But today we are looking at a figure of 101 million. Pre-diabetes has increased, hypertension has increased, generalized obesity has increased, abdominal obesity has increased, and dyslipidemia. All these are becoming a much, much bigger problem. Now, if you look at the 2019 atlas, despite having so many advances in the field of diabetes, there has been an increase in coronary artery disease, ischemic heart disease, stroke, cardiovascular death, and years of life lost. You just pause for a second and think, why is this happening? There are so many new drugs, so many new things that have come into the market in the last 30 years, but still the people are getting into problems, especially the cardiovascular disease. This is a shocking news, and we really have to think. In fact, almost 2 decades ago, The Steno clinical trial actually looked at this. They control diabetes to the extent possible, keeping the HbA1c to less than 7. They controlled hypertension to target. They used aspirin. They used statins. They did everything right. Now, despite doing everything right, the cardiovascular disease risk reduction was only 53%. So we need to think, we need to pause, ask ourselves a question. Are we missing something here? And what is this missing link? You know, this is just a slide to show you that we do see CVOT trials. We do look at cumulative mortality, and we see what was the difference between the group which took a particular drug versus the group that did not take the drug. And we see a difference of 20%, 30%, 35%, and we feel very happy. But what we are missing is, if a particular drug helps reduce the cardiovascular risk by 25, 30, 35, whatever it is, percentage-wise, why is it not helping the remaining 65%? So, with this in the background, let's just think, is chronic cellular inflammation the cause? Because you're looking at all other things. The only thing that we are not looking at, what we have not taken seriously and what we are not treating, is cellular inflammation. And we know about inflammation and diabetes, the link. It has come in the headlines of the Time magazine also. And for over 2 decades, especially with rheumatoid arthritis and diabetes, we know that there is international evidence. Inflammation is not only linked to diabetes and pre-diabetes, but we also know it is linked to rheumatoid arthritis and it's causing atherosclerosis. So it is the metabolic syndrome. So metabolic syndrome, as we know, is a condition associated with type 2 diabetes. It's actually a cluster of conditions. The components of the metabolic syndrome are all listed here, and it's known to all of you. I don't have to go into the details of this. And we know it actually is causing endothelial dysfunction, leading to atherosclerosis. So cellular inflammation is linked to insulin resistance, atherogenic diet, linked to prothrombotic state, hyperglycemia, hypertension, and visceral adiposity. So I think this is something that we have to take it very seriously. It plays a very significant role in the development and progression of metabolic syndrome, and that metabolic syndrome is worsening the cardiovascular events. And we have known this. We have been measuring the inflammatory markers for quite some time. We do have inflammatory markers in obesity, dyslipidemia, hypertension, diabetes. And nowadays, we are also seeing it in NAFLD, which now is called MAFLD, and it leads to the prothrombotic state. You have cytokines, IL-1, IL-6. We also have adiponectin, hsCRP, and TNF-alpha, which can be measured. But in clinical practice, you may think that, oh, I cannot really measure these cytokines, and all these are for research. You have a simple CRP that you can measure. In fact, if you look at this particular meta-analysis of 19 studies, the relative risk production for CRP as a cytokine is the highest. Most of the labs in India, you can measure hsCRP, and if it is more than 3, it is clearly telling us that there is cellular inflammation. Now the question is, if we knew this for the last 2 to 2.5 decades, why have we not tried any of the drugs? Yes, this is the list of the drugs that you are seeing in front of you. In fact, all these drugs have been tried and they seem to have failed at some point or the other, except for hydroxychloroquine. There are potential targets, how these drugs work, how they actually change the cellular inflammation? What are the sites that we can target? I will not go too much into the details of this, but I'll show you one or two clinical trials. In fact, in Jupiter trial, statins were used, rosuvastatin was used. And people were very happy that there is an anti-inflammatory effect that we see with statins. And since we also use statins in dyslipidemia and our diabetic patients, this can probably reduce cellular inflammation. But what we saw was the rosuvastatin group did have a higher incidence of physician-reported diabetes. So it's not used as an anti-inflammatory for cellular inflammation, but of course we know the uses of statins. Another great trial was the salicylate trial, what we call as the Tinsel trial. Now, in this particular salicylate trial, a dosage was particularly used. They saw a reduction in the white blood cell component. They saw a reduction in the neutrophils. In fact, the adiponectin level rised. All these were positive reports, and HbA1c got reduced. Now, what more do we want? Salicylate is very inexpensive and can be used in reducing cellular inflammation. This is what the world thought. And this was done by Dr. Alison Goldfein. But unfortunately, salicylate had no significant effect on hsCRP, which I and you can measure. So this trial ended with a sad note, and we are not going to discuss too much about it. But the interest in hydroxychloroquine actually came many years back. They were actually using hydroxychloroquine in patients with rheumatoid arthritis, and they saw that there was a 77% reduction in the risk of developing new onset type 2 diabetes in the group which was taking hydroxychloroquine. So they started looking into this a little more closely and thought, how is hydroxychloroquine reducing the risk of developing type 2 diabetes? We will come to that a little later. Hydroxychloroquine, we know, and it has proved over several decades that it inhibits the cytokine production, especially IL-1, IL-6, and TNF-alpha. It also reduces hsCRP, and there is plenty of evidence to support these things. It inhibits prostaglandin synthesis, inhibits leukocyte activation, and inhibits leukocyte migration. So this has been a drug which has stayed in the rheumatoid arthritis space for a number of years as an anti-inflammatory drug. Now we have to see whether we can use this in patients with diabetes. In fact, there was enough of studies to prove that it reduces HbA1c and its beneficial action. So the DCGI approved this drug to be used in type 2 diabetes as an adjuvant in 2014 itself. It's almost a decade since hydroxychloroquine is actually approved by DCGA to be used in patients with type 2 diabetes. And we really haven't looked into this. It's almost been a decade. In fact, RSSDA guidelines also included it in 2017. Now, how does it reduce sugars? How does it work in a patient with type 2 diabetes is interesting. We know about it for quite some time. Basically, it inhibits insulin degradation. Insulin, after its production, can get degraded, and that is why hydroxychloroquine works at that spot and makes the available insulin work better and probably increases the level of insulin from preventing it from degradation. Plus, we know it has anti-inflammatory action. It improves sensitivity. Well, the beta cell preservation is just a few animal studies. We'll not go into that. Now, this is something that is very clearly known. You give hydroxychloroquine to a patient with type 2 diabetes, and you see there is an increased level of available insulin. So hydroxychloroquine reduces the degradation of insulin in the beta cells. So you have more insulin available for use by the patient. And this has been proved while we have looked at the reduction of HbA1c. This was a phase 3 trial. It's available for you people to read about it. Hydroxychloroquine was pitted against pioglitazone, and what we actually saw was a reduction of HbA1c, actually, which is almost equivalent to that of pioglitazone. Change from the baseline in hydroxychloroquine was 0.8, and in pioglitazone it was 0.9. This is a phase 3 trial. And we have similar studies from all over the world. And therefore, the DCGI actually approved this particular drug. Now, does it reduce hsCRP? Yes, there has been enough of clinical trials, but I'm just showing you one slide that if you reduce hsCRP by more than 1, it actually means you're reducing HbA1c by 0.8. And we have enough of trials which shows that it reduces hsCRP by 1.5 to 1.7. And it also increases the plasma adiponectin levels. And we know that increase in the plasma adiponectin is actually beneficial to our patients. Well, this is from the Journal of American Heart Association, which clearly showed there was a 72% reduction in the risk of CVD when hydroxychloroquine was used. But this, of course, was in patients with rheumatoid arthritis and not diabetes. So don't expect a CVOT trial to happen with hydroxychloroquine. Okay, where are we today with diabetes? Now, diabetes is turning out to be not just glucocentric, but turning out to be cardiometabolic, renal, and vascular in approach. And we know about it. So things have been changing over a period of time. We are moving beyond the glycemic control. We know that the drugs which actually help diabetes and to reduce the complications are GLP-1 and GLP-2. So they will probably stay as the main drugs to be used in most of our patients. But hydroxychloroquine 400 mg given once at night can be a great add-on if there is no contraindication for use of this drug. So ladies and gentlemen, diabetes and inflammation, we know the components of the immune system are altered in both obesity and type 2 diabetes. As a result, changes occurs in the adipose tissue, the liver, the pancreatic islets, the vasculature, and circulating leukocytes. And these immunological changes include altered levels of specific cytokines and chemokines, changes in the number and activation state of various leukocyte populations, and increased apoptosis and tissue fibrosis. Together, these changes suggest that inflammation participates in the pathogenesis of type 2 diabetes, and preliminary results from clinical trials with salicylates and interleukin-1 antagonists support this notion, but they did not turn out to be what we were looking for. So at this point of time, efficacy and safety data from hydroxychloroquine is extremely promising. Thank you very much. And with that, I will stop sharing my screen. And I'm sorry I'm not there, but if possible, then I'll try to come on live to take the question and session on the day of the conference. Thank you so very much.
Thank you, Dr. Arvind. And as he said, Dr. Arvind would not be able to be here sharing the question and answer. But in fact, the inflammatory process starts from the day one of the dysglycemia. And as the microvascular events start, the macrovascular is always a response to inflammatory process because they invite the adhesion cells, they invite the adhesion molecules, the lipid accumulation, and subsequently disruption, the movement of the sugar moiety to the either hepatocyte or to the adiponectin always is associated with inflammatory changes. So apart from diabetes being a metabolic condition, a dysglycemia, it has also component of the increasing inflammation form. And that's the reason why the at least hydrochloroquine, initially which was chloroquine only, the drug has been used in different disciplines. It has been used in the to improve the fibroblast growth factor, in systemic lupus erythematosus, in dermatology. This has also been used in leprosy, many conditions, and many skin-based conditions, many epidermal conditions they have been used. So it has a potential role to take care of dysglycemia as well, and also, and one of the wonderful observations Dr. Arvind has presented, that 74% decrease in the risk of cardiac risk reduction in patients suffering with rheumatoid arthritis using hydrochloroquine. And they could have, they may have, they may not have insulin resistance or dysglycemia. So that's a wonderful observation which could be extrapolated. So thanks, Dr. Arvind. Can we move for the next slide, next presentation? Dr. Siddhant Trehan. Dr. Trehan did his graduation from Maulana Azad Medical College and did his postdoctorate DM in cardiology from Sri Jayadev Institute of Cardiovascular Research, trained in a sector where have been doing many angioplasties and intervention, has been senior resident in cardiology, GV Pant Hospital, has been intensivist in the Artemis Hospital, Gurgaon, and also worked in cardiology department of GV Pant Hospital, as well as and both as a capacity of senior junior resident. So over to Dr. Siddhant Trehan.
Am I audible?
Yes, you are audible.
1 second, sir. First of all, thank you so much for the introduction. So today, having the last session of the day, I think we'd like
last
to
but not the least, it is a very, very important session.
It's an important topic. So
yeah.
I'd like to keep it very simple, stick to the basics, and try to hit on points which are seen very commonly around us. So today we'll be discussing a case related to heart failure, and then we'll discuss what are the current treatment options for the same. Before we start, I'd just like to discuss about what heart failure really is. It's not every patient who's having breathing difficulty and is a known patient of heart disease. Heart failure, technically, by definition, is a situation where the heart is unable to meet the demands of the body or is able to do so with higher pressures. Heart failure has been classified in stages and along according to the function classification, and there's a lot of confusion between the two. So we have an AHA, or the American Heart Association, staging for heart failure, and then we have the NYHA classification for heart failure, which we all are very well versed with. So the AHA staging tells us that it's ABCD. A is all patients who have only risk factors, but they have not developed any structural or any symptoms of heart failure. In stage B, patients have had structural changes in the heart, but they've never had any signs or symptoms of heart failure. Patients in stage C are the ones who have structural heart disease and have also had symptoms currently or previously. And stage D are patients who are refractory to heart failure despite the best optimal medical therapy. But what we commonly come across is the function classification. This is a subjective classification that we classify people into based on their symptoms, which they tell us. These symptoms are very dynamic. Their classification is dynamic. On treatment, they switch between classification. They may be in stage 4, they may move to stage 2, and vice versa. So today, this case is a very typical gentleman. He's a 74-year-old male. He's a known case of heart failure with reduced ejection fraction. He had an ejection fraction of 25%. His baseline NT-proBNP level is 1190, which is a surrogate marker for your cardiac filling pressures. Patient is also a diabetic who's fairly controlled. His medical history includes him being a diabetic for the last 25 years with some albuminuria. He also had some ischemic event 2 years back for which he underwent successful revascularization. Patient is on glimepiride and metformin for diabetic control. Patient previously has been intolerant to metformin, and he also had genital mycosis, mycotic infections related to SGLT2. So this is a very typical case that we all see in our day-to-day practice. So how we manage this patient? The idea was to start GDMP where ARNI and MRA had to be started initially. So the patient came in with some fatigue and was obviously had a worsening of his function classification. So beta blockers were stopped for the time being, and he was started on ARNIs and mineraloid receptor antagonists. And with these, his symptoms definitely improved. On follow-up, this patient's ARNIs were up-titrated, his MRA was continued, and finally he was reintroduced with carvedilol. SGLT2 in the form of dapagliflozin was started at a smaller dose, and his diuretics were stopped. Now, he had been on follow-up, and over the 6 months, this patient has been doing much better. So he's now on optimal dose of ARNI, and it's important to see when I'm mentioning this as optimal dose of ARNI at 200 milligrams BD. He's also on carvedilol, eplerenone, and dapagliflozin. His NYHA classification has improved from 3 to 1. His ejection fraction has tremendously improved from 25 to 48%. His NT-proBNP levels have decreased to 600. His HbA1c as a diabetic is fairly well controlled, and there's no worsening of his albuminuria or his creatinine levels have not worsened. So this is a classical case that we see, and it's important because this patient happened to be a diabetic, and along with that, he was also having reduced ejection fraction, and he was managed optimally, and he had wonderful results. So what exactly are the challenges in managing these two things together? As we all know, and Arvind sir very nicely mentioned about diabetes being a syndrome which is involving multiple organs of the body. How does it really affect the heart? So directly, it increases the atherosclerotic risk, which leads to ischemic cardiomyopathy. It is also known to cause hypertension, which relates to hypertensive cardiomyopathy. And it directly also affects the heart to cause diabetic cardiomyopathy by causing metabolic disturbances, disturbed cellular functions. There are structural alterations that causes cardiac autonomic neuropathy, and it activates the RAS system. Patients who are diabetics have more than twice the risk for developing heart failure. So the prevalence of heart failure in diabetics happens to continuously increase as their glycemic control decreases. So for each 1% increase in the HbA1c level, the risk of incidence of heart failure increases by 8 to 36% across different geographies. The clinical incidence and mortality of diabetes complicated with heart failure is 4 to 8 times higher than the non-diabetics. So heart failure and diabetes is like a double whammy for the patients. And both of them together happen to have worsening of outcomes of cardiovascular death and of hospitalization. And here we can see as we move from preserved ejection fraction to reduced ejection fraction and from non-diabetic to a diabetic status, our incidents and events keep on increasing. So what are the real challenges that we face? Firstly, diabetes complicated with heart failure is one of the most dangerous diseases in modern medicine. It's extremely difficult to control, and the outcomes, despite the best standards of therapies, are not very good. And there's a huge burden of this disease. And for the longest time, diabetes and heart failure have been managed separately. And there is also not really a very effective treatment for diabetes, which complicates heart failure. The drugs which we have are quite limited. Many of the hypoglycemic agents that we use have potential cardiovascular risk, especially with pioglitazones or the glitazones which lead to salt retention. And the conventional drugs for heart failure treatment are also not very effective in the treatment of diabetes. And a lot of our patients, despite being on optimal medication, seem to not have a very good glycemic control. Therefore, it is necessary to further explore the treatment plan. So now, what do the guidelines really recommend? And as per the AHA guideline of 2022 for heart failure, ARNI has been recommended as the first-line therapy for heart failure patients, especially all patients who do not tolerate an ACE inhibitor or an ARB. Even chronic symptomatic patients on a class 2 or class 3, despite being on ACE or ARBs, replacement to an ARNI is recommended. Even in asymptomatic patients with chronic heart failure, switching to ARNI from an ACE or an ARB is recommended if there's no financial constraint. And ARNI is also recommended as de novo treatment to be started in acute decompensated patients in the hospital before they're discharged. So all in all, ARNI has to be the first line therapy. Any patient we feel has a decent amount of blood pressure, is not having a very poor kidney status, and potassium levels are not so bad, we should definitely consider starting ARNIs. So this was also concurred in the ESC guidelines, which recommended ARNI as a replacement for ACE inhibitor in suitable patients who remain symptomatic despite using ACEs, beta blockers, and MRA therapies. But however, ARNI may be considered as a first-line therapy instead of an ACE inhibitor. And then again, we know ESC guidelines take a while to sort of accept. So where is the evidence for the backing of ARNI? So ARNI in HFrEF, it reduces the events of cardiovascular death and heart failure hospitalization by 20%. And it is irrespective of the glycemic status. This meta-analysis shows that even diabetics do fairly well, but they don't do as well as patients who are normoglycemic or pre-diabetic. One thing related to overall outcomes we see that is patients who are underdiagnosed diabetics with heart failure happen to not do as well as patients who are diabetics and are on diabetic medication. The all-cause mortality is reduced by 16% in comparison to ACE inhibitors. And again, as the diabetic status worsens, the outcomes aren't as good, but still much better than enalapril. ARNIs also improve the ejection fraction, which in this recent trial, PROVE-HF, where it showed that on patients on ARNIs, they have a significant improvement in their ejection fraction, which could be up to 8 to 10% over a span of 12 months. And consider compared to what we used to think earlier, that 3 months is sufficient time for an ARNI to function and sort of improve the ejection fraction. It's now proven that the improvement in ejection fraction can go on up to 12 months. ARNIs also decrease the cardiac volume, help with the cardiac sizes. It helps in reduction in the LV end diastolic volume and the end systolic volume indices. And because of the improvement in ejection fraction and the decrease in the cardiac volumes, there's a significant decrease in the requirement of specialized devices such as ICD or a CRT-D. ARNI also happens to lower the cardiac filling pressures, which are seen in the NT-proBNP levels, which are reduced by 25% further compared to enalapril. The second drug, which helps a lot for heart failure as well as in diabetes, are the SGLT2 inhibitors or the gliflozins. And recently in ESC 2021, it was finally recommended that SGLT2 inhibitors should be one of the first-line therapies when managing heart failure patients with diabetes. And even the AHA guideline in 2022 concurred the same, where heart failure and type 2 diabetes patients, SGLT2 inhibitors should be used. And in fact, the AHA has also gone a step ahead, where it's recommended the use of the SGLT2 inhibitors in patients who are even non-diabetics and who are also having reduced ejection fraction. So the combination of ARNI and SGLT2 inhibitors show better clinical outcomes compared to the conventional therapy in heart failure patients, decreases the rates of cardiovascular death and the rates of hospitalization with heart failure significantly. Any delay or halt in these medications tend to slow clinical progression in these patients as compared to conventional therapy. The evidence for using these two together stems from the recent DAPA heart failure trial and the reduce in the reserve trials. The pooled meta-analysis indicated there was a 32% lower occurrence of cardiovascular death and hospitalization from heart failure. And I cannot emphasize this enough, like I mentioned previously also, that it's very important to get these patients on an optimum dose. And it's also recommended in our guidelines. And the patients with heart failure with reduced ejection fraction, it's very important to titrate our medical therapy to achieve targets which have been shown to be efficacious in all the randomized controlled trials to reduce the cardiovascular mortality and heart failure hospitalizations unless not well tolerated. The titration and optimization of these medicines should be frequent, as less as 3 to 7 days or maybe up to 2 weeks. And during this time, we should also look at the improvement in patient's symptoms, his vital signs, especially the blood pressure and the heart rate. And we should also look at laboratory lab findings such as the creatinine and potassium levels. Even if the symptoms of a patient have improved and our markers have gotten much better, these medications should still be up titrated to the trial-defined target doses. that if the target dose cannot be achieved, only in that situation should we control the patient at their highest tolerated dose. And even in the ESC, it also concurs the same, that medication should be up titrated to the doses used in the clinical trials. So with this simple discussion, we see that controlling heart failure well with the guideline-directed medical therapy, which has 4 pillars today, based on ARNIs, which are the newest ones, and then MREs, and then the SGLT2 inhibitors and the beta blockers. The outcomes have gotten far, far better. They've reduced the risk of cardiovascular death and mortality. They've improved glycemic levels. They've delayed the clinical progression of the disease, and they also promote reverse cardiac remodeling. And before I conclude, I just would like to add a very simple thing that, I mean, in the 90s, when all these beautiful medicines were not there, the mortality for patients with heart failure with reduced ejection fraction is extremely high. To the extent that we used to say that any patient who has an ejection fraction below 40% would have a median survival of only 50%. So a median survival of 50% at 18 months is quite bad. And in 2020, once these medications started coming into the picture, it's now said that, or it's amongst the, among the data now proves that patients who receive the best guideline-directed medical therapy, along with any important device therapy or any revascularization that the patient needs, that our outcomes are as good now that a patient who has reduced ejection fraction has a 10-year survival of 80%. So from having a median survival of 50% at 18 months to coming up to 10 years with an 80% survival is, I think, it speaks for itself. Thank you so much.
Thanks, Dr. Trehan. Is there any question in the chat box? Otherwise, I have one small query, Trehan. Initially, when this molecule came, there was instructions and there were the recommendation that if patient is already taking ARB-AC before,
yes, sir,
you better stop it and then start sacubitril valsartan combination.
So actually, what they have proven is that if a patient is on an ACE inhibitor, it is advised to start this molecule after 36 hours. And if the patient is taking an ARB, then it should be started with the next dose of the ARB is planned. Because if you don't do that, the risk of developing angioedema and allergic responses and anaphylaxis is a little higher.
Yes, because 2 studies done in this country. One was the LARD1, one was the LARD2. When we come, and even on target trial, if you combine the 2, even patient could be in problem first to second dose. Patient is already taking ACE inhibitor, then you add ARBs.
Yes, sir.
There is drastic reduction, and there could be incidence of acute kidney injury in some of these patients.
Yes, sir.
So that is one point of the consideration, and should be also
so for
answered.
that, what we see is that if the creatinine levels have not increased by 30%, then it's relatively a safe.
Exactly. What level cardiologist, as a cardiologist, what level you would consider of serum creatinine values before you prescribe? Do you look at the serum creatinine value or you don't look at it?
So I actually, where I trained, there was a huge myth that anybody having a creatinine more than 1.5, nobody started an ARNI or an ACE for that matter. But in my personal practice and from what I've learned from my seniors, creatinine up till 3 also I'm very comfortable. Unless there's a gross worsening in the urine output or significant hyperkalemia or there's a significant bump in the creatinine levels post starting with an ARNI or an ACE for that matter.
What is your recommendation for patients of grade 2 diastolic dysfunction? Often we get in the report, these patients are dyspneic. Even on the diuretic, they do not respond. Their hemoglobin is all right. They do not have any lung, their lung compliance is better, but they feel dyspneic with the normal coronary arteries.
Yes, sir. So actually, heart failure with preserved ejection fraction is, I think, a much, much bigger disease than diabetes or heart failure with reduced ejection fraction, because the incidence of that is extremely high. We just had Arvind sir in his presentation mentioned that hypertension has a prevalence of around 35% currently. So add that to the aging population, the prevalence of heart failure with preserved ejection fraction is extremely high. So in these patients, it becomes very essential to manage the volume status, the renal status, and the afterload very I mean, it has to be a good sort of an amalgamation of all the three that needs to be taken care of. And when it comes down to using an ARNI, we know that it's a non-inferior drug. The best results of ARNI continuously happen as the heart as the ejection fraction keeps falling further and further. So I mean, in my practice, or from what I have learned in my experience, that's what I would like to add.
And you want to continue as long as patient visits to you, or is there any level at which you would like to discontinue or stop the medicine?
So I would like to go up to 200 mg BD, but unfortunately, in all the trials which were conducted, they were done in a Western population, which are slightly bigger in size compared to our Indian habitus, and the general blood pressure levels in them are a little higher than what they are in our country. So I would prefer being up to 200 mg twice a day, but unfortunately, I think it's very few patients that we actually can reach that level. Maybe 5% or 10%.
That's what we have also experienced, that patient with even 100 milligram BDU continue get sufficient result, and these patients. But the only question remains, how long? As long as this was costly medicine, then people do ask how long to continue. Like Digitalis, do you continue all their life?
No, sir. I personally don't use Digitalis unless patient has repeated hospitalizations. And as per that big trial and the Radiate trial, the only role was to decrease hospitalization with Digitalis. What I personally use in patients with heart failure with reduced ejection fraction who tend to not tolerate the medication because of lower blood pressure. So after my patients have been started on an ARNI or guideline directed medical therapy, we see that their function status improves. They will move from a class 3 to a class 2, or maybe a class 2 minus, somewhere between a class 1 and a class 2. At this point, these patients are very well dry, relatively dry. So in such patients, I like to add a little bit of fluid intake so that, that helps in holding or maintaining the blood pressure, and that helps me to continue my ARNI rather than withdrawing it.
Would you like to continue Digitalis if the patient has been on Digitalis before? Would you like to continue, or will you stop it?
So if the patient is on Digitalis, I would not like to withdraw the drug unless that the patient is having a hypertension.
I think that's very true. That's very true. And the second advantage we have with the SGLT2 inhibitor, that it acts on sodium hydrogen exchange molecule, which is a good molecule, and work on the cardiac myocyte to prevent any abnormal site for initiate the arrhythmias or atrial fibrillation. So this is a good molecule.
Actually, fibrosis, both these drugs are decreasing
and prevent fibrosis as well.
Yes, sir. So that improves.
Thank you, Trehan. Thank you. Thank you. Yes, Raju, can we take a leave?
Yeah. Thanks a lot, sir, for moderating the session so wonderfully. And I'm happy to share that Dr. Siddhant did a wonderful presentation, and I'm a proud father-in-law of Dr. Siddhant Trehan. He's a very, very learned, very, as someone was saying, it is not only science, but art also. He's a wonderful interventional cardiologist in this part of the world. He does complex angioplasties and very, very difficult angioplasties, which are mostly refused by most of the cardiologists. So that way, I'm a proud father, and I thought I must introduce to you. So with that,
thank you to both the Chawla and Dr. Trehan for making the session so wonderful. Can we say now good night?
Good night, sir. Thank you. With that, we close this second day. And I think it has been a wonderful, since 1:30. It has been a very, very long session. And tomorrow we are going to have our physical conference starting at 9 a.m. in the morning at Hyatt Regency. So all those delegates, those who have logged in from NCR, Delhi, we invite them to be part of this physical conference. Even if they have not earlier sort of registered, they can have a spot complimentary registration also. So with that final words, we express our gratitude to all the delegates, those who have stayed back till so late, and to all the experts, faculties, those who have done more than justice to their sessions and have been part of this wonderful scientific feast. Thanks a lot. Thanks, Professor Tripathi. Thanks,